the inauguration of the scientific program. Then we will have formal inauguration in the evening. Pramod sir.
A very good afternoon to all of you. Thank you, Shamshad. And without much ado, I would request the first speaker, Dr. Jabir Abdullah Kutti, to come to this stage, and we'll also request the discussants to come to this stage. Dr. Arvind, Dr. Vipin, Dr. BP Singh, and Dr. Adil Akhtar Khan, and myself. I'm also the moderator. So I hope you have loaded your slides. Okay. So just a few lines about the drug-eluting balloon or drug-coated balloon. The European Society now says that you should call it drug-eluting balloon rather than drug-coated balloon. So it's a work in progress. Dr. Abdullah Kutti is one of the senior interventional cardiologists from Kochi, working at Lizzie Hospital, has very wide experience of interventions in complex, and has also a keen interest in drug-coated balloons used in complex interventions. So I now request him to start his talk. And during the talk, if anyone has any question, if you want to make a comment or a question, I'm sure you will have a mic, and Dr. Jabir will be very happy to answer your questions.
Meanwhile, I will also request Dr. Devdutt sir, because he is also having a vast experience in DCB, to come as a discussant for this session also. And I also request Sandeep sir, who is present over here, to come on the dais.
Good afternoon. And it's a great pleasure being here in this city of Patna with great historic relevance in the history of India. Especially, I am staying in the Hotel Maurya, which reminds us of the great Maurya dynasty, which ruled over this part of India for quite a long time and contributed much to the cultural heritage of India. And at the outset, let me thank the Cardiological Society of India Bihar chapter for giving me this great opportunity to be here. And in fact, I'm here in Bihar, visiting the Bihar for the first time. So I'll be discussing about how I utilize DCB in long diffuse coronary lesions, which seems to be one of the most important indications of drug-coated balloon. Drug-coated balloon alone, or a hybrid strategy in diffuse lesions. Why? Because the length of the lesion, coronary lesion, and the breadth or the diameter of the coronaries, these are proportionate to the stent failure. So there is an exponentially increased target vessel failure, which directly correlates with the total implanted stent length and the metallic burden. Not only that, when you put in a long stent or multiple long stents, it cages the vessel, and the conformation or the conformability will be lost in the long tapering and tortuous vessel anatomy. So the vasomotion is lost, the chance of stent restenosis increases, the chance of stent thrombosis increases, and the chance of stent failure and target lesion or target vessel failure is much high when you use long stents in diffuse disease. So if you use a DCB, it could reduce the stent number by around 65%, and it could reduce the total stent length also by somewhat around 64%. So this is a very exciting concept. Only thing is we need the proof of the concept with a long-term data in terms of safety and efficacy. I'll show a few cases. This is a triple vessel disease. Distal vessel size is small, it is diffusely diseased. You can see the LAD proximal, there is a lesion, the LAD distal, there is a lesion, and the distal LAD seems to be around 2.5 millimeter. The OM, there is a pretty long lesion, and the distal circumflex, which is a small vessel, has a lesion. So we thought a hybrid technique to do the LAD by putting a drug-coated balloon to the distal LAD. So applied a drug-coated balloon to the distal LAD and a drug-eluting stent to the proximal LAD. This is the hybrid technique. And a drug-eluting stent to the OM and the distal circumflex, again, drug-coated balloon. Dr. Pramod was telling that now we have to call it as drug-eluting balloon. Initially, we called it as drug-eluting balloon, then changed over to drug-coated balloon. I'm little used to this drug-coated balloon terminology. And you see the posterior, the posterior descending artery, which is also small caliber, long distance, long lesion, and the proximal RCA has also a lesion. But proximal RCA is a big vessel.
Just 1 minute, I'll ask them to get the lights down, please. You can't see the screen. It's too bright. Can you get the lights down? No. These lights down.
There is a light which is focusing onto the screen. If that is put, right.
We don't need that light. Please take that light away, then we can see the screen better. Okay, yeah.
All right, so it's a 2.5 30 millimeter drug-coated balloon to the posterior descending artery, and a big stent that is 3.5 into 38 millimeter drug-eluting stent to the proximal RCA. You can see we could do a full revascularization, and after the drug-coated balloon application, you can see the PDA, which is a very long vessel, important vessel, and it's supplying the large area of the myocardium. So it's a full revascularization, a hybrid strategy, distal LAD, drug-coated balloon, proximal LAD, drug-eluting stent, a drug-eluting stent and a drug-coated balloon in the circumflex, a drug-eluting balloon and a drug-eluting and a drug-eluting stent in the proximal RCA. This is a patient who underwent a primary angioplasty to the proximal RCA. At that time, the PDA was diffusely diseased. There was a lesion in the PLB. So we thought we'll put the patient on medications and take up the patient after some time, maybe after it. And he was taken up for a interval angioplasty 3 days after the primary procedure. So it was a stage procedure. We prepared the posterior descending artery lesion with a cutting balloon, and followed by cutting balloon. You can see the posterior descending artery is well prepared. The size is good. There is no significant recoil, and there is some amount of dissection, which is a part and parcel of the drug-coated balloon therapy. So a drug-coated balloon was applied to the PDA, and you can see the drug-coated balloon. Normally, we use the drug-coated balloon for a single inflation. This is a protege balloon we use for multiple inflations. So there was 2 inflations with the drug-coated balloon. Sorry, there are 3 inflations with the drug-coated balloon. It was a 20 millimeter protege, and this is the DCB application, 3 successive dilatations. And we thought of putting a drug-coated balloon to the PLB also, but after the preparation, there is a significant recoil. You can see the recoil. When there is a significant recoil, drug-coated balloon is out. So this recoil, even with a cutting balloon, then after with a non-compliant balloon of the 1:1 size of the vessel, there was no benefit. The recoil persisted, and then we went ahead with a drug-eluting stent to the PLB, and you can see the final result. A drug-coated balloon, it was a protege because this lesion was long, and that's one limitation when we use drug-coated balloon in a diffuse disease. The maximum length available is 40 millimeter, that is sirolimus eluting stent balloon, and most of the paclitaxel coated balloon are 30 millimeter, except for the protege, which there's a certain particular mechanisms that we can have 3 dilatations. They have 20 and 30. So there is some amount of dissection in the posterior descending artery, which can be safely left alone. Another patient who is a 75-year-old male, he had RCA angioplasty done in 2010. Now he came with a Furtangina class 3. There is diffuse ISR in the proximal RCA and a long lesion extending up to the precrux from the PDA to the precrux and some amount of disease in the PLB also. We thought first we'll do a drug-coated balloon to the PDA, but there was difficulty in tracking the cutting balloon, but somehow we could send the cutting balloon inside, but that gives an idea that the drug-coated balloon is unlikely to take that acute ankle and somewhat calcific ISR. So we put the cutting balloon, prepared the lesion, and use a guide extension catheter to track or to take the DCB to the target lesion. So here also we used a 30 millimeter protege, 2 dilatations. And this is the final result. And the proximal part, we prepared it with IVL. The calcium was broken with IVL, and DES was applied to the proximal RCA. You can see some dissections in the posterior descending, and there is a proximal lesion at the precrux which was there initially itself before the angioplasty. And there is no dye staining, or the dye is not hanging up, and there is no flow limiting dissection. So these dissections can be left. So acute tissue levels for this protege, for the first inflation and the second inflation and the third inflation. Even at the third inflation, there is some amount of therapeutic paclitaxel that can be taken up by the vessel to prevent restenosis. A 48 years old male diabetic PCI to the LAD and diagonal one with a biovascular scaffold in 2012. Now you can see the biovascular scaffold markers. He came with restenosis of the BVS and a lesion in the diagonal. The diagonal lesion, we used the cutting balloon and a long 40 millimeter drug-coated balloon. This is the sirolimus eluting balloon, was put up front. This is the upfront hybrid therapy where in a bifurcation lesion, we apply the drug-coated balloon first to the side branch, and then the main branch will be stented. So 2 drug-eluting stent to the main branch. So, and there is another bifurcation lesion here, the LPDA, OM, and the OM1. So the LPDA and the distal OM was prepared with the cutting balloon, and this after the preparation, the vessel is well prepared. Drug-coated balloon, this is a sequential drug-coated balloon application to the bifurcation. One in the OM, followed by another in the LPDA. And the OM1 also, a cutting balloon was used for preparation, followed by a non-compliant balloon and drug-coated balloon. So we used 4 drug-coated balloons in this patient, 1 for diagonal, a 40 millimeter, 1 for the bifurcation, LPDA and the OM, and for the OM1. This cutting balloon was taking the curve into the LPDA, so we used a scoring balloon into the LPDA. And the OM1 was also tackled. Now you can see the acute result is good. There was no recoil. We usually wait for 5 to 10 minutes. There was no recoil, and the patient was discharged. So the entire areas was revascular. It's a long OM1. It's a large. It is supplying a significant area. The OM1 is significantly appropriately revascularized. The OM1, another major OM as well as the LPDA. So this is the pre-DCB and the post-DCB pictures. You can see it seems to be a good result at the bifurcation. A high lateral wall STEMI, we did a plain old angioplasty, a balloon angioplasty to the diagonal and a stent to the LAD. So the diagonal appears diffusely diseased, but maybe due to a significant amount of spasm. So we thought we'll take up the patient after anticoagulation for 3 days, and took up the patient, use a cutting balloon to prepare, then put a drug-coated balloon, a 40 millimeter drug-coated balloon, and you can see the result. It's a pretty big diagonal with a TIMI 3 flow and no significant residual lesion. So it's our planning. In drug-coated balloon, the philosophy in the use of drug-coated balloon is totally different from that of the drug-eluting stent. So the key determinant of a successful DCB PCI is a vessel preparation, aggressive vessel preparation. It is escalation of the balloons, smaller balloon, bigger balloon, and then balloon of 1:1 size. Use of a cutting balloon, most of the time we use either a cutting balloon or a scoring balloon. This gives a controlled dissection, and it prevents the dissection from extending into the main vessel if it is a branch vessel or an ostial disease. So progressive inflation, balloon escalation, and prolonged inflations may be required, and use every necessary tool. It could be a scoring balloon, it could be a cutting balloon, it could be a calcium modification tool. And at the end of the vessel preparation, the vessel should be of a size. The vessel should have a residual lesion of less than 30%, and then we can apply that, and there should not be any flow limiting dissection. And the dissection classification has also changed now, and the vessel sizing is extremely important. If finance permits, it's always better to size the vessel, because we have to use a 1:1 or at least 0.8:1 size truck-coated balloon, and also we have to size the cutting balloon or the scoring balloon which we have to use. We always use a scoring or a cutting balloon which is 0.25 to 0.5 millimeter less than the vessel size measured. So procedural optimization is key. Use of a cutting or a scoring balloon. They are designed to relieve the vessel hoop stress by creating controlled small incisions in the vessel wall, and they do not move, especially in the ostial position due to the stabilizing effect of the blades creating controlled dissection. What you need is a controlled dissection. It's beyond our control to have a controlled dissection, but this is the only method. So this is not a random, uncontrolled dissection. What we are going for is a controlled and a focused dissection. So these are the cutting balloon-induced cuts or microchannels in the OCT. So Wolverine, we use Wolverine or Aperta. These are the two common things that we use. So the type 1 dissection now, previously we were using the type 5 up to type 5 dissections, but for a drug-coated, after the entry of the drug-coated balloon and the widespread use of drug-coated balloon, now it is type 1 and 2. Type 1 is intimal tear, there is TIMI3 distal flow, no luminal compromise, and the contrast clears. That is the most important catch. It's a type 2 dissection, we have to go for a stent. It's a reduced TIMI flow, spiral dissection, the contrast is hanging up, it's not clearing, and there is a progressive luminal encroachment. So for what are the indications for stenting when you see a dissection after a drug-coated balloon? Persistent contrast hang-up, progressive luminal encroachment, and more than 30% encroachment and a reduced TIMI flow. Unless and until these findings are there is no need to worry about. Just seeing a dissection is not enough to go for a bailout stenting. So the green light for DCB, less than 30% residual stenosis, TIMI3 flow, no flow limiting dissections, proceed to court. Otherwise, we may have to go for a drug-eluting stent. So how do I do DCB in diffuse and small vessels? Size it with intracoronary imaging whenever possible. Prepare with gradually escalating size balloons, cutting balloon or a scoring balloon, and may undersize by 0.25 to 0.5 millimeter, and NC balloon of 1:1 size. A DCB of 1:1 vessel size, inflation time of 1 minute, nominal pressure, 2 balloons, and protege for long lesions. Anticipate tracking issues and use a cutting balloon. So use a guide extension catheter. I'll stop soon. So we have looked at the data of our institution. You can see from 2022 onwards, there is a rapid jump in the use of drug-coated balloon, and there is along with that parallelly there is a jump in the use of a cutting balloon and the scoring balloons. And our bailout for so far 460 successful drug-coated balloon usage in the institution over last 4 years, and the bailout stenting was required only for 5. So DCB in a small and the diffuse disease, it's an evolving science and philosophy. Each drug-coated balloon is different, we cannot compare it, and the preparation is the key to success. Small vessel and diffuse disease is the ideal substrate for drug-coated balloon. The art and science of DCB is totally different from that of the DES. Thank you.
Excellent talk. As Dr. Jamir mentioned, it's a work in progress. Unfortunately, in spite of all the work going on all over the world, the guidelines have not yet recommended it as class 1 indication, not even in ISR, which was supposed to be the niche. But it's a work in progress, and it is more of an art than science, which he has shown to you. Like a goldsmith, you have to be lot of perseverance, persistence to prepare the lesion well, and then do an IVUS if it is possible, see what have you achieved, and then wait, and then go for it. If you have any question, Dr. Devrat, any comments?
I think he showed everything that we do. And preparing the vessel wall is paramount. So if you do not have lumen gain, the drug-coated balloon doesn't work. You have to have lumen gain. And as he pointed out that the residual stenosis should be less than 30%. Now, the other point that he emphasized on was gradual dilatation. So do not rush to dilate. You might, so you are taking a cutting balloon, but the cutting balloon will not always go. So you have to prepare a little bit of passage for the cutting balloon, and then take the cutting balloon and be very careful about dilating it. Do not go to very high pressures initially. And as he said, very, very important is to undersize your cutting balloon a little bit, because you do not want to tear the vessel. If you go with a 1:1 cutting balloon, then there will be a bad dissection, usually. Also, we are working on smaller type of vessels, diffuse disease, like he showed wonderfully in his PDA. It is a little easier if you have a slightly larger, with a larger vessel like a 2.5 plus, with a lesser length of stenosis. If you have a long length of stenosis, if it is on a bend, then it becomes much more challenging. And that is what he showed in his PDA cases. He took the balloon, he dilated it. There were 2 PDA cases that you showed, and the second one was very, very good. In the first one, I thought there was a little bit of residual stenosis, and that sometimes happens. You cannot always be perfect with these cases. You have to accept a little bit of imperfection, that like what we are used to see. In stent, we are used to see perfect. But here it doesn't matter. If you have produced a little bit of dissection, the vessel will positively remodel. And you will see later that the vessel lumen size is actually important. At the same time, it is also important not to have residual plaque. Sorry, I am going on and on.
So, a quick comment from Dr. Vipin, Dr. Arvind, Dr. Sandeep, then we will finish this session.
Yeah, I just want to ask, sir, that in smaller vessels, like 2 or 2.25 mm vessel, long lesion. So in those cases, when we do, and in those cases, bailout stenting may not be possible. So in case dissection happens or flow limitation happens, so in that case, how to?
Sometimes we may have to leave. Sometimes we may have to leave it for medical therapy. For example, whoever is using drug-coated balloon, because all interventionalists in the current era has 2 eyes. One is the DES eye, other is the drug-coated balloon eye. So you should not look at the drug-coated balloon result with the DES eye. DES eye means perfect. The vessel is flowing well, no dissection, no dye hanging, nothing. If you are asking me, in a 2 millimeter vessel, I'm trying to open up the vessel, trying to revascularize, but sometimes I may fail with a drug-coated balloon. As you rightly pointed out, a 2 millimeter vessel is extremely likely to dissect, extremely likely to lose the flow with a dissection. Then you cannot go ahead with a stent, especially if it is a long lesion. At that point of time, I think we may have to stop the procedure and go for a medical therapy if there is no life-threatening issue. If there is a life-threatening issue, we have a 2 millimeter stent available with the Medtronic, but I seldom use it.
Yeah, and sometimes a 2 millimeter is actually not 2. You will see that it will grow. Yeah. So you have to be a little patient about it and be very careful about pre-dilating it. So if you really think it is a small vessel, do not dilate it aggressively. Dilate it gently, give nitro, and see whether it grows. If you have intravascular imaging, it is easier.
Sir, and it's a millimeter by millimeter dilatation with the cutting balloon. Cutting balloon, you go up to 2 millimeter weight, 4 millimeter weight, go up to 6 millimeter weight for another 20 seconds, and then inflate. 6 atmospheres, and then increase. There are people who go for aggressive dilatation with the cutting balloon or scoring balloon, undersizing it. Or there are other school of thought is 1:1 size and at a low pressure. So that depends upon if there is calcium, we may require a little higher pressure. So always undersize.
So in situation long segment lesions diffuse, can we put 2 stents, proximal and distal end, in between drug coating balloon?
Yes.
What is the concept of spot stenting? Spot stenting followed by drug coating balloon.
There are 2 methods. One, the shortest part, or the area where it is long diffuse disease and small diameter, we use a drug-coated balloon. Drug-coated balloon is 40 millimeter, and this proteage can be dilated 3 times. We don't know the long-term result. That is a problem. Though the manufacturer is claiming that even with the third dilatation, it releases adequate amount of drug, which is sufficient to prevent a restenosis. We are not sure about the long-term result. Otherwise, the maximum length right now available is 40 millimeter for sirolimus, 40 millimeter for the paclitaxel is coming up. You put one, then with an overlap, you can put another drug-eluting stent. There should be at least 2 to 3 millimeter overlap area between the, just like how we do 2 drug-eluting stents. Then you can use 2 drug-coated balloons also, but then it is pretty expensive.
Yeah. Twice the cost of. So, you know, actually in those long diffuse lesions, if you have prepared it, so you see where your lumen gain is best. That area you can put the drug-coated balloon, and the others where the lumen gain is not good, you can put the stent. That is the hybrid which he has shown to you. So you have to make sure that your lumen gain is what you are expecting, what you are predicting. If it is there, you have got it, you can deb it. You don't need to stent that area. That's what we do.
And there
so
is some amount of positive remodeling can also occur with the paclitaxel coated balloon.
Yeah, that's a very important part of the drug coated balloon angioplasty. This is like a bare metal stent where you do get a positive remodel. So yeah, Dr. B.P. Singh.
Yeah, Javed, you found good cases. Any role in acute coronary syndrome? Any experience?
We do it in acute coronary syndrome, not for major big vessels like proximal LAD. We have done a few cases of proximal LAD, but still we are afraid, and the data is not much favoring. I have seen Antonio Colombo has published a paper with proximal LAD cases, but some of them are in acute coronary syndrome. Right now we are doing it in acute coronary syndrome, especially ostial OM disease, ostial diagonal disease.
Or branches.
Branches.
Thank you. Thank you.
So we thank Dr. Jabir, and then we call this session off, and the next session we have moderator Dr. Krishna Kumar.
Thank you so much, sir. Just a small announcement, the felicitation will be taking place in the side panel.
So after the session, I will request all the discussants, moderators, and the speakers that felicitation we will be performing after the end of every session on the side part of the hall. And now we will move on to our next session.
Thank you, Dr. Alam. For the next session on the pediatric intervention, may I request our moderator, Dr. Krishna Kumar, to kindly come on dais. For the discussants on the session are Dr. B.B. Bharti. May I request you, sir, to kindly come on dais. Dr. Nigam Prakash Narayan, Dr. Supreet Ballur, Dr. Smita Singh, and Dr. B.K. Singh.
Please, आप announce कर लो.
Sorry, sir. No, not at all, sir. Okay. May I request the honorary presence of Dr. Ajit Pradhan if in the house?
He's not come, I think, yet.
Okay.
He's on his way.
And Dr. Pooja, may I request your presence on the dais? Thank you, ma'am. Sir.
It's my honor to introduce Dr. Krishna Kumar, sir. He's my guru, and whatever good things I'm doing is because of his teaching. He has got a par excellent academic records, you all know. He has been taught by the best of the teachers in India and abroad. But his contribution to the Pediatric Cardiac Society in India is basically to train thousands of students who are performing all kind of procedures all across India and abroad. Whatever we are doing with our patients good, it's because of his teachings, and his legacy is living long. I introduced Dr. Krishna Kumar for this lecture. Who else can be better than delivering this lecture for acquiring excellence in structural disease interventions? Dr. Krishna Kumar, sir. Thank you.
Thank you, Ashish. You can continue to moderate. It makes it very convenient for me. Bad job. Yeah. Thank you. Thank you, Ashish. thank you for the opportunity to come to Patna. I don't see Ajit, my good friend, whom I've had an association for over nearly 2 decades. And of course, it's been truly wonderful to catch up with Dr. Chatterjee, with whom I trained in All India Institute. We were colleagues. And just to see him back after so many years has been wonderful. So thank you again for this opportunity. What I say will matter to adult cardiologists also. So it's not just on structural interventions. I think you'll find there are common threads that even you can relate to. So I'm going to talk about the story of, because I have grown with interventions. I was associated with the first balloon mitral valvotomy, amongst the first angioplasties in the country with Dr. Kaul, the balloon mitral valvotomy with Dr. Srivastav. So I just have seen the whole field grow in front of me. How does it move forward? I can move it with this? Down arrow. Acha, theek hai. Nahi ja raha hai. Aage. Kar lijiye. नहीं, this one. ये भी नहीं कर रहा है. अच्छा ठीक है. अच्छा ठीक है, आगे. So the question, I think we must always ask this question: why do we do it? What motivates us? What's the reason why we intervene? It's not so simple. It's not always what you think. So, madam, I'm not able to move forward. Can we? I use the mouse. Is there a mouse that works?
Like this one.
अच्छा, अब काम कर रहा है. ठीक है. Thank you. This was off. So, this woman, her name is Stella Van Praag. She is the wife of Dr. Richard Van Praag, who is the famous cardiac pathologist. And the reason I remember her is that we were looking at a specimen of a dead child in the pathology lab, whose aorta had been torn by an aggressive interventionist. And she asked this question. And this coarctation should have been operated upon. But somebody was very aggressive, and they decided to tear that vessel, and she was looking at a dead child and the heart, which was done on autopsy. And she asked this question. She was in pain. Are we doing this for ourselves or for the patient? It's a very deep question, if you think of it. Why do we intervene? Is it for our egos, our feeling of satisfaction, our sense of accomplishment, or the patient's real requirement? So we often, it's a drive. It's become a thing that we have to do something. And it takes precedence over a patient, what patient needs, and this has become a real issue, and particularly in pediatric cardiac care, and I feel strongly about it, so I'll start by talking about it. Like small VSDs, and I'm very particular that we shouldn't be closing small defects, just because that defect exists, because we have now data on 1,000 VSDs that I've followed in my institution, where they're doing really well despite not doing anything. Borderline coarctation, small ASDs, silent PDS. There are lots of examples, and of course in your own coronary world, you must be knowing about many more examples that I'm not qualified to talk about. So what's our motivation? So obviously there is commercial motivation, but I think it's not just commercial. It's also this elusive sense of power of having changed something in a patient, and perhaps you think dramatically. So the other question is, who should be doing congenital heart interventions? Should it be pediatric cardiologists? Can we claim complete ownership to this field, or should it be adult cardiologists who are seriously interested in structural heart? Or both, with some kind of an arrangement. The only thing that I object about, and you see the picture at the bottom, I call it cherry picking. What I object about is adult cardiologists saying, I'll only do the ASDs because they are nice and easy to do, but everything else, let somebody else look after. Now that's bothersome. If a patient comes with Eisenmenger at 50 years of age, that's not my problem. You can send them off, but if the patient has an ASD that I can close, I'd like to close it. Now that is also something that we need to think about. So who should not be doing interventions? That's a more important question. Congenital heart interventions, I think it's very important that you have to do it when you have an essential perspective on the disease as such, not just the technique of it. Okay, I know how to close the ASD, but I don't understand ASDs. I don't know anything else about it, but I can close the defect. That's not a good idea, because then you do not do justice to the patient. So question is, you must have a perspective on natural history before you know whether a lesion should be closed or not, and what the patient needs versus what we are capable of doing. Just because we can, we shouldn't actually do it. And then, most importantly, where you do it. Where, in which institution can you close ASDs? Now, it's very important. You can only close it when you have a surgical backup. If you do a congenital heart intervention in a place without surgical backup, you will land into serious trouble one day, no matter how good, how thorough you, how perfect you are, because you have to do only enough numbers to get into trouble. I had my, after 5,000 ASDs that I have implanted, I've had an ASD embolization happen 4 weeks ago. Not embolization, but displacement, and I had to retrieve and put back the device. So everybody can, it can happen, and when it happens, you really pray that you had surgical backup. So at least you need a decent surgeon backing you up, and in our case, we discuss our procedures with the surgeons up front. Whenever we anticipate problems, we let them know. We have an operation theater kept awaiting. It's also important to have intensive care. You try to do interventions on sick babies without intensive care, you'll burn yourself. So it's important to recognize that you do it, but with responsibility. So how does one train to become a good interventionist? And I've been trying to do this for the last 30 years. I've been trying to train people. And I've sort of understood what it takes, but I'm not sure if everybody has imbibed those lessons the way I intended it to. So I'm going to ask this question: who's a good interventionist? You can ask this question to even adult cardiologists. Someone who's safe. I think that's first, safety first. You can't do damage in the cath lab. Of course, you should be skilled. You should be versatile. You should be capable of handling a different, like what Dr. Jabir just showed, a whole range of really challenging coronary lesions. He's able to do it. You should innovate. That's like quite sexy, and you know, it attracts a lot of attention. You can come to meetings such as this and show your results. And you should be willing to take some courage and do difficult lesions, which nobody else wants to do. But today's times, there are challenges in pediatric cardiac care. I'm not talking about adult, but in pediatric cardiac care, what has happened is diagnostic caths and angios have disappeared. I think Dr. Chatterjee and I trained in an era when we used to do a diagnostic cath on everybody. Today's pediatric cardiologist has no access to that. So they don't intuitively understand angiographic anatomy. They don't intuitively understand hemodynamics. Other big problem today is our care is fragmented. So-and-so will do so-and-so in his little hospital or nursing home. That's it. You don't have supportive services. Somebody with an airway problem, a Down syndrome child requires a PDA closure. That child needs a lot more attention. But you're a part of a fragmented system, so you can't actually do justice to the child. There aren't enough numbers for everybody. There's a lot of competition. Everybody is doing. Not enough numbers to acquire practice and excellence. And worst problem is everybody only wants to do interventions. Outside of interventions, we as cardiologists have no identity. We are nobody. Now that's a serious problem. We have to respect the fact that cardiology is much more than just doing interventions. It's a real issue. And why is it so? Because of the glamour, we've somehow made it very glamorous. Of course, it's lucrative also. And our medicine has become procedure-centered. It's not patient-centered anymore. We just look at procedures and outcomes. We don't look at patients and what they do and what happens to them so much. There's also an instant gratification. You just see some good result and you can feel excited about it. Also, sense of independence. You don't need anybody. You don't need the surgeon anymore. You can do it all yourself. You don't need anybody else. And you think, you also have this equivalent of doing something quick and fancy in the cath lab, and that's being very smart. So all this adds to this very, intoxicating blend of attributes that you make a very good interventionist. but not everybody can become a good interventionist. So this is a great book, which I would recommend everybody should read. It's by a Nobel Prize winner in economics. I spent a lot of time reading this book and then imbibing some of the concepts and trying to relate to it. It's a book called Thinking Fast and Slow. There are two ways our brain thinks. The quick thinking brain actually works on heuristics, on thumb rules, simple. We work and it's all instinctive, whereas others think slowly. Now the catheterizers, traditionally we think need to have that quick thinking. And in fact, you don't do the second bit. As a result, you can do a lot of judgment errors, but you don't really think too deeply or too much into the future. You don't think of the minute steps involved. You just want to get the job done. And most of us have become instinctive. But there is a balance to it. Not everybody can just think quickly and become a good interventionist. You need to have judgment. So essentially, to be a good interventionist, you need a balance of opposite attributes. I'll come to that a little bit. You'll understand what I'm saying. You need to be courageous. You need to do difficult procedures that nobody else wants to do, but you can't kill patients. So you need to have caution as well. Balance the two. Which patient you need to be courageous? Where should you be cautious? And if you have the right balance, you become a good interventionist. You know when to not cross the line. So you can also, the fact that you're willing to deal with uncertainties. So that's courage. But at the same time, you should also be willing to know a certain amount of, you should have some amount of planning. So this is the balance. Now the fellow who's really cautious will want to anticipate every single possibility in the cath lab and you will not be able to do the intervention. You want to think through every possible complication, you can't touch the patient. But if you're too gutsy and you don't think through the possibilities, you can actually do damage. I'm going to give you some examples, but this is a statement that is very famous. Nothing will be attempted if you want to overcome all possible objections. So here are two examples. I'm going back to the specimen Dr. Stella Van Praag showed me of coarctation. This is an infant with coarctation. I don't know if I can get you the pointer to point towards the coarct segment, but I'll use my mouse or something like that. Pointers here, very good. So if you look at it, this is the coarct segment. That's the duct. This is the coarct segment. Now, this is not going to yield no matter what you do. But if you try and open up this vessel, you can do serious damage. Another example, perimembranous VSD. Now Ashish is going to speak about it. But when we sat in Dr. Van Praag's lab and looked at this specimen, we really didn't want to put devices out there because we were worried as to what the disc will do to the tricuspid valve tensor apparatus. And we were very cautious. For many years, we didn't touch VSDs until we slowly started doing, and then it became commonplace. But even now, if you're careless, you can damage the tricuspid valve. So you need to have that fear. A little bit fear is good as an interventionist. But at the same time, you can't be too afraid. Here are some examples that I have done for the first time. This was something I did for the first time in the world. That is closing a preterm PDA in the lab, in the cath lab. So this was a series that we published in 2008 in JACC, where we took a 900 grammer and put coils in the PDA and closed it. It was considered mind-blowingly difficult, but I had to be a little crazy to do it. I was a lot younger at that time. Here's an example of an ASD that is so large that you hardly have a margin, but I closed it in the cath lab in 2003. And I felt terrific about it. But I can tell you that you have to really think hard, and before you venture into something of this nature, it is not so much of bravado, but it also requires a lot of thinking, deliberation, and acceptance of failure. Another set of opposite attributes, being calm in the cath lab and being steady, but also having short reaction times. When you see a disaster, quickly acting on it. But at the same time, being calm and steady and not getting hyper-reactive. Planning of everything in the procedure, but still being willing to be flexible in the cath lab. Something doesn't go as per plan, you should be willing to innovate. So that's another balance. Being meticulous. When we were at All India Institute, we had to take pressure in every location, everywhere, and then come out. But 3 days ago, I did a balloon aortic valvotomy in a child who was going to die. I can't insist on getting LV to aorta pullback. The child will be dead. I had to go and balloon the valve. So it needs a balance. And again, it's dictated by the circumstance. Most important, when to stop and when to persist. That's a fine judgment that comes after years of being an interventionist. You must know when to stop. But at the same time, you should not give up in a patient who's going to die. So that's another judgment. And again, these are all lessons you're going to pick up on your own. It's not something that I can talk. Finally, when you have a problem, when you have a complication, you should be able to introspect, correct, and come back a better person. If you get destroyed by the complication, you can't intervene again. But if you are totally not bothered, you'll make that same mistake again. So that balance is very important. So it's, of course, independence versus interdependence. I don't need anybody. I can do it all. I don't care. I can do it. I don't need a surgeon. No, that's not the right approach. There are circumstances you need somebody else. So role models, who are the really great interventionists? I'm going to talk about a few of them I worked with. What is special about them? How did they learn their craft? So these are two men I worked with. The man on the left was my guru, Dr. Jim Locke, who taught me interventions. He taught me to think in the cath lab. The person on the right is Dr. Shaq Qureshi, a very different kind of person. He's not my guru, but again, a very successful interventionist. But these are people who had some commonalities. Dr. Savitri Srivastava, my guru from All India Institute, a remarkable personality who taught me a lot. And Dr. George Joseph, I'm just giving you an example, a tremendous innovator. He's still very active in Vellore. I look upon him as an extraordinary interventionist. Dr. Philippe Bonhoeffer. And these are the bottom names of the two, Dr. Joseph and Dr. Bonhoeffer, are for their innovation. Remarkable innovationists. Dr. Bonhoeffer is the reason why you're doing TAVI today. Okay, what's the common thread? What's common to all these people? I think I noticed one thing. They had rock solid foundations. And what were those foundations in? They knew their anatomy really well. Not just anatomy. Dr. Locke had a GPS in his brain for anatomy. What was going in 2D, he understood in 3D. They understood physiology and hemodynamics. For congenital and structural interventions, that's paramount. They understand that really well. It also matters further. And they knew their hardware. They knew every bit of how those hardware was designed. And they could innovate because they understood that. And then, of course, they understood when not to do. I think in that, Dr. Srivastava stood out. She would not intervene when it's not going to help the patient. So they knew natural history. So this is so important. And if you want to become a good interventionist, this is your investment. So, as I said, you must have a mental 3D image. The more time you spend with models, the better it is. Today you can do it with virtual reality. You should know your hemodynamics, every bit of it, and it's really fun to understand it. Then you know how to take the right decisions in the cath lab. You should understand hardware. Really, I use a lot of adult hardware, and I've learned so much from that. And then natural history, of course. Here's an example, 2 examples. This is an ASD I had closed with an Amplotzer device many, many years ago. And all seemed well, but the patient had a continuous murmur when he came to my clinic 6 months, and he had an aorta to RA shunt. So this is an important lesson for me, to understand that ASD device is not safe all the time. I mean, this is 1 in 1,000 cases. Another case, 8-year-old, intervened in another institution, small VSD, not a large VSD, with ADO1, good result. 4 years later, severe, significant AR. Moderate AR became significant because of erosion of the sharp end of the PDA device. So closing a small VSD recklessly created this damage. We took the patient to the OR. There was a hole in the aortic valve that you can see beautifully out there that had to be patched. The device had to be excised, and the patient did well. But then you should know about it, and you should know when to do it. And these are the elements that I have listed that constitute a safe cardiac catheterization. It's a long list. I'm not trying to go through all of it, but this was how Dr. Srivastava and my mentors at All India Institute taught me a lifetime lesson. This 25-item checklist is so important for every trainee in the initial years. It's the most important investment. You have to be safe. So remember, the fun part of catheterization is only a few minutes, but the planning and before that happens afterwards is of extreme importance. So it's everything that goes into cardiac catheterization, hand-eye coordination. All this is really given a lot of importance, but it's a small part of. So the roadmap is really to acquire solid foundations, lifelong learning from mentors, deeply introspect on your work, think of your failures, and both long-term as well as short-term, remain patient-centered and not procedure-centered, be a part of team or build one. Thank you. I just have to end with showing you this last focus, which is Dr. Tandon, my guru, my ultimate guru. What he stood out is humility. As an interventionist, you have to become humble. Humbled by your experience and by your patients. So you have to treat every patient, every procedure, everybody who contributes to that procedure, every step with respect. Thank you.
Thank you very much, Dr. Krishna Kumar, for such a brilliant opening presentation of this session of pediatric intervention. And I'm really impressed about the whole journey of yours and the sanskara you have put in to your people like Dr. Ashish Chapre, who is doing really wonders right now. We have actually had pediatric cardiology. We are watching in my 46 years of practice how it grew. And certainly in this century, the things have developed very fast. And certainly Patna is also catching up very quick with these people like Dr. Ashish Chapre and Dr. Prabhat, Major Prabhat. He is doing wonders. I mean, they are doing wonders. And I'm very much impressed. My PICU right now, I'm also in Vedanta. I'm heading the division of pediatrics. So the whole PICU is practically being occupied by his candidates. So he is doing a wonderful job. Thank you, Dr. Ashish Chapre. I think the stage is yours now.
Thank you for giving me this topic. It will be very difficult for me to maintain the engage the audience the way KK sir did, but I'll try whatever little way I can do. So I'm going to talk of my experience on perimembranous VSD closure, and again I am discussing on the planning and the execution of that. So VSD device closure, basically first, as KK sir said, you have to understand the morphology of the lesion. You have to understand where it is located, what are the margins, how you can approach that VSD, and how you are going to close. Should it be closed by the catheter intervention or by the surgery? And all this decision is not made in the cath lab. You have to do it prior in the echo lab. So what you are doing, you are selecting your cases properly. You should not be using the cases where device will not fit or it will be, margins will be very small, or you are eroding the aortic curves. Your approach, you have to select what is the size of the baby. Is it going to take that sheet for that device size? You have to be very precise in device selection. You have to plan your intervention in such a way that how you are going to cross this lesion, because the bundle is there, you can damage that while even crossing. So you have to be very precise in planning your procedure. So why we want to go for catheter intervention, surgery versus, it has evolved over a period of time, but surgery is still the gold standard. So whenever we are planning a device closure, what we have to do is to maintain the standard of surgical results of VSD closure. So all these complications are because of the surgical VSD closure, and you can see the complete heart block. So if you are doing a device closure, you have to understand why during surgery this complication happened, and then you have to avoid those complications. So complete heart block, it is basically because of the mechanical damage or injury to the conduction system. It can be because of the patch placement, the stretching of the tissue during the handling of the VSD. You can leave a residual VSD, you can damage the tricuspid valve, you can damage the aortic valve. So all this complication can happen during the device closure. And unless and until your incidence of this is not matching with the device closure, then you are not justified in doing the device closure for the VSDs. This is an AI generated slide which I have got, is basically showing the results more or less the same in all over the world. If you go with all the meta-analysis and all, this has taken into consideration. So you look at this, that the risk, if the cases are selected properly, it reaches the same level as the surgery. Even the conduction block is nowadays is lower than the surgical VSD closures. So how you understand the morphology, first we did in the echo lab, then we are going for the LV angiogram. So you have to plan angiogram also according to the morphology of the VSD. Then these videos are not playing, I don't know. Why videos are not playing? So, oh, I have to do this. So these are the VSDs. KK sir may not agree with sometimes smaller, but I try to do I am not doing QPQS assessment, but I am going by the echo images. If I see the LVs enlarged, LIs enlarged, then only I'll take this kind of VSDs. We have to, I'm sorry. Yeah. So should we close this kind of VSDs or not? That is a question. Then these are the mid-muscular VSD. So you have to understand the morphology. Then there are many variations of when we are dealing with VSDs, perimembranous VSD particularly. You can have, I'm sorry, I'm not getting this right. It's not going on this.
There's no video, right?
No, these are videos actually. So you can have this one. But how I'm going to get that? Yeah. So you can see there are different morphologies of even septal aneurysm. There can be multiple RV egresses, there can be egresses in different directions. So you have to plan what egress you are going to cross, where you are going to place your wire, how your catheter is going to cross, what will be your device placement. So all these minor details are very, very important. Now coming to the tools, this is what we started, we have learned from KK sir only that we used to do that PDA device using for the perimembranous VSD also. That time we were doing very minimal numbers of VSDs with the PDA device. People have tried this kind of double disc devices which came earlier, were actually meant for muscular VSDs. Then came the asymmetric VSD device also. ADO2 device was basically the largest size available is 6'6", so you can close a maximum size up to 4 mm only, so which is not a very significant shunt. Nowadays what we are using is this Konar MFO device designed by one of our colleague only. So this is the device right now everybody is using, and the advantage of this device, it can be used retrogradely also. It has got a screw on both the sides and it fits into the device. It's a low profile device, goes through the small sheets. So all these advantages are there. So nowadays most of them are using this device only. Now over the period of time I have realized that whenever you are going from the venous side, you are taking this route actually, and it is responsible for a lot of complications you are going to get. The tricuspid regurgitation, heart blocks, all because it's so much tension on the tissue at that point. So what retrograde approach gives you, that you are crossing the perimembranous VSD, you are parking your catheter in the apex. So it's a direct straight connection. You are not giving that much of stretch on the tissue surrounding the VSD. So how you are going to cross this VSD? Basically, when the flow is there, the wire goes automatically to the pulmonary artery. What I have realized over a period of time, I should not get my catheters from there. I try to get always my wire with some manipulation into the apex, then I cross, and then I'll be placing my delivery system and the device. So retrograde approach is preferred nowadays, whatever I've shown. Previously, we used to do arteriovenous loop. Still, sometimes we have to create those. And one of the method, if you have some compromises on the arterial access, then you can use directly crossing. I will show an example where you can cross directly from the venous side, RV, to the LV side. So these are the advantages of the retrograde approach. So I'm just showing this, one of the example of this. So you can just, I have realized over a period of time that if you place the catheter around the VSD, then you have to do a lot of manipulation of the catheter, and then this causes some kind of edema. At least you will see some transient heart block. If you are crossing with the wire only, then it gives you better results. Placement of the device again depends on the morphology of the lesion. Sometimes you have to do intra-aneurysmal deployment, and you have to use the device in such a way that it is not causing any, there is not residual VSD, and it is not causing any aortic valve damage. So this is the type of device deployments you can have. This is a case we have done with adult VSD. The VSD was small, but there was an indirect gerbo shunt. So we decided, because there was RA overload, so we decided to close it. The careful, you have to be very careful in deploying the RV disc here, because it get caught in the tricuspid chordae. So you have to be very careful. I'm doing that, and then I'll just like to show one case here. So this is a posterior muscular VSD where you can use a venous approach. You can cross directly from the SVC to RA, RV, and then you can cross and you can deploy your device. This is a very interesting case which we have done few months before here. It was a perimembranous VSD in a less than 5 kg child. The dilemma was, should we go for surgery or not? This child was having a wet lung. He was dependent on the long time in our ICU on the oxygen and supportive methods. He was a Down syndrome. We had a discussion with our surgical team, and they were reluctant to take this patient, thinking of the post-operative care and all. So we thought, can we do it without intubation? And we made a decision. These were all the deliberation. We thought what approach, and ultimately we decided that we are going to cross directly from the venous side, not putting any stress on the surrounding structures. And we did the device deployment from the LV side directly, and we could get the good result. This child I have been following for the last 6 months. He's doing very well. Just 2 minutes more. So as Dr. KK said, you should know when to stop. These are the 2 examples of Everest climbers from Indian origin. Last month only, they died. Actually, they reached the summit. They lost their life while climbing down because of the 2 mistakes. One climber who is so experienced that he has climbed all the peaks of each continent, he was told that you are too tired, don't go right now to the summit, wait, once you gain the strength, then only go. He didn't listen because he had a failed Everest climbing experience last year. He climbed there. While returning, he could not take this, and he died at the Everest death zone. The second one, he did a small mistake after achieving the summit. He was standing there. He removed glasses for taking a selfie for 2 minutes. They are UV glasses which are protecting you from the snow blindness. And he got that. His cornea was damaged, and while coming down, he was totally blind. He could not be saved. And one of their bodies is still lying in the Everest. So, most important thing, you should learn when to stop and when to relook at your decision, and there is no ego issue in that. Thank you. Thank you for patient listening.
Thank you, Dr. Ashish Sapre. I think you talked about this stewardship, and this is also very important, not only in antibiotics, but here in your intervention also. When to stop and when to really do it with courage. I'm sure that the next speaker is another of your Medanta team, that is Dr. Soni. And she will be speaking on mid-term outcomes of balloon coarctoplasty in neonates. This is something which is so innovative for neonates. You are doing that so successfully. Dr. Soni.
Good afternoon, everyone. Thank you for the topic. My topic will be severe neonatal coarctation with a small transverse arch, whether we should go for surgery or we should intervene. Coarctation of aorta is the sixth most common lesion in the congenital heart disease. The incidence is 4 to 6 per 10,000 live birth on CSD. Coarctation represents not only a single disease, but it represents a spectrum of disease from discrete coarctation to tubular hyperplasia, along with association with other congenital heart disease like bicuspid aortic valve, PDA, VSDs, and Schwann's complex. So this is the fetal development. It is showing the development of heart from day 15 to day 50. And here it clearly illustrates the aorta, which is complex anatomy of the aorta, which is deriving from multiple structure. This is a morphological classification. This is a normal arch, and this shows discrete coarctation. The third diagram shows hypoplastic distal arch, and the last diagram shows hypoplastic long segment arch. So another classification is in relation to the duct, which includes juxtaductal, preductal, or postductal. So the primary goal of treatment in newborns will be relief of the obstruction, improve antegrade flow, reduce diastolic runoff, and reduce LV afterload, and overall improve the hemodynamics of the newborn. So the options available are basically surgical, interventional, and medical stabilization. So the strategy will be, first of all, planning the procedure. And the planning of the procedure starts once the diagnosis is made. It starts from the imaging, like echocardiography, CT pulmonary angiogram, or 3D reconstruction, vascular access, deciding the diameter of the vascular access, means which axis we should take, then length of the balloons, whether the child is associated some other features like aneurysm, etc., and the size of the balloons, and whether pacing is required or not. Then comes the counseling part, and last is the execution of the plan. So the treatment options among surgery, it includes subclavian flap aortoplasty, resection and end-to-end anastomosis, and patch aortoplasty. Other options are balloon angioplasty and stenting. The surgical complications of the surgical complication of repair of coarctation are residual or recurrent coarctation, hypertension. The child will be taken on pump, so very high risk. The child will have a post-op stomy course, means there will be difficulty in the extubation. Complications like aneurysm and dissecting aorta has been noted. Laryngeal nerve palsy, stroke, paraplegia, and even death is seen. So this is the ESC 2020 guidelines, which shows when we should, how to manage the coarctation of aorta. Means when there is a peak-to-peak gradient of more than 20 mmHg along with arterial hypertension, the class of recommendation becomes the 1A, and we should intervene. And when there is no arterial hypertension, then it becomes class 2A of recommendation. So coming to the case scenario, 22-day-old neonate, weight 2.4 kg, came with the heart failure symptoms, with bad lungs and impending cardiogenic shock. The neonate was on fluid and inotropes. Echo suggestive of severe coarctation with moderate hypoplasia of the transverse arch, means Z score was between -2 to -4, and along with severe MR. So the plan will be relieve the obstruction. Options are surgical. It will be a very high risk for the surgical repair of coarctation in 2.4 kg with the bad lungs, because the child will be taken on pump and the risk will increase more. There will be very post-op stomy course and the chance of recurrent coarctation will be there, and in the long-term follow-up, hypertension can be seen. So another option is stabilize medically and then intervene. So because after intervention, there is noted potential for the growth of the transverse arch. So the treatment of choice here will be balloon dilatation of coarctation. So this is the basically echo of the child, which is showing moderate hypoplasia of the transverse arch along with the coarctation. And this one showing this is the color running image of the quart segment, and the 2D still Doppler image showing sawtooth pattern with continuous holodiastolic flow reversal. The CT scan shows the arch, which shows hypoplasia of the arch along with the discrete coarctation, and 3D reconstruction was also done. So after proper planning, we took the patient to the cath lab, and in such a case, vascular excess was made. Vascular excess are generally dealt with USG guided so that we can have minimum complications. And then we planned for the femoral approach, and after securing femoral access, a guide wire was passed, and we crossed the quart segment. Angiography was done, which revealed this image shows the transverse arch is approximately 3.8 mm and ascending aorta is approximately of 11 mm. So first of all, the balloon dilatation of the quart segment was done with a coronary balloon, and then followed by semi-compliant balloons like Tyshek. And similar, the balloon coarctation was done of the transverse arch also. This image is the after 2-month follow-up, the child came for the follow-up, and this is the image, and we have seen the transverse arch, which was approximately 3 mm, grown up to 4.5 mm. So coming to the case 2, 1.2 kg newborn, 7-day-old. The child was a syndromic baby, weak femoral pulses, echo suggestive of severe discrete juxtaductal quart with smallest transverse arch with moderate LV systolic dysfunction. The child was transported on higher supports of prostaglandin and blood gas suggestive of metabolic acidosis. So the plan was stabilize the child and take the child for the emergency balloon dilatation of the quart. So this is the LV study showing moderate LV systolic function. And we have planned, as the child was 1.2 kg, so we have planned for the right axillary approach. And because femoral was very of very small caliber, so axillary approach was, axillary artery was secured and injection was done, and the transverse arch was approximately 2.9 mm, and this DTA, descending thoracic aorta at the level of diaphragm was 5 mm. Continuous holodiastolic flow reversal was seen in the DTA. And successful balloon dilatation of the quart segment was done. This is the image. After balloon dilatation, this is the image. And the child was discharged. Then afterwards, on the second follow-up, when the child was approximately 2 months old, the child came on the follow-up, and we noticed that there is again redevelopment of the coarctation. So at that time, the child weight was approximately 2.4 kg, and then we again planned for the balloon coarctoplasty. Then that time we have done the femoral approach, and this was the basically after post dilatation scene. And now the child is approximately 4 months old, and now child is in continuous follow-up. We have seen improvement in the Z score for the transverse arch also. So indication of transcatheter balloon angioplasty are whenever there is a systolic pressure gradient of more than 20 mm Hg, systemic hypertension, or presence of significant collaterals, and nowadays stent are of open cell type, so stent can be placed whenever bailout, in bailout situations, and because the stent can be redilated up to the adult size. And whenever there is a ventricular dysfunction, then we can take the patient for the balloon angioplasty. And when there is a significant narrowing of the aorta, less than 50% of the DTA at diaphragm level. So this was the follow-up of 6-month follow-up of the 10 patients of who underwent balloon dilatation of coarctation at Medanta Hospital. Among that, one patient who was, means we have dealt with a grave prognosis of death because it was associated with a, just 2 minutes, with a pulmonary PPHN. So I would like to conclude that neonatal coarctoplasty is preferred in neonates with native coarctation and associated congenital heart disease. The evolution of catheter intervention and the minimal evidence of recoarctation and the use of USG-guided vascular access has improved the outcome and can avoid the need for surgery. And we have also noted that there is a potential for the growth of the transverse arch, and the evolution of low-profile stents in this era has blazed a trail in the coarctation stenting. Thank you.
Thank you, Dr. Soni, for your enthusiastic presentation. I think you can take your seat. Before we take the discussions to take the technical issues forward, I think we have a pleasure to invite the last speaker of this panel, Dr. Major Prabhat Kumar. He is from Mahavir Vatsalya Hospital. In fact, I have been watching him right since the day of inception, where I was the governing body member, and he's doing such a good, nice job. So please go on with the PDA device closure, not always simple. Let us know about it.
Thank you, sir. Good afternoon, everybody. And when I came to know that Dr. KK sir is here, I had a really goosebump. And Dr. KK sir is really our authority of the PDA device closure. He started his career, I think, from the coiling of the PDAs only. So I came here not with some topic like any new things, but came with some problems. How to move it?
Next
So in my training period, I came to know the PDA device closure is very simple, and we start the career from PDA device only. So in PDA device closure, the usual steps we follow is taking the vascular access, particularly femoral vessels, do the angiography and the PD profile, and the last, deploy the device. In some situations, even looking the simples, but may have some problem. We know the types of the PDAs, and I covered in my topic only the type A conical PDAs. So I start my first case having the problem with the vascular access. My patient was 1-year-old, 5 kg syndromic child. Her echocardiography showed 3 to 4 millimeter small conical PDA and gradient of 67 30 millimeter mercury, along with having the mild aortic stenosis. However, my routine practice is to check the IVC before proceeding for PDA device closure. The proximal IVC was patent. So I planned 5 months old, only 2.5 kg. Syndromic, failed to extubate for long time. On ventilator, having multiple issues, pneumonia, anemias, and sepsis. Only echocardiography having the 2.5 small tubular like such. But actually it was the type A PDA. Having some empalage there, good space there for retention of the aortic disc. And there was mild PAH only. So my pediatric colleague has told me do it and we'll try to extubate from the vent. I referred this case to my surgeon colleague, but there is parenteral effusion and surgeon also not reluctant to do this case. So I plan to do the PDA device closure of this child. We took the only venous access without arterial access. We did arch angiogram through the venous sheath, and we found the exactly same picture of PDA as did on the echocardiography. So, you can see there is a small PDA and having the small skirt of retention there in impala is liquid size. In second angio, after the deployment of the device, there is no compression of the left coronary artery. In third image, you can see after releasing of device, they came back, ricochet of device. On echocardiography, there is a minimal encroachment on the aorta after releasing. It's not crossing beyond the 50% of the diameter of the aorta. But after follow-up in 1 year, child developed mild coarctation around gradient of 40 by 21 millimeter mercury. So coming to last my case, this patient, 5-year-old, 18 kg girl, came with facial puffiness with bradycardia, had normal blood pressures, and non-case of PDA. On ECG, having the complete heart block, rate around the 50 to 55 minutes. Echo has the 3 to 4 millimeter conical PDAs. And what's the plan? I take the first plan, refer this case to the surgeon for epicardial pacemaker implantation plus PDA ligation. But in view of the financial issues, parent refused for the surgical. So I planned for some transcatheter maneuvers. So I, along with my adult colleagues, did the transvenous pacemaker insertion with my electronic device, and later by the PDA device closure done. But I found there's a mistake. I realized later on I did mistakes. What mistakes? There is a loop of the pacemaker lead in RV, and I was crossing through the loop. So this was a bigger mistake if something happened. But luckily, we saved, and the child also saved. So to conclude, problem may occur in any case, hence we should be prepared. Cath lab should be well equipped, must keep all kind of hardware and scenarios, and well-trained pediatric cardiac team, including surgeon, is essential for any procedures. There also financial support is required for completion of any procedure. Thank you so much.
Yes. Thank you, Dr. Pradhan, for nice delivery. And the main discussion point of the pediatric intervention is Dr. KK sir told all the interventions is not helpful to patient. All the things should be patient oriented. The backup surgery is mandatory in all the pediatric intervention. It is two things very important. Many of the intervention is harmful, not good for the patient. It is the one third thing. In Bihar, the pediatric intervention is rising because two of the doctors working, Dr. Pradhan and Dr. Sapre, doing very good work. Initially, when we have come, that time there were no pediatric intervention. Only few pediatric intervention were doing. Dr. KK was coming in Jiva Khada Sudan doing many of the things. That time I was present there. But pediatric made a totally a dedicated team effort is mandatory because post-op care is very, very important, and dedicated nursing and all the teamwork, then the good result will get. Otherwise, it is very difficult to achieve a target goal. It is the most important thing in pediatric intervention. When the doctor KK had told about the perimembranous VSD. The natural course of perimembranous VSD is very important. Many of the VSD will close, lifelong persist. There is no need of intervention. But now a new thing is coming when the VSD is closing, many of the patients going for a small VSD intervention closure. That is very harmful to patient. One of the example he showed, the patient developed AR in later stage. So that is, you should look all the thing. 5 years later, how will this behave? It is not short-term thing, not look from the narrow angle. For long time, his quality of life is improving, his longevity is improving. Not these are the things is important for the pediatric intervention. And because it had taken most of the surgical things is coming to the pediatric intervention, like like PDA closure, ASD closure, and now a VSD. Now many of the ASD primary is closing by device. How much is a long-term result, I don't know, but many of the things doing nowadays, this is very important.
If you want to add anything, Dr. Suprit Balur.
Just wanted to ask Dr. KK sir, his take on small PDAs or small VSDs.
So, I have my views on these. For the small PDAs, if it is clinically silent, you can't hear a murmur, then closure is not indicated. If you have a systolic murmur, I don't close because there is no benefit. Why do you close a small PDA? You want to prevent endarteritis. For preventing one endarteritis, you have to close 2,400 PDAs. So if you look at number needed to treat, it doesn't make sense. So I don't close these. I close a PDA only if there is a continuous murmur. So there, yes, there is volume overload and it's a simple procedure, so I do it. With VSDs, I was having the same problem. So what I did, 15 years ago, I established a cohort in my institution of 1,000 VSDs. 1,000 consecutive VSDs I have been following for the last 15 years. And I've looked at all the complications. In those 1,000 VSDs, I've had 3 endocarditis. Others, maybe dental hygiene in that part of the country is good and I have advised, but 3 endocarditis. No other major complications. In these 1,000 cases, 200 cases, we went ahead and intervened because there was some complication on follow-up, like aortic valve prolapse or significant volume overload, or the patient is having symptoms. But the remainder, we are able to follow, and the patients are doing well. So with small VSDs, unless there is symptoms, significant volume overload as measured by ventricular Z-scores, more than +2, or there is failure to thrive, surgery is not closure is not indicated. We were having a different set of standards when we were having only surgeons close the VSDs. We would say all these things to our patients. But now because we have devices, we have become a little liberal. So we have to be careful. Because the first rule of medicine is don't do harm. So I tend to be conservative. I'm different from mainstream, but that's reflected by my data. With ASDs, if it's large, the long-term results are good, sir. So I don't think there is a problem with significant ASDs. It is now clearly indicated that you should put a device. Or a large PDA, or a VSD that is hemodynamically significant, there is no problem.
Sir,
any comments from you?
Yeah. Just one small question. About the small VSDs, we agree. I have seen patients of small VSDs for last 30, 40 years who are doing absolutely well, having no problem. But there is one problem in small children. There are 2 types of VSDs about which I am concerned. One is the perimembranous, where you have got some difficulty or some incidence of complications that can occur. But there are small muscular VSDs also. What happens is these patients are absolutely well. They do not have any problem. But when they grow up and they go for employment, they do have difficulty. What do you think about that?
You have to be, so this employment issue I have been able to resolve.
Yeah.
What you have to do is give an explicit letter. The question that you have to tell, you have to really say what it is. And the way I communicate to the patient is like this. Would you like a 2 millimeter hole in your heart or a 6 millimeter device? Metal.
No, it's not the patient.
No, I know.
I'm
telling you, it comes from that.
Yeah.
It comes from that.
Yeah.
So Air Force employment, many other areas, if you are having a membranous VSD with a device sitting inside versus just a VSD, you are at a greater risk if you have a device sitting inside, if you're looking at an Air Force point of view, because you are at a small but definite risk of complete heart block happening later in life. You can't rule it out. You haven't followed these patients enough. To put a piece of metal sitting in that region is far more dangerous than a tiny hole. So I write a letter. And I have been successful, not always, but quite a few times. I've got a railway employment done with a small VSD by issuing a letter saying that this is the problem I don't anticipate this problem. I don't anticipate functional difficulty. I don't anticipate any limitations. You can go ahead and get employed. So this I do. For all these minor lesions, I write a letter. Now
what about muscular VSD?
Muscular is the most harmless. Small muscular VSDs, the chances of closure are extremely high. So we don't worry about it at all. Muscular VSDs close. If it is hemodynamically significant, of course you must close it.
I hope we can conclude the session now. If you don't have any comments, yeah. Thank you. Thank you so much.
Thank you, sir, for such a wonderful session and such a great learning. So I have one small announcement I have to make. We have fellow session at 4 in Hall B, that is Darbar Hall. We have 2 judges with us, Dr. Jabir and Dr. Vipin Kumar. 6 presentations will be there from our fellow DM and DNB residents. Ashutosh Mishra from Patna AIMS, Dr. Tejas from Patna AIMS, Dr. Vikas from Ford Hospital, Patna, Dr. Nitya from IJMS Patna, Dr. Manish Kumar from IJMS Patna, Dr. Amit Tony from IJMS Patna. So I request all these presenters to kindly report to Darbar Hall 1, that is Hall B, for fellows presentation. And that program will be mobilized by Dr. Shaheen Ahmad and Dr. Shresh Trivedi. So I request every one of them to be there and get that program run. In meanwhile, we will move on to our next session. We have high tea. High tea will be served here only in the hall. We have asked the people to serve high tea in the hall so that the program does not break in between. Now we move on to our next session, that is based on imaging and calcium management, part 1. Basically, we have divided imaging and calcium management in 2 parts. Day 1 we have part 1 and day 2 we have part 2. For this we have our national fame speakers. So I will like to call upon our discussants, Dr. Pawan Kumar Singh on stage, Dr. Nasser Abdali, Dr. Ashish Kumar Jha, Dr. Jyoti Karn if he is here, Dr. Avinav Bhagat was kindly come on stage. So today's calcium management also you will have to wait because Dr. Anshu Agrawal will be late today. I will also like to call Pramod sir on stage as a discussant. Dr. Jwala Kumar, he is here. I will like to call him as a discussant for calcium management session. And Dr. Bharti sir, kindly come on stage for calcium management session. So we have our first speaker, Dr. Devdutt Bhattacharya sir. He will be speaking on how we use IVUS in deciding the treatment plan. One more announcement which I have to make, we have ongoing felicitation ceremony just downstage besides the hall which is ongoing. So I request all the discussants and all the moderators and all the speakers to stay back just after the program so that we can do the felicitation part just beside the stage. Thank you. Dr. Devdutt sir.
Can I have my slides, please? Thank you. So, my topic is how I use IVUS in PCI. So, why should we do IVUS at all? Why should we see the vessel first? Till date, intravascular imaging is heavily underutilized, and despite multiple randomized trials having demonstrated that intravascular imaging can alter outcomes, especially in certain subgroups. And IVUS and OCT are both helpful as intravascular imaging devices. And image guidance should be considered strongly in complex PCI lesions and potentially in all comers. So this is the year 2011. So I have been doing intravascular imaging for a long time, and we bought an IVUS machine back in 2011, but we really didn't know what to do with it, and we were not doing a lot of IVUS. But let me share a case. So this is a 53-year-old man, non-diabetic, hypertensive, smoker, presented with chronic stable angina, and he had ECG changes in his anterior leads, and his echocardiogram was normal. And you can see that there is stenosis in the LAD D1 bifurcation, quite tight stenosis, and we did POVA to the diagonal, and we stented the LAD. And this is a 3 millimeter stent. And this was our final result. Now, this patient came back after 1 year with severe angina. And this was his angiogram. Now, this is a little disappointing because this is a drug-eluting stent. And we were quite confident that the patient would be fine. And he was also very disappointed, and he didn't want a second angioplasty, and he went and had a luma to the LAD. So the questions arising from this case are, where is the problem? Why should we fail in simple cases where angiographic result appears so satisfactory? And how can we solve this problem? And is it patient or procedure related? And can intravascular imaging help solve this problem? So now this is another patient, and this is the year 2014. These are all real cases. And this is someone who had angioplasty at another hospital. Patient presented with ACS, and he had a direct stenting with a 2.75 by 33 millimeter stent. And this was the final result. And this patient also had restenosis. This patient came back, and this was how it looked. This is actually after a little bit of balloon dilatation, because I wanted to do intravascular imaging. It was much more tighter than this. And this is what it showed. So if you can see that after balloon dilatation, I have produced some space, and is this working? No, where I want to do the pointing. Oh, okay. Thanks. So you can see this is the external elastic lamina, and this is the stent after I have dilated it, and you can see it is grossly undersized. Okay, so this is 1 millimeter. So this stent is not more than 2.5 millimeters. So this has not been stretched out to accommodate the actual diameter of the vessel. So that is the problem here. And this is after we have dealt with it. So now we have optimized it, and we have put in a 3.5 millimeter stent here. And that is solely because I appreciated what had gone wrong with this case. And these were lessons that we were not aware before. Now we know very well what to do. But before, we were not so much clever about these things. And angiography, as we can see, can be misleading in vessel sizing, leading to undersized stent and under-expanded stent. And in instant restenosis, IVUS can always provide valuable insights. Mostly it is undersizing. And henceforth, we decided to do IVUS-guided PCI in all our patients coming with ISR. So to show you a few more cases, these are 2 cases presenting after 5 years. So this is RCA instant restenosis. And again, the IVUS showed that the middle of the stent was grossly underexpanded. You can see here. This is the stent, and this is the vessel. The vessel is huge. This is a 4 millimeter vessel. And this is what happened after we had stented it. And I could go on. I could show you more cases. This is a case that had come back after 15 years with a calcific ring in an LED stent. And we failed to do anything to this because it wouldn't yield to anything. Now we know we have super high pressure balloons, we have OP and NC, and this lesion needs an OP and NC balloon to crack it. Again, this is a severe instant restenosis in a RCA with a subtotal occlusion, and look at the size of the stents, a 2.75 and proximally and a 2.5 distally. And we ended up with a 3.5 proximally and a 3/38 distally. All I was guided. And here again, 5 years later, so sometimes you will get away for a while, but if you have undersized your stents, they will come back to bite you. And this is 5 years later, ISR in a 3 millimeter bare metal stent. So this is not a drug-eluting stent. And we have put a 3.5/28 after IVAS guidance. So all these things you come to appreciate if you start doing intravascular imaging. And you develop a different understanding of how the angiographic dimensions can be actually misleading. So after I had done a few of these cases, I did a series of patients with diffuse coronary disease in diabetic patients. And these were all female patients. And this is the background, diabetic Indian females with small vessel disease. And we know that at that time, these patients would never go for angioplasty. They all went for bypass because they had a very bad prognosis after angioplasty. And Indian women with an overall small bad body habitus, they were believed to have small vessels. Are these vessels really small? So I illustrate these cases. So this is a series of cases, and in case 1, you can see that if you go by angiography, your proximal and distal landing zones are 1.6 and 1.3. And however much you might imagine, you will not implant a stent that is 3+ here. But this is what we saw. So these are more cases of similar dimensions, and I will show you what we did. So this is what we did. We did an intravascular imaging assessment of the distal landing zone that we thought was suitable by angiography. And then we did a IVAS interrogation of the entire vessel. And what we saw was that these vessels were actually not small. These vessels were not small. If you look external elastic lamina to external elastic lamina, these are actually fair-sized vessels with a very large plaque burden. And this is why they appear so small. So once we had seen this, what we did was we did very aggressive pre-dilatation, and then we stented and we did very aggressive post-dilatation. And you can see that the dimensions achieved by these under intravascular ultrasound guidance are much, much greater than what it would have been if we just went by angiographic guidance alone. And I will show you, to just hurry you up. So the distal landing zone, which at the time of stent implantation appeared between 2.25 to 2.5, invariably required dilatations 0.25 millimeter greater than the chosen stent. And the proximal LED in all cases, so the proximal LED required a dilatation with a 3.5 millimeter balloon. And this is now the dictum. So if you have a lesion in the proximal LED, however small it might appear to you, it will take a 3.5 millimeter balloon dilatation. And if you think that it is less than that, you should do intravascular imaging and confirm it. Very, very rarely it will be less than 3.5. So what we found was that all these patients who had very small, apparent very small vessels, where actually they were not small at all. And the proximal LED, especially in all cases, were greater than 3.5. And that was the lesson I learned from this series of patients. And we published it in TCT-AP, and it was published in the TCT-AP Korea JAC edition. So you can go and look it up there. Now, the question is, so this is another case. So you can see that this is almost a CTO. It is again a diabetic female, very diffuse disease distally. And I think you just saw what we did here. So this is the index procedure. There is something here, okay. And this is what happened after 3 months. So you can look both side by side. The distal vessel has actually grown. I was very skeptical about this result, that what would happen to the distal vessel, and I have not addressed it. Apart from this small segment, the whole of the distal vessel has grown. So this is what you can expect if you put a fair size stent in the proximal LAD. Now, I will skip through this. So I have already told you what I learned from this. Now, I come to a case of Deb. So this is a 49-year-old male, an IT professional, smoker, hypertensive, poorly controlled risk factors. He had PTCA to the diagonal artery first in 2011, then again in 2019. So he has 2 stents in the diagonal, and the diagonal was a big artery, and he's now presenting with ACS. He also has a stent in the obtuse marginal, but just ignore it for the moment and concentrate on the diagonal. And you can see there is a very tight in-stent restenosis in the diagonal again. And now we have to deal with this. And what should we do? That is the question. What are we going to do about this? The RCA is occluded and it has collaterals from the LAD. So this is what we have. We have 2 stents in the diagonal and we have an in-stent restenosis. So we passed a balloon to make a little way for the IVUS catheter. Then we put an IVUS catheter in and we did the IVUS. Now look at this IVUS. This is ALA. This is the Avigo system, and you can see that the whole vessel is severely diseased. And I will show you sections. So this is 3.8 here. So where the cursor is, that is the corresponding. So I will show you a few more measurements. Again, 3.25, 3.7, 3.44, 3.01, 2.59. So cursor is here. This is the tightest. And remember, this is a stent sandwich. 2.53. And here we are at the distal beyond the stent. And this is a reasonably good landing area. And you can see it is 5.23. So what we did was took a 3.3 by 10 OPN NC balloon and we went up to very high pressures. And for the proximal part, which was not stented, we took a 2.75 by 10 Wolverine balloon. And this is the IVUS after we had dealt with it. And you can see from the Avigo itself, the longitudinal layout, that it has expanded all the way. And now it is suitable for a DEB. So this is a drug-eluting balloon, 3 by 35 at 6 atmospheres for 60 seconds. And the pre-dilated ISR diagonal stent. And this is the final result. This is spasm. I mean, this is a still image. So this is spasm. This will go. So you can see that we have now caused a very good lumen gain by our dilatation, and we have used DEB here. Now I will skip through the cases quickly. So this is again RCA, very similar type of problem. Where do you land your stent? And here we have seen that the distal landing zone is 2.6, but the proximal is 3.4. So our final result was like this. But why am I showing you this case? This is 1 year down the line, and look at what has happened to the distal RCA, how much it has grown. So how do you decide where to land your stent? If you see that the distal vessel doesn't have plaque, it is only undergrown, then you can land your stent proximally. So I will not show you the IVUS guided CTOs because it will take some time, but I will show you one case with, this is my last case. So this is a 73-year-old man, diabetic, hypertensive, progressive shortness of breath, and echo shows a ejection fraction of 44%. Patient came in failure, creatinine slightly raised, and there is a regional wall motion in the LAD territory. And worse, the LAD actually supplies the RCA. So we are in a bit of trouble here with this man, and you can see here that the IVUS won't cross. Let me just go back. 2 more minutes. So you can see I'm trying to put the IVUS down and the IVUS won't cross. And there is a lot of calcium here. Starting from there till there, we have calcium. So we had to modify the calcium for the IVUS catheter to pass. So this is rotablation. I won't bore you with the runs here, but it took us a long time. That is all I will tell you. But now look at the IVUS. So I will just show you, because I am speaking on IVUS, I am going to show you this IVUS. So this is, we are coming up, doing a pullback from the distal, and you can see as we come up, you will be able to see the cuts in the calcium, and I will try to point them out to you. Not yet, not yet. So this is fibrotic tissue. We have not yet reached that region, but we will. Let me just rush it a little bit, maybe. Yeah, so now you can see the calcium here. You can see there are cuts, but there are regions where the calcium has not yielded. There again, there is a cut there. There are reverberations here. There is a little bit of cut here. So this is a very difficult case, because just doing rotablation with one burr will not modify all the calcium. So you have to either go up with a bigger burr, or you have to do something else. And what we did was, we first tried to see how a 2.5 by 12 NC balloon would behave. And you can see that there is a dent here, there is a dent here, and there is a dent here. So the balloon is actually not expanding fully, which is why we took an IVL balloon. So this is a 3 millimeter IVL balloon, and we kept giving pulses, and we finished all our pulses. And ultimately we thought that the vessel is now dilated. And then we did an IVUS. I don't have time to show you the IVUS, but we stented it, and you can see that there is still this little notch here. We went up to very high pressures with a 3.5 millimeter balloon, and this is our final result. And you can see that all the diagonals are flowing, the septals have come out, and the right coronary artery is also now better perfused. And this man was very sick, and he's still 1.5 years down the line, he's fine. So in conclusion, calcified images require intravascular imaging. We all know that. AI-driven image interpretation will become more and more important in our practice, and probably make interpretation of IVUS user more friendly in the coming days. Thank you very much for your attention.
Thank you, Dr. Debadat, for an excellent discussion on use of imaging. The only funny part is that the latest one of the studies says that you don't need imaging even in left main.
Yeah, I mean,
so
I think I didn't show you the left main because of that reason only, that people will bring this up.
Yeah.
I have read that study.
Yeah.
Now, there is a problem with that study. So they are all experts, and they are all familiar with IVUS. There is no one in that study who doesn't know how to do IVUS.
Yeah, true.
And
true.
Then if you look at their data, so if you are doing a study, you have to have equipoise. So there has to be a real question about the size of the vessel. Here, regardless of the fact whether they have done IVUS or whether they have done angiography, their stent sizes are the same. So you already knew the answer. If you already know the answer, how will IVUS make the difference?
Yeah, so these are the experts who developed that insight after doing IVUS.
Yeah.
So exactly. So now with that insight, you may not use IVUS. But
yeah,
for
so
beginners,
the question is not there.
Yeah, no, but for beginners, I would still say that IVUS is a great tool. You must develop the habit of doing IVUS more and more. Don't think that this is a simple lesion. This doesn't require IVUS. You know, there are labs in Japan where do IVUS in 100% of the cases, and look at their results. So familiarity with IVUS is a very important thing for any interventionalist, anyone. So thank you, Dr. Debadat, for an excellent talk. We have next is a panel discussion on rota ablation in ACS situation. Very interesting. Dr. Sharath Reddy is online, and we will request him to start his talk. So his introduction is there, a real expert. So we are all waiting for him to start his talk. Dr. Sharath, can you hear us? Can somebody just call him? Just call him. In the meantime, I will just ask the participants here, how many of you are using IVUS? 1, 2, 3, 4. And what percentage? More than 50% cases? Who uses in more than 50% of the cases? No one. That's very sad. We can see you, Dr. Sharath, but we can't hear you. Can we move to the next speaker while the system is being fixed? So we have a speaker from Ranchi, Dr. Vineet Kumar, rota ablation, IVUS guided PCI in diffuse calcified balloon uncrossable LAD lesion in CKD patient. Dr. Vineet. Can you hear us? Dr. Sharath, can you hear us?
Am I audible?
Yes. Okay. Welcome.
Yeah, thank you. I think there is some technical glitch. See, I unmuted myself long back, but they're just trying to figure out what the problem is. Okay, yeah. Can you see my presentation now?
No, not yet. Not yet. We can see you. We can't see your presentation yet.
Can you see it now?
Yes. We can see it.
I'm sorry, I really wasted a couple of minutes of all of you. I'm really sorry for not being physically present there, due to unavoidable circumstances in my institution. Nevertheless, I'm very thankful to all the Bihar Interventional Council and everyone there for giving me this opportunity to come in front of you. I'll move on to the talk. I was informed, to have a panel discussion with the cases which I'm going to show. But before I get into cases, probably I'll just take a look at data. Yeah, look at data on rotablation in ACS versus non-ACS patients. Is it really different when we handle these patients with rotablation? So this is our Indian data, so which you can see in the data available. If you look at complication rate, which most of us assume that it might be more in ACS patients, that is low flow and no flow. So there was no significant difference, observed in this single center data. Of course, the sample size is small, but overall, there was no significant difference, observed between the two categories. Look at this data, from again a registry from same registry, multi-center registry from Europe, I believe. So rota in acute coronary syndrome, especially non-ST elevation acute coronary syndrome patients. And if we look at this, the angiographic success is almost same. And if you look at procedural complications and follow-up MACE, so definitely, as the numbers here show, so in NSTE ACS patients, these two are slightly high, and you can also see the statistically significant number. But when they further analyzed, these patients with deep diving into further characteristics of the patients, you will see, you can see here, this is procedural complications, and as well as slow flow, no flow, which appeared, statistically significant. But when it is further analyzed into their, overall profile of patients, so the incidence of CKD as well as incidence of vasculopathy, that is a diffuse disease, is much more in patients with acute coronary syndrome. So, and when there is propensity matching done with these, variabilities, that's when, it reflected, you can see here, after propensity score matching, so there was no significant difference between, survival outcomes and as well as follow-up MACE rates. So the conclusion is same. A rotational atherectomy has a similar procedural outcome and safety profile in patients with both ACS as well as stable angina. Only thing, higher adverse cardiac events are associated with high presence of comorbidities in these patients, especially vasculopathy and renal failure. And with that pretext, I want to move on to cases, and probably panel can also discuss on cases once I show. So my first patient is a 70-year-old male with a non-QMI, good RV function, and is diabetic as well as hypertensive, smoker, and normal renal function. And the culprit vessel was right coronary artery. So this patient was treated and tried doing PCI outside, but they failed. And the reason being, you can see the amount of calcium, in RCA. It is almost like tram track calcium throughout RCA. And also there is tortuosity. And operator was not comfortable probably in doing, rotablation to start with. That's the reason they tried, all sorts of balloons, everything, and they also tried laser. You can see they tried sending laser, but laser didn't go beyond this point. Despite, even guide extension, laser went up to only mid RCA, and finally they had to stop, procedure. And by the time they stopped procedure, the distal RCA became totally occluded. So here is a case where probably, operator threshold for rota was very high, most likely because of little tortuosity in coronary, as well as ACS, and but finally, they couldn't do procedure. So, with us, we decided to go ahead. See, this patient, I believe, without rota, it is almost impossible to find a solution to this patient. The questions are, what's a wiring strategy? So how to wire this? Because by the time he came to me, the distal RCA was totally occluded. Unfortunately, I couldn't keep that image. So, but distal RCA was totally occluded. And what's a calcium modification strategy, and what are the precautions, we have to take while rotablating, this vessel? Case is open for chair to discuss, and then I'll show what I have done.
So, Dr. Pawan, Dr. Abhinav, Dr. Ashish, anyone with any comments on his questions, wiring strategy? Dr. Devdar? Dr. Devdar.
In such case, sir, orbital will be fare better than the rota. And if the rota, then shorter runs, the spacing between the two runs should be almost 30 seconds to avoid the no flow. Hemodynamics should be maintained to avoid the no flow, slow flow phenomenon. And AL guiding, I think the proper support AL would be better choice.
Yeah, I mean, it is a bend, so there is a sharp bend there, and whatever either you use orbital or you use rota, you will have to experience that problem in the bend. I mean, if it is rota, it's a front cutting device, so probably it is going to be easier going across that proximal stenosis. But if your orbital goes across the proximal stenosis on the glide assist mode, and then you can do a retrograde cutting, then that would be, I think, much better. But it is difficult to say whether it will go or not. And I couldn't follow the previous procedure whether balloon dilatation was tried at all. Because if a balloon dilatation can be done and some passage can be made, then the orbital will go through it. But sometimes these are balloon uncrossable or balloon non-dilatable lesions, in which case you have to do modification with a calcium modifying device. If you can do some modification and can slip in an IVL, which is much costlier, then also I think this is a good option for that bend. It is a safer option for that bend. So that is my take on it. And of course, intravascular imaging, Dr. Sharath Reddy is an expert. He must be showing us intravascular imaging in this case as well. So we will have better understanding.
Yes, Dr. Reddy.
Yeah, thank you. One thing, I couldn't show, IVS of this case since that time is, very short. And there are two more cases. But however, the entire vessel is calcified. You can see that on fluoro itself. Yeah, I'll just get into the intervention, what we did. The first operator primarily failed. By the time he wanted to take rotablation, so his distal RCA was totally occluded, and they did a lot of balloon dilatations in entire proximal RCA, which answers, Dr. Bhattacharya's question. So they tried doing balloon dilatations, entire proximal RCA multiple times, but they couldn't advance anything, beyond mid RCA. So, and this total occlusion, that became a total occlusion. So, my strategy here is straight away I've been doing a telescoping even to cross the distal lesion. So you can see here, there is AL guide, as already mentioned by one of the panelists. So a high support guide I took, and there is a guide extension, that is guide plus, and there is a corsair. So this entire system is placed, to start with, and then I started wiring. Okay, so and wire went beyond the proximal, and this is the distal bend lesion where I was stuck. I used a Fielder XTR to cross that lesion, but Fielder XTR crossed that lesion, but all of us know, how much support this Fielder XTR gives. It generally won't give any support. I couldn't advance corsair because my plan, if I can advance corsair, probably I'll exchange to rotawire directly, but it didn't cross. Rotawire, I immediately tried sending a rotawire, but rotawire was not advancing. So then I had to take a scion because it is more flexible wire. It just went deeper. Now I have to make a path for my rotawire. So for that, what I did, so I took an alveo balloon and dilated in distal lesion. That's a lesion with bend, which Dr. Bhattacharya talked about, and then dilated with 1.5 balloon. This is a trek balloon, and that's when my corsair crossed distal lesion. It's a fine cross. So fine cross crossed distal lesion, and then exchanged to rotawire, and then did a rotablation, with 1.5 burr. Again, so the rotablation, see, you can see the distillation, how resistant the distillation was because of the bend. So, but finally, I could cross the distillation after, 4 to 5 birds. So, 4 to 5, burring, and then we did an IVS. There was 360 degrees calcium at this spot, so we decided to upgrade to IVL. So this is one upgrading to rota or upgrading to IVL. These days I prefer, once rota is done and created a space, it is better to upgrade to IVL. Because if I try to upgrade burr and do burring on entire RCA, that is when the incidence of no flow or slow flow will increase. That is much higher if patient is an acute coronary syndrome patient. So we did a rotatripsy at the distal lesion as well as even the proximal lesion, and then we stunted based on the imaging data, and this is the final result which we have got. So I'll stop here for comments from panel, and then I'll move on to the next case. If time permits, or otherwise I can move on to next case.
The only comment from the panel is it's an excellent.
Thank you, thank you. So I'll move on to next case. Again, something similar. So non-QMI, 70-year-old, mild LV dysfunction, diabetic, hypertensive, and again failed procedure, outside. So you can see this is how it will be, in non-Q, any ACS with the calcified lesions, you will have diffuse lesions, tortuous lesions many times, and very, very, very bad calcium. You can also see here there is only TIMI 0 or TIMI 1 flow into the distal vessel. So first procedure got failed because they couldn't cross the distal lesion that is here, and balloons couldn't cross this spot. So there is a calcified nodule here in IVUS, and their balloons couldn't cross this spot. So that's the reason they couldn't, finish the procedure. Again, yeah. So the same questions. Probably I'll just move on in view of time. So same questions. Crossing strategy is the most important in such cases. I always do again same telescoping to cross, and then go ahead with rotablation. So even in rotablation, when there are so many bands, I do use guide extension assisted rotablation in such patients to prevent coronary perforation or eccentric burring. So what I did here, you can see again fine cross and then wire, and you can see, but the balloon was not crossing. That was the exact problem which first operator had. Balloon was not crossing from this point. So then I tried dilating with 2.5 balloon, thinking of making some space, but I could send fine cross up to this point. That is still the distillation, but from there, nothing was crossing. I did antegrade wire escalation to UB3, but even that was not advancing because the support was not great. So that's when I decided to go ahead and do an ablation at the first lesion, that's a proximal lesion. I did a rota to ablate proximal lesion first so that I can deliver the things to the distal lesion and then do again, wire escalation. So this is a rota ablation of proximal lesion. So yeah, it's a sequential rota ablation in this case. So yeah, you can see now the proximal lesion is ablated, and you see the resistance in the beginning. The burr was not crossing that point. That was the reason for nothing being crossed that point. And once that is done, I could advance my Corsair, you can see Corsair Pro to the mid RCA and then started wiring. That's when I get support to antegrade wire escalation. And then you can see Fielder XTR crossed, distal RCA, and then I did a Wolverine to the proximal lesion, and then followed by took a guide extension into middle. This is 7 French guide extension to take 1.5 burr through the guide extension, and then I took a burr through the guide extension. Yeah, I can. So yeah, there was a balloon uncrossability here. So that's the reason I had to do a granuloplasty. You can see here, balloon is ruptured. And yeah, just to even advance Corsair beyond the distillation. And after granuloplasty, we crossed, distillation with Corsair. And that's when I started, moving on to rota ablation through the guide extension. These are the sizes and its compatibility with guide extension. And this is how you can deliver, you can deliver guide extension and rota burr simultaneously, wherein, guide extension is piggybacking on your rota burr. That is one way of delivering. So here, your sending rota is same as, any other case, but where your guide extension is already inside, you can see, in this case, my guide extension is already inside. That's where you have to take care of the burr entry into your, guide extension. And we can see when the burr is at the entry of guide extension, then you pull the guide extension back to send the burr inside and then go ahead. So, and then we went ahead and then did, you can see this is, we just did a burr of the distal lesion now. So, with a guide extension beyond the proximal lesion close to the band, and followed by did an IVL since the calcium is 360 degrees, and then we finished the procedure with 3.5 stents, and this is the final result which you can see. There is a little bit of slow flow. In fact, patient had this kind of flow even from beginning. So yeah. And this is a final IVUS, so we have got almost like 7.1, 7.2 lumen areas. So, I mean, this is a lost case. If time permits, I can show. This is an LMCA. Calcium you can see in a non-QMI patient. You can see there is a kind of nodule in LMCA. So, and what we did, so again, same thing. So I'll just move on, and we tried sending IVUS into proximal LAD, but it didn't grow. That says clearly, you have to do something about it, and balloon got stuck there. So that's when I took it 1.25 bar, and we did, rotablation to LAD as the imaging was not crossing. And after 1.25 bar, we did IVUS. You can see here, so proximal LAD, there is calcium. And you can see here, it's almost like 360-degree calcium at bifurcation. And you can clearly see there is a nodule sitting here at 6 o'clock and close to the LCX ostium. And there is a nodule again in LMCA close to the ostium. So since calcium in LAD was significant, so I upgraded a bar to 2, and we did 2 bar. And again, did, IVUS, you can see still calcium is more than 230 degrees here, and there is a calcified nodule here. And also you can see at the close to bifurcation, it is nearly 360 degrees calcium. So we shouldn't assume once ablation is done, calcium is broken. So imaging after ablation, each ablation, that is my practice, but it is, you have to have your own strategy to understand whether the calcium is broken or not. You can also see calcium nodule in LCX ostium. So that's when I decided, the nodule is not, since it is in LCX ostium, it may not, ablate from ablation to LAD. So you have to go with the ablation from LCX, and you have 3 branches here. So take a middle branch so that you won't cause, perforation or eccentric burring won't happen. So treated LAD, and then went ahead with, ablation into LCX, you can see here. And once you can now observe, the nodule is significantly reduced in its volume. You can see here. And once the nodule volume is reduced, we went ahead and stunted LAD. It's just a provisional stunting strategy. And you can see LCX is flowing nicely as we ablated nodule, and patient is doing well. So just to conclude, rotablation in ACS scenario is different from non-ACS scenarios. As complications look slightly high, though they are not statistically significant in matched population, but there should be a specific strategy in such patients. And most often, these patients will have diffuse blockages and also associated vasculopathy. Thank you.
Thank you very much, Dr. Sharath. A quick comment, otherwise we'll move because we are running really short of time. So thank you, Dr. Sharath, for an excellent presentation. Thank you very much from everyone here in the audience. Can we move on to the next presentation?
Thank you.
Yes, thank you, Dr. Sharath. Thank you very much. The third presentation is by Dr. Vineet Kumar from Ranchi. Rotablation IVUS guided PCI in diffuse calcified balloon uncrossable LAD lesion in CKD patient. Dr. Vineet, you have 8 minutes, so we'll be happy if you present your case in 4 or 5 minutes, then we can have some kind of discussion if possible.
Thank you, sir. Good evening, everyone, and thank you, BIC and Dr. Samsad, for inviting me to this wonderful conference and giving me chance to present my case. So without wasting time, I'm moving to my case.
So my case is a 78-year-old man came to OPD with class 3 angina since 1 year. He is a non-diabetic, hypertensive, CKD on optimal anti-anginal therapy. ECG shows biphasic T wave in V1 to V4, and echo there was mild LED territory hypokinesia with ejection fraction of 45 to 50%. CAG done, we show diffuse calcified LED from proximal to distal with tram track calcification. LCX is 80 to 90% disease with calcium, and RCA mid to distal non-critical disease. RCA. I'm not able to move my slide. It's not moving. This is LED, diffusely disease, heavily calcified, you can see. This is LCX. So patient was given option for CABG, but relative was not willing to go for bypass in view of old age and high risk of surgery. Finally, we decided to go ahead with the PCI strategy. So LED was heavily calcified, so we took upfront rotablation strategy because of diffusely disease, and even 1 mm balloon was not able to cross. So we took 7 French extra backup catheter. We have some difficulty in crossing micro catheter across the mid LED lesion. So we keep our micro catheter at the mid LED, and from mid LED I have faced some difficulty while passing rota wire distally, and after passing rota wire, we can see after 5-6 runs we are able to cross the lesion. Serial pre-dilatation with 2.5, and in proximal LED cutting balloon with 2.5, 12 at 16 atmosphere done. And we can see after cutting, bed was prepared. We tried to push IVUS catheter initially to get information about lesion, but I was not able to pass my IVUS catheter initially. So after doing rota and IVUS, we have rota ablation and cutting balloon strategy. I am able to pass my catheter. Sorry, I am not able to move my slide. Can you help me? Okay, thank you. So after preparing the lesion, well, with rota ablation and cutting balloon, I have done IVUS, and we can see 360 degree of calcium with thickness more than 0.5 millimeter. And after rota ablation, we can see multiple cracks with proximal and distal diameter of 3.5 and 2.75. You can see so this is the angiographic result after, and from then it was straightforward. Distal is 2.75, 40, and proximal is 3 into 40 at 16 atmosphere, and post dilatation with 2.75, 3 and 3.5. So this is the final result of LED. And after stenting, you have again confirmed with IVUS about the stent apposition. We can see the well apposed stent strut with good lumen gain even at the most calcified segment, MLA of 6.5 with no edge dissection and tissue prolapse seen. Next, we tried to tackle LCX. LCX was straightforward, just yielded well with 2.5 cutting balloon, and LCX stented with 3 into 38 at 12 atmosphere, post dilated in proximal with 3.5 and in distal with 3 milliliter balloon. So this is the final result in LED LCX. So initially we started with this LED and final result with this got. I am sharing one more case. I will not take much time. This is a similar case but in acute setting. It's a 75-year-old male with a known case of again CKD on maintenance hemodialysis with history of chest pain and shortness of breath since 1 day. ECG show ST elevation in 1 AVL with ST depression in V2 to V6. In echo, there was a moderate AVR with LV ejection fraction of 35%. Tropi was significantly elevated. LED again is a diffuse disease with tram tract calcification. LCX is subtotal occlusion with thrombus and calcification. RCA in mid 70 to 80 with calcification. This is RCA. This is heavily calcified LED. And this is LCX. So we started with culprit vessel LCX, initially wired with filter FC wire, dilated with 1.25, 2 and 2.5 balloon, and we stented finally with 2.524. So we get a good result in LCX. So we thought we will tackle LED in next sitting, but even after revascularizing LCX, patient was complaining of chest pain. So after 3 days, we decided to tackle LED in the same sitting. So again, there was a heavily calcified LED. We took 7 French EBU guide and upfront rotablation strategy to tackle this LED. We have difficulty in wiring because even microfine cross was not crossing this lesion. I don't have imaging at this time. In imaging, there was a calcium nodule that was obstructing the passage of this fine cross microcatheter. You can see this. I am wiring this by putting this microcatheter at the mouth of the lesion, and after struggling for some time, we are able to wire LED. Can you
show us the last result, please?
Yes, sir. 1.5 were taken, and after 5 pass with few deceleration, we are able to cross the lesion. And after that, it was straightforward. Distal was stented with 2.536 and proximal 3/38. So this is the final result. In imaging, I did imaging a well-opposed stent with good luminal gain of 6.8 area in proximal LED with no stent malopposition. So my take home with this case is CKD is a known risk factor for dense calcification in coronary. Lesion preparation is of paramount importance in calcified lesion before deploying stent. And ROTA is a proven tool for balloon or microcatheter uncrossable lesion. Restenosis rate is higher in calcified lesion, but it can rise even higher if lesions are not prepared well. Stent under expansion is leading cause of stent thrombosis and late luminal loss. Imaging is equally important in dealing with this diffuse plaque and calcified lesion for choosing stent size, proper landing zone, especially in diffusely diseased vessel, and adequate optimization post-stenting. Thank you.
Thank you, Dr. Vineet. We are really running late, so we'll move on to the next presentation by Dr. Gaurav Tripathy, rotablation in uncrossable CTO. Oh, Dr. Tripathy is not here, so we have some time. If anybody wants to comment on Dr. Vineet's case, any questions from the discussants? I just have one comment to make. You know, you stented in both your cases the distal LED,
mid to distal LAD. You didn't think of putting a drug-eluting balloon in those two. So micro dissections are needed. Okay, all right. But I just want to tell you that those are the places where if there is a restenosis, you are really stuck because you can't put a graft there. And as far as micro dissections are concerned, you really want them. The new AI generated IVUS algorithm actually detects those micro dissections, because unless until you produce those dissections, the drug will not go into media. So you want them. You're not afraid of those micro dissections. But anyway, thank you very much. The end result was very good, no doubt about it. So Dr. Gaurav Tripathy is not here. So we'll move on to another next presentation, that is complex case, trust the ultrasound. Dr. Advait Akash Patna.
Good evening, everyone. Born and brought up in Patna, sir, but currently in Dhanbad.
But रहते धनबाद में हो यार.
Anyway, so let's start. So this is an interesting case. It starts with a complex calcification case and then it turns into a nightmare. Let's see. So this is the history, basic history. It's a 72-year-old gentleman with a history of diabetes, hypertension, already a PTCA to LAD done in 2022 with rota to DES. So we know that we will be dealing with some calcification. Now, currently coming with chest pain, CCS2. These are the ECG echo, normal LV function. This is the coronary angiogram of the left side. It's a patent stent, nothing so serious. Now on the right side it is a bit interesting. On the right side we can see that there is a significant lesion in the proximal to mid RCA with some haziness in the mid part. So the question is, what now? What this haziness is? Thrombus, calcium.
Discussants.
Looks like thrombus. I don't think it is.
Show us more views.
These are the two that are available, sir. These are the two images that are available.
I can't be sure whether the lesion is significant or not.
What is the ECG? What was the ECG?
So the ECG was showing on the rest there was no particular changes. But the patient was complaining of typical pain.
The left side again?
I don't know whether we should intervene or not.
Yes, sir. So that's what it's about. We'll see.
Because the flow is good, even if there is thrombus or whatever it is.
Patient, so with the 6 French JR guide catheter, we took another shoot. Now this looks a bit more significant.
Yeah, there is a thrombus. You can see it clearly.
So next step was imaging.
Haziness. So if your wiring is difficult, then it is calcium. It's a nodule.
Exactly. That's what we got to know. So we attempted wiring with the BMW guide wire. Wiring was difficult, in fact, but was successful ultimately. IVUS was tried, but the catheter could not be crossed. And the lesion turned out to be actually a balloon uncrossable lesion. So we do what we can do in such situation, and that's rota. So rota has come to the rescue, 1.5 mm burr. It was done. Post rota shoot, now we can see not a lot of benefit maybe angiographically, but balloons could be crossed and IVUS catheter could be crossed. So this is the IVUS. So as we can see, there is a significant chunk of calcium. And this is the particular place where we can see a calcified nodule, 360, almost 360-degree calcium. Right. So this is the proximal reference segment, distal reference segment. More importantly, what we can see is a good, I mean, there are multiple things that we can see, but more importantly, calcified nodule with reverberations and showing that there are cracks. So, I mean, rota has worked. The tightest part had a MLA of only 2.19 mm square. After yeah, that's a nodule, sorry. True. So with the NC balloon, we did the ballooning, serial balloon dilatation of 2.0, then 2.5 into 12 mm. Still needed body wire for crossing the balloon. With gauge inflation, ST changes appeared on ECG. Now everything was looking good till the nightmare started. So the X-ray tube suddenly malfunctioned. It was really unfortunate, but it is what it is. So cine run looks like this and later shut down completely. Fluoro was working, but only for 1 second runs. Now, desperate times, desperate measures. The second cath lab was busy with CTO, so there was no point of waiting. Risk of losing wire access was there, and vessel occlusion if patient to be shifted. Patient was complaining of mild chest pain as well. So it was decided to complete the PTCA with the available short fluoro runs and IVUS guidance. So we put the second wire as a marker for the proximal reference segment where we wanted this stent proximal part. And the contrast injection timing had to match the 1 second fluoro runs. Sorry. So DES of 2.75 into 38 mm was deployed under the limited fluoro guidance. Post dilatation with 3.0 into 10 mm NC at 10 atmosphere was done. And finally, the moment of truth, we did the post stenting IVUS. So it showed no malapposition, no edge dissection. These are the MSA. So the MSA, we could achieve 5.82, which was completely acceptable. Later, patient was shifted to the second cath lab, and this was the final shoot. So the take-home message for this would be that sudden unexpected cath lab malfunctions can happen. We don't need to panic. We should stay calm. Finding a solution is much more easier with a calm mind. We have to make use of whatever limited options that are left. And intracoronary imaging can provide the necessary confidence while dealing with both a tough lesion and a tough situation. No situation is so dark that there is not a single ray of light. Thank you.
That's very good. Excellent. No doubt about it. I mean, with this kind of unexpected, I've never seen this kind of nightmare when the cath lab starts malfunctioning in the middle of the procedure, but you did very well. Any comments from anyone?
Yeah, after the rota, this is a 1.5 bar, isn't it?
Yes, sir.
I mean, your lab broke down. It's very unfortunate. But clearly, there is more work to do before you stent it. Because you showed that there was there was that very tight lesion, which you dilated with a 2.5 balloon, right?
Yes, sir.
Now this RCA is much bigger than 2.5. Yeah, so if you look at your IVUS measurements proximally, it will be a 4 millimeter vessel.
We could get a 3.5 mm, certainly. Yes,
yeah.
sir.
So, I mean, if you looked at EL to EL, that is a 4 millimeter vessel.
True, sir.
And you did achieve a reasonably good MLA at the tightest segment. It was 5.82.
Yes, sir.
But remember that for a 4 millimeter vessel, 5.82 is quite a bit under dilated.
Certainly,
okay,
sir.
so I mean, we tend to do this. We think we are there, but still there is a little bit more to do. That is why people use other things, other devices to modify the calcium further. But it is a very difficult case. You had lots of challenges. So
certainly we could have done much better, sir. But given that we had limited visibility,
you had
we just achieved whatever we could.
Yes,
and,
I mean, I would, if I was in your situation, and if the patient was not having a lot of problems,
yes,
I would take your 1 second fluoro run, and if it is okay, then I would have, if it was TIMI 3 flow, I convinced myself, I would wait and transfer the patient to the other lab and do it like at leisure. Because that is very difficult to do, what you did. You did it, but it was very difficult.
Thank you, sir.
Thank you. Thank you very much, Dr. Advait. Excellent.
Thanks.
Now we have the last presentation. No, we have 2 more presentations. So this one is calcium modification by Dr. Gautam Kumar from Patna.
Good evening, everyone. It's my great pleasure being part of this event. Thanks for the opportunity. Respected dignitaries and my dear colleague, today I'm going to present calcium modification. As you all know, calcium troubles us a lot. Just by seeing this image, you can imagine how calcium makes our life miserable. You have balloon uncrossable lesion, balloon undilatable lesion, you have poor MSA, you have dissections, perforations, and you have underdilated stent thrombosis, poor MSA, poor outcome, more TLR, TVR, and poor overall poor outcome. So coronary calcium is interventionist worst enemy. It hinders stent delivery, limits stent expansion. You have more frequent and persistent stent malopposition. It limits effectiveness of balloon angioplasty, and finally it worsens procedural outcome. So all calciums are not same. You have deep and superficial calcium, you have concentric calcium, you have eccentric calcium, you have calcific nodules, eruptive, non-eruptive, and we have plenty of tools like rotational atherectomy, orbital, IVL. We have specialty balloons like cutting balloons, scoring balloons, and high pressure opium balloons. But calcium modification, in calcium modification, most works in most, but none fits all. So you may have to approach hybrid approach. This is a algorithm. We have several algorithms for calcium modification, but all algorithm starts with intravascular imaging. We have imaging criteria. If you have more than 360-degree arc of calcium, more than 270-degree arc of calcium.
We'll request you go to the case. We don't have much time. If you don't mind, please.
Here is the case example. This is a 70-year-old female with class 3 angina, and this is her angiogram. You can see significant mid-LCX as well as mid-LED lesion with moderate calcification. So a front rotablation was done. After a few runs of rotablation, we could manage to cross the lesion, which was followed by NC balloon dilatation and stented with 1 DES. Looking at the tortuosity of circumflex, we have decided to do halfway rota to avoid the complications, and we have had consider of unfavorable wire bias, so we did halfway rota ablation, followed by NC balloon dilatation and stent deployment. This is nice final angiographic result. This is another case, 63-year-old female presented with unstable angina. You can see a large chunk of calcium sitting in the proximal LAD. So upfront rotablation was done. After 2-3 runs of rotablation, we could manage to cross the rota bar. And after that, we did NC balloon dilatation. You can see NC balloon expands well, followed by stenting post-dilatation. And this is final angiographic result after 1 DES and NC balloon optimization. Here is another case of a 56-year-old male with class 3 angina. You can see distal left main and proximal LAD has significant lesion with a chunk of calcium sitting in left circumflex. So all angiography does not tell the full story. We have inapparent calcium, so we did IVUS. This is IVUS run. You can see fibrofatty plaque in the distal LAD. And 180-degree arc of superficial as well as deep calcium. Somewhere it is more than 270-degree arc of calcium. So we had decided to do shock wave balloon lithotripsy. All 80 pulses were delivered to the target lesion. You can save 20 pulses for if in case you have underexpanded stent. So here we had all 80 pulses delivered to the target lesion. This was followed by 1-to-1 NC balloon which was fully expanded. And this is post-IVL lesion preparation IVUS run. You can see some fractures, but in case of IVL, you may not get any fracture. There is micro fractures are there. It increases the compliance of the vessel. This was followed by LMLAD stenting with post-dilatation and proximal optimization of left main was done. Here is the final angiographic result after 2 DES and NC balloon optimization, and in the right panel you can see post-stenting IVUS run. Stent is well expanded with great MSA. This is last case, 65-year-old male with he had his PCI to LAD. He was hypertensive, reformed smoker, presented with low-grade non-STMI. You can see a large diffuse calcium in the right coronary artery. It is tram tract appearance. It was a microcatheter uncrossable lesion, so keeping microcatheter there, and we did direct wiring with rotafloppy wire. And in such scenario, don't waste time with balloons, just go with upfront rotablation. So we did rotablation. After 5 to 6 runs of rotablation, we could manage to cross the lesion. Follow rotablation, we did aperta balloon dilatation followed by a 1-to-1 NC balloon dilatation. Here you can see NC balloon expands well. So post-rota NC and cutting balloon dilatation, this is a IVUS run. We have fibrofatty plaque in distal LAD. You can see reverberation. This is suggestive of thinning of calcium, which we had prepared with rota, cutting and IVL. So reverberation is a good sign. You can see multiple fractures. So this is suggestive of that you have prepared your lesion well, and you can see NC balloon dilatation in 2 orthogonal view. If there is no waste, there is no dog boning, then you can proceed with stenting. Here you can see the fractures. Plenty of windows has been created. You can see the acoustic shadow behind the calcium, which was not visible initially. So it was stented with 2 drug-eluting stent in mid and proximal RCA. Was post-dilated. And this is nice final angiographic result. And this is post-IVUS run. The stent was well expanded with great MSA. So in conclusions, intravascular imaging is key. So you have to do intravascular imaging if you are going to treat calcium. So calcium modification strategy, intravascular imaging is must, and preparation is the key. In fact, for calcified lesion, preparation is angioplasty. If you have prepared your lesion, it is angioplasty. You have done your angioplasty. So it will prevent you from stent regret, that you have already put the stent without. So never do direct stenting. Always prepare your vessel. Appropriate tool for plaque modification is must. We have plenty of tools, so you can use depending upon the nature of calcium, and one size does not fit to all. So hybrid approach may be considered, and beware of rota regret in longer diffuse disease. Don't waste time with balloons. You will dissect the artery, then you will not be able to do anything. So go directly with rota. Consider temporary pacing in rota ablation of RCA, dominant circumflex, sole surviving vessel. You have low physiologic reserve, valvular, significant valvular lesion, so consider temporary pacing. Be prepared for all calcium related complications irrespective of the device you choose. So the take home message is preparation is angioplasty in calcified coronary lesion, and the final word is if imaging catheter crosses, shock it. If it can't, drill it. Thank you very much.
Thank you very much. We still have 2 more presentations, but your results were very good, and it's so gratifying to see the use of rota becoming more popular in Bihar. So we have next presentation in navigating through the tough stenosis, plan, prepare, and succeed. Dr. Shivendra Rai, is he here? No. So the last presentation of this session is by none other than Dr. Nishant Tripathy, calcium modification in complex PCI from preparation to optimal stent expansion.
Thank you, sir. At the outset, I would like to thank Shamshad, the organizing team of BIC. I think we have already seen most of the things, so it's almost repetition. We have come to the conclusion that calcium is one thing which is very difficult for everybody, and we have to be sure that we are doing the right thing in selection of cases and going for. This case basically summarizes all the problems that we face in calcium management. So this was a brief case history, and we planned PTCA of RCA. This is the different one, I guess. This case is different one that they have loaded. दूसरा केस है.
So just a comment, about the use of IVL and orbital. We recently had 2 presentations in TCT, I think, where they have compared high pressure balloon with these 2 calcium modification tools. The calcium modification tools were not superior. So any comments on that by the time he prepares? Are you ready with your? Yeah. Okay, so please go ahead then.
So by going, this was a different case that they have loaded basically. So, but patient profile was similar. This diabetic hypertensive male patient, heavily calcified TVD, and syntax score was 27 with comorbidities, diabetes, hypertension, and diffuse disease. So obviously we had to do an imaging and all those things. First we have to go for, just have a look at this angiogram. Similar to the cases that were shown, the first was RCA. For LAD we had decided that we'll go for rotational guided rotational atherectomy followed by stenting. RCA, our colleague was very excited to do just the distal RCA, and then we will proceed for the LAD. And this was a diagnostic angiogram from a radial approach. We tried an ad hoc basis of tackling RCA. That is not here, but we failed to cross the distal lesion, and there was no support from the radial route. Then we decided to do the procedure bifemoral on the next day. And this was the LAD. Again, the image shown by our previous colleague doesn't look like lesion, but on the left aleocranial view, you can see the tight stenosis, which is heavily calcified. And I will skip this. So this was the RCA. When we failed to do the across the distal RCA, on the next day we planned everything. We went with the IVUS femoral route and showed fibrocalcific lesion, diffuse disease, and you will get as the IVUS came into the mid RCA, there was heavily. This is the calcium part, tight lesion. At the maximum area, it was 270-degree calcium. So we decided with a cutting balloon atherectomy, what Dr. Pramod sir was suggesting. All the tools should not be used in all the cases. Just because you have seen calcium, you should not be doing all the you should not be taking out all the hardware. So we just did a cutting balloon with 315, and this is all. This is after a balloon cutting balloon atherectomy. Still, we were finding very difficult to pass on the stent. We took help of a guideliner to pass a distal stent, which was 2.5 into 32, and then a proximal stent was. So this was after stenting of the RCA. Obviously, there were underexpanded areas, which was post-dilated. This was after after stenting. Again, it showed a bit of under-expansion in some parts. So I'll quickly, but overall a good result, satisfactory MSA. We did a post-dilatation with 4 into 12 balloon, and this was the final result. So satisfactory result. Then LAD, which we had initially planned to go with rotational atherectomy, we wanted to do an IVUS first, but IVUS won't cross. Similar to the first case shown by Dr. Bhattacharya, IVUS just won't cross at this point. So we did a rotational atherectomy first. Then it opened up and see the calcium. It was dense, thick, and very long calcium. So we did an IVL to modify the result further. Placed a stent. Just to show that with calcium, you should not be very casual. So the learning from this case, for me at least, if it is an elective PCI, don't go for ad hoc PCI in a calcium if you are not ready with your hardwares. Just plan before starting any procedure, make available tools that may be needed, and take use of guide extension catheters, micro catheters to pass on your wires and tools, and get ready to face complications beforehand. Thank you.
Again, excellent case.
Just to summarize everything in one case.
Yeah, sure, absolutely, absolutely. So, any comments? Any comments?
One thing which I would like to ask in all these cases, what are the criteria when you decide whether I have to go by cutting balloon or we should take a rota or IVL? One thing for rota is sure, that is a balloon uncrossable lesion. But whether or not it will open by a cutting balloon. So any imaging criteria?
Yes, yes. There are many scores now have come up. After you do an imaging, you have to do an imaging. So in OCT, there is a rule of 5. If there is thickness of calcium more than 5, length of calcium more than 5, then you have to do some debulking. And if the arc of calcium is obviously more than 270, then you need some sort of debulking. If the arc is less than 270, length of calcium is not very much, then you can go with cutting balloon. But I think if we follow this principle only, if there is thickness of calcium and length of the calcium. If it is big vessel, very long segment of calcified disease, then you need some sort of debulking.
Because as sir said that in one trial it was shown that there is no benefit of all these modifying techniques. So apart from rota ablation where balloon uncrossable lesion, okay, then there is no other choice. But why not cutting balloon followed by a OPN high pressure balloon?
You know, you can say that about, based on those two trials, you can say that probably OPN and cutting balloon will produce the same result compared to IVL and orbital. But there is no trial comparing these, balloons, high pressure balloons with rota. So we cannot say about rota. Rota, like you said, an uncrossable lesion is the single most important criteria for using a rota. But people who do rota regularly, or people who do calcium modification by IVL and orbital, they feel that the life is much easier if you do it upfront. You know, rather than struggling with cutting, and then you have dissection, then you can't do rota. So again, I would say that it depends on your own experience, depends on the kind of work you have done. But we do, imaging makes a big difference. If you have done an imaging and you are sure that it doesn't fulfill the criteria, as Dr. Nishant said, we always try to start with cutting and high pressure and then go to stents. Any comments from you, Doctor?
Can you show this slide? This slide.
I think when the balloon crosses, then it opens up a lot of possibilities for you. So if you can pass a 2 millimeter balloon and dilate it, even if you are very good at orbital atherectomy, you need actually a little bit of dilatation, and you want your orbital bird to go distal to the lesion. It is much safer to do a retrograde than trying to force your orbital through a very tight lesion proximally, because the orbital is not front cutting. When you're taking it back, it is actually cutting while you're taking it back. So balloon crossability and balloon uncrossability, it is like it divides into two different. And the other thing is, you can have a lot of calcium, but your lumen may be actually quite not so bad. So if you have a 2 millimeter square MLA compared to less than 1.5 millimeter square MLA, that makes a difference, and that is in one of the calcium scores. So even if you have concentric calcium, but your lumen is like 3 millimeter square, you can get a balloon down. If it is concentric, you can take OPN-NC and crack it. It is very, very safe if you have concentric calcium to take a well-sized OPN-NC balloon and go up to 40 atmospheres. Nothing will happen to the vessel, because the concentric calcium will stop the vessel from rupturing. So these are things that you can do. And so far as cutting balloon is concerned, fibrocalcific is the best for cutting balloons. The only thing where all of these things, these balloons and these things don't work, is the calcific nodule. And there you need modification. There you need modification. If you have good wire bias, you can have a rota, or you can have an orbital atherectomy. Nothing will work in calcific nodule. It is the worst thing to have when you are doing these calcium cases.
So I think this slide basically gives you the summary, current consensus of how to deal with the calcium. So mostly it's only for uncrossable lesions you have to do rota or other atherectomy. With IVL,
Vital also, I have seen it crossing very well. Means it crosses very well, and then we can do the retrograde cutting. And the advantage is both antegrade and retrograde cutting. And the major benefit for orbital is the chances of getting stuck is very less.
Yeah.
That we have
actually it's
seen.
more of familiarity, I guess.
I think once you start using it more frequently, once your experience grows, you become more familiar with the device, then you use it more and more.
Yeah.
And the kind of cases which we have seen here, you can see that the growth of rota in all the institutions is improving. And I think that's a very good sign for the future.
Sir, as you rightly pointed out, it depends upon the experience of the operator and how he is comfortable with a particular calcium modifying device. But certain situations, as you pointed out, if it is not crossing, you have to go with either rota, because orbital is not a crossing device.
Right.
Or at times we may have to use the laser also. And I think another thing is, even if you see a calcium crack, it is not a guarantee that the stent will expand. So we have to put in the balloon and see whether the balloon expands. Once the balloon expands, then it is a guarantee that your stent is going to expand. Unexpanded stent in a calcific lesion is a catastrophe. It's a disaster.
Yeah,
Thank you. Thank you, Dr. Nishant, and thank you, everyone, the discussants, the presenters. It was a marvelous session, no doubt about it. And it just shows that how intervention cardiology is progressing in our state. Thank you, everyone. So the next session is on left main, another challenging part, left main and bifurcation. And moderator is going to be none other than Dr. Jabir Abdullah Kuti. Discussants, you will call them.
Thank you so much, sir. So moving on to the next, as I said, left main intervention and bifurcation PCI. We have the discussants. May I request their honorary presence on the dais? Dr. Sandeep Kumar, Dr. Jwala Kumar, Dr. Selva Bharti, Dr. Shishir Kumar, Dr. Ajit Pradhan, and Dr. Shaukat Ali, along with our moderator, Dr. Jabir Abdullah Kuti, please. May I request the presence of Dr. Anoop and Dr. Bipin on the dais, please, as a discussant. Thank you. Dr. Anoop and Dr. Bipin, please.
Good evening. So left main bifurcation intervention, this is the most difficult of all the subsets because the large amount of myocardium it serves or it supplies around 70% of the myocardial supply, blood supply is from the left main. The difficult anatomy and the outcomes, and if a target vessel failure occurs, it's a difficult thing to manage, and also patients develop the hemodynamic issues during the intervention. But we have traveled a long way, and with the current imaging, the current stenting technique, it is more or less equal in majority of the cases. The outcome is more or less equal in the coronary artery, equal to that of the coronary artery bypass grafting. I'll go show a first few cases and then we'll go. Move into the discussions. So this is a non-complex anatomy. So in left main, what I have to look at is whether the anatomy is complex, whether the anatomy is simple. In a non-complex anatomy, the intervention will also be non-complex. So this is a non-complex anatomy. You can see the left main has a disease, around 70% disease of the left main in the proximal and the mid shaft, not much encroaching onto the bifurcation. So we dilated it with a balloon and thought of crossing over from the left main into the LAD. So it's basically, we put a stent from the left main to the LAD, did a pot, and you can see the circumflex has a pinch. When the circumflex has a pinch, if it is a dominant circumflex, that is another thing that decides whether the circumflex is dominant, whether RCA has a problem or not. So when the circumflex has a pinch, most of the operators are a little bit reluctant to leave it like that. Many of the people, some of the older operators, they believe that when you put a crossover stent, it's always better to cross over to the circumflex and give a low pressure kiss so that the struts are opened up, the struts move away from the circumflex ostium, and later on, if they require an intervention, it helps. It helps for the, it helps in the vascular axis, the axis into the circumflex. So since there is a significant pinch, we thought we could do a tap. So this is the tap, again recrossing into the circumflex, dilating the circumflex ostium, putting the stent with one strut protruding into the left main, left LM to LAD stent, kiss, and the final pot, and you can see the result. Tap is not a very favored technique in left main bifurcation, and for that matter, many of the people, though it's a simple technique, many people now believe that it has some problem with the carina and it may not be an ideal bifurcation technique. But it's an important and an excellent technique when the angle is favorable. It is close to the, if the carinal angle is close to 90 degree and it's a provisional stenting where you have to bail out. And this is the follow-up. This is the proof. The proof of a good procedure is the follow-up. After follow-up, after 3 years, the left main stent is patent. And the Achilles heel is the circumflex ostium. Here the circumflex ostium is also patent and widely patent stent in the LAD. So this is one thing that we always look for, and this is one thing that we should always have. This is a patient with anterior wall MA. He was lysed elsewhere, and we took him up for a systematic early PCI. Again, it's a favorable carinal angle. The circumflex ostium do not have much disease. The circumflex is non-dominant, the relatively disease-free circumflex ostium. So again, left main to LAD crossover stenting. No, nothing. We didn't touch the circumflex ostium, and you can see after 5 years, the follow-up angiography after 5 years, it's okay. It's the circumflex ostium, some amount of disease, and down into the OM there is a tight disease without the patient is not much symptomatic. Let us leave him, and a pretty big LAD is flowing well, and the stent is patent. The two major stent technique in left main is a DK kilo and a DK crush. So how do you decide on whether we should go for a DK kilo or standard kilo, or it is a DK crush, which is the most favored technique when you go for a 2-stent technique in left main? Here you can see the circumflex angulation. It's a difficult angulation of the circumflex. The wiring is not that easy. And it's a very wide carinal angle. The carinal angle is even more than 100 degrees. So when the carinal angle is very wide and the carinal angle is less than 70 degrees, DK crush is the best option. So it's a wider carinal angle, especially when you have a difficulty in accessing one of the daughter branches. So the ankulator daughter branch is first tackled. So I think many of the people now consider that in left main, it is not a side branch and a main branch. It is mainly the two daughter vessels, which is of equal importance, especially if the circumflex is dominant. So it's a standard DK crush, and you use for crush, you use a good sized balloon. The balloon size should be at least 0.8 millimeter, 0.8 to 1 is to size of the vessel, and use a non-compliant balloon. If the crush, you feel the crush is inadequate, because this step is extremely important. An adequate crush is essential for the success of a DK crush. Then the first kiss, again the stenting to the main vessel, port, kiss, report, and this is the follow-up after 16 months. So look, I am showing cases where I have a good follow-up. That doesn't mean that all the cases will be like this. A large number of cases will come back with the problem at the circumflex ostium, and I believe that circumflex ostium is the Achilles heel of left main intervention. That is the area where the problem arises. That's why our thought process is changing. And imaging is extremely important for left main, and the recently only we have the imaging guidelines for left main intervention that was released in the last EuroPCR. So here after stenting, you can see the OCT is showing a well expanded stent with no complications, no edge issue, no lumen issue, and if you look at this is the ideal situation. This is the ideal situation. You can see the circumflex ostium is totally free of any stent struts across the circumflex ostium, and the circumflex ostium, the stent struts have been moved to the roof of the LAD, and it is free, and this is the ideal situation or the ideal result we should have, which usually impacts the long-term outcome. A 76-year-old male with LM bifurcation disease, and you can see there is something hazy at the left main bifurcation close to the circumflex ostium, or right across the circumflex ostium. It seems to be a calcific nodule. Do the OCT, or for that matter IVS, and you can see this. If you look at the longitudinal view lower down, you can see right now the calcific nodule that is protruding into the left main ostium, or it is just astride the circumflex ostium. These are dangerous situations, because this can produce problem. This can produce a carinal shift when you modify the calcium. So this patient requires an excellent calcium modification method. And previous discussion, you can see that there is a good lumen. This is eccentric calcium. He has calcific nodules. So we have two options, either orbital atherectomy or IVL. This was done when orbital atherectomy was not available to us. So we took the IVL, and after the IVL, we got some amount of calcium modification. Sorry, this is the IVL to the circumflex, and we did it to the LAD. And then You can see now there is some amount of calcium modification, some cracks in the calcium, and there is debulking. Actually, the calcium volume has come down, the lumen has expanded. Now, we did a Culo with the final kissing balloon dilatation, first to the circumflex, then through the circumflex into the LAD, then the port, then the kiss, and the final port. So this is the result. And it's not sufficient to do the pre-procedural imaging. You have to go for a post-procedural imaging to look at whether your procedure is optimal or not. There is some amount of some 300 microns malposition is seen, which is unlikely to be clinically relevant, or so we can leave it alone. And now you can see the circumflex ostium, which is widely open. Another case where you can see the bifurcation angle is quite narrow. It's around 60 degree or 50 degree bifurcation angle. A bifurcation angle of 50 degree or 51 degrees or less is an OCT criteria for likelihood, which increases the likelihood of a side branch occlusion. So narrow bifurcation angle and the size of the vessels are more or less equal. So we thought it is better to go for a DK Culo. So preparing the ankulated vessel, prepared it well and put a stent, then cross with the two balloons, the first kiss, followed by stent into the circumflex, then again a port, cross it, kiss, and followed by the final port, and this is the result. And you can see the OCT showing absolutely no struts across the circumflex ostium. The side so the daughter vessel ostium is free. So this is unlikely to produce a problem like a strut across the circumflex ostium, which can act as a nidus for further neointimal proliferation. So this is the DK Culo. You first put the stent, kiss it, the next stent through the other stent, again recross and kiss it, and the final port. And this is the result. So Europeans goes for Culo mostly. If you look at the EBC data, it is Culo is the most favored technique, followed by tap. But you look into the Americans and the Chinese, they do most of the DK crush trials, and even the Koreans. A 36-year-old male, ACS, FFR, LM to LAD 0.76. And a DES from LM to LAD, we did the port, the circumflex was recrossed, ballooned. And this is a new thought process coming at. Why do you want to increase the metal burden? Why do you want to have tackle both the vessels in the left main, in the circumflex and the LAD, when you have another option, that is the drug-coated balloon? So use a cutting balloon for preparing the circumflex ostium, and a drug-coated balloon was put. We did a kissing, and the current criteria or the current consensus statement, they believe that this kiss is not required, but port is required. This kissing balloon dilatation is not required at all. The port is required. So if you look at the OCT predictors of the side branch closure, I am doing more of OCT than the IVUS. What I have seen from the previous operators, I think it's more of IVUS here. A side branch angle of less than 51 degrees, and that is a carinal tip angle, and the BPCT, that is the branch point to the carinal tip. If that is less than 1.7, a short distance, the chance of side branch closure is high. So a pre-procedural OCT evaluation, you look at the carinal angle and the side branch, you can see what happens when the branch point to the carinal tip is small. The short length between the branching point and the carinal tip, the carina shifts and it occludes the side branch. So that is a problem, and in that cases we should be prepared for an upfront two-stent strategy. So this is the current intracoronary imaging guidance from the left main PCI. You do the pre-PCI planning, the landing zone selection, the stent length, stent diameter, plaque morphology for plaque modification. If it is calcific, fibrocalcific, then device, what devices should be used, what all things should be there in your toolkit. These all things are decided by the initial or the pre-procedural planning imaging technique, and the stent technique, which stent technique you should use. And the other one you can see, that basically tells, after imaging, if you find that this is a complex left main, if it is a complex left main, mostly upfront two-stent strategy. If it is a simple left main, it is a crossover or a crossover plus a drug-coated balloon. So defining the complexity variable, how do you assess the complexity? The most common used thing is now definition criteria, where the side branch lesion length, what is the length? If it is more than 10 millimeter, the diameter stenosis of the side branch is more than 70%, or in non-LM it is more than 90%, then there are many other minor criteria. So 1 major plus 2 minor is a complex lesion. It's extremely difficult to remember all these criteria. How many criteria can a cardiologist remember? Every day a criteria comes. But at least one thing, the length of the lesion in the side of the circumflex and the severity of the stenosis, then the reference vessel diameter and all. And if you look at the 4 techniques, the Q-load, T-stent, DK crush, SKS is not done nowadays unless it's a dire emergency where the patient is going to crash in an acute setting. So the Q-load, it is ankle less than 55 degree. The side branch is equal to the main vessel. So the circumflex size equal to the main vessel, then you go for a Q-load. Provisional, it is suitable for a provisional technique. Complexity, you have to do wire 2 rewiring 5 steps, 1 to 3 ports. T-stenting, it is side branch less than the main vessel, 90 degree ankle, provisional it is suitable, only 3 steps, it is quite simple. DK crush, side branch less than the main vessel, less than 90 degree. For provisional it is not possible, but you can go for a reverse crush is needed. But then it is complex, you need to experience a little longer learning curve. 2 rewiring, 2 steps and 1 to 2 port. So the LM stenting strategies, you can see provisional, no procedural complexity, contrast volume and timing. So in these 2 things, the provisional is better. And risk of carinal shift, the provisional is a problem. And efficacy in complex anatomy, the best is a DK crush. So more complex the disease, DK crush is the choice. Complex LM lesions, long side branch lesions, steep ankle. Then it is Q-load and then it is TAP, especially for a bailout strategy. So the practical algorithm is mandatory IVUS or OCT assessment. Simple or complex lesion, simple lesion, upfront 2-stent strategy. Complex lesion, it's a provisional strategy or a hybrid strategy. And a complex lesion, upfront 2-stent strategy, either DK crush or a DK Q-load. And DES plus DCB is another strategy you have to think. The EBC main has shown that the provisional is better because it was simple lesion. So both these group are right. The DK crush 5, the complex cohort, DK crush was better. So for a complex lesion, DK crush is better. For a simple left main bifurcation, always the crossover is good. So provisional wins in simple anatomy, DK crush is required for a complex anatomy. This is the data from our institution. What is happening 2020 to 2023? We did the bifurcation. 2-stent strategy, it was 164. Stent plus DCB was only 3. Now what's happening? It is 2-stent. 2024 to 2026 is 123, and stent plus DCB has changed from 5 to 124. This is what is happening. The 2-stent strategy is coming down. The 1-stent plus DCB strategy is going up. You can see the other one is coming down. That is the current scenario in many places. So this is my take-home message. Do the meticulous work before the PCI. Study the angiographic assessment, the imaging assessment, discuss with your colleagues, plan, think about the contingencies. How do you manage the contingencies? Every plan should be there in your mind and with your colleagues and the team. The entire team should discuss, sit down and discuss. Angio plus intracoronary image assessment, circumflex non-dominant lesion-free ostium, it is provisional. Circumflex non-complex hybrid approach, that is DCB plus a stent from LM to LAD. DK Q-load, if circumflex and LAD are of equal size with a narrow bifurcation angle and significant circumflex disease. Significant circumflex disease, dominant circumflex disease, unequal size of the daughter vessels, DK crush. And finally, if you ask me, what is the choice of 2-stent strategy in majority of the complex lesion? It is DK crush, which has got plenty of data also. TAP, if only the angle is favorable, non-complex disease, and as a bailout strategy. Thank you. Thank you so much.
Very nice presentation, Dr. Ravi. The 2 most important things in my view to take home message from your presentation is imaging is the must thing, and the port is the final we have to do in all the procedures, because without port it is not going to complete anything.
Even if you can't recross the side branch, do a port. so that your main branch will be better. The main branch will be preserved. But nowadays, I think with the two steps of balloon dilatation, the DK crush and the DK kilo, side branch, failure to cross the side branch has come down like anything. And what is here, the trend is that two-stent strategy coming down and DCB plus one-stent strategy going up.
Yeah, mostly say one stent. So I am asking that if you are going for provisional strategy and the side branch ostium is a minor disease or a normal, and after doing POT and everything post-dilatation, and if we don't intend to DCB to the side branch ostium, and our imaging shows some stent struts in the side branch ostium. So do you want to dilate it or do a kissing balloon?
It's a big question, very, very pertinent question. You do a crossover stenting, you optimize, you do a port, then do the imaging, and you are seeing a strut across or a connector across. If it is a connector across a side branch ostium, I would like to do a kiss and move that strut away, because we have seen in a good number of cases, we cannot see a large number of cases, it's only an observation, that this strut serves as a nidus for neointimal proliferation, and neointima deposits around that connector. And it divides the circumflex ostium into what you call something like two separate ostia finally, when they come back. So we would like to move the connector away.
So that will need 1:1 dilatation.
1:1 dilatation at a low pressure. Okay. At a lower pressure. It is something like a snuggle.
Okay, so after
just
that,
a soft, we call it a soft kiss.
So after that, no need for a DCB, or we can leave it that?
If there is no significant lesion, or to begin with, if there was no significant lesion at the circumflex ostium, especially when you do the left main stenting, it's always better to have imaging pullback from both the vessels, so that it can give an idea about the circumflex ostial disease. If no ostial disease, it's better to leave.
It has to be less than 50% then.
If it is dominant circumflex, I'll put a drug-coated balloon.
Sir, one question. You have told that you have shifted from two-stent strategy to 1 days plus DCB. After DCB, how will you proceed with kissing strategy?
Right. We can have for DCB, you can have two strategies. Upfront DCB into the circumflex ostium, then do the crossover stenting. And if there is nothing is happening to the circumflex ostium, leave it. Or if there is significant pinch of the circumflex ostium, two ways you can handle it. Either you can do a pressure wire and see whether the FFR is negative or positive. If the FFR is more than 0.8, don't touch. But seldom we do that. Though we discuss it very efficiently in most of the conferences, many of the people do not do that. That is a practical scenario. It's not easy to do things. Not only because of the technical difficulty, because of the cost also, it escalates the cost. The most important thing is, if there is significant pinch, ECG changes, chest pain, we'll cross and do it with a standard non-compliant balloons. Because the BIF trial, the last trial in bifurcation, the BIF protocol itself was like that. Provisional stenting, but that is not in left main, LAD-D1. They will put the stent across the main, stent into the main branch, across the side branch. If there is a significant side branch pinching, more than 70%, they'll cross over, prepare with a standard balloon, standard non-compliant balloon, put the drug-coated balloon, taking it through the stent struts, and then a kissing balloon dilatation with two non-compliant balloons and port.
That effect of the drug will persist in side branch?
Yeah, now the concept is changing. Previously we thought that if you are using a drug-coated balloon, that is the last instrumentation, no more instrumentation, it will take away the drug. Now the concept is, when your drug-coated balloon expands, the entire drug which is required for prevention of restenosis will be taken up immediately. It's a rapid transfer into the vessel wall and retention. Further instrumentation cannot affect the previously taken up drug. The concentration of that drug cannot come down because it has already, the maximum amount has already gone into the vessel wall.
Thank you, sir.
Thank you, sir.
We'll call our next speaker, which will be case presentation. And I'll request sir to sit on the desk. So, Dr. Sushil Kumar.
Good afternoon, sir. Basically, my case is very simple. Basically, it's a part of last lecture, DK clot. case summary. My case is 57-year-old hypertensive non-diabetic male came with chest pain for last 5 days. The ECG reveals NSTMI and echo findings are hypokinetic apex, distal IBS, and antral wall hypokinetic. LVF is 45% around. Then angiogram showing LED diagonal bifurcation lesion Medina 111. In view of good side diagonal and significant ostial disease, two-stent strategy was planned. Radial 7 French access was taken as per angiogram findings, and a EBU 7 French guide catheter was taken. Lesion was crossed with BMW and run through guide wires. And pre-dilatation done with 2.5 into 15 in both LED and diagonal. The stent of size 2.5 18 giants placed in diagonal, protruding 5 to 6 studs in LED. Then pot done with NC balloon with 3 into 15. Diagonal wire crossed to LED and other BMW wire placed in diagonal. The stent studs was opened with 2 into 15 balloon followed by 2.5 into 15 balloon. The first casing done with 2.5 into 15 in diagonal and 2.75 into 15 in main vessel LED. And then stent of size 338 placed in LED and diagonal wire remove out, followed by pot done with 3 into 15 size balloon. BMW wire placed in diagonal via LED stent struts. The final case done with 2.5 into 15 balloon and 3 into 12 size balloon in LED and 2.5 in diagonal. It's not working. And pot done with 3.5 into 15 NC balloon. I was imaging, so it's slightly less opposed. After I was, slightly less expanded. After this I was, with a proximal part slightly less expanded. Then we pot with and that's our final pot with 3.75 into 15 NC balloon, and it's our final result. The take-home message is double kissing culotte is simply classic culotte plus an extra kissing balloon expansion midway through the procedure that minimize stent distortion and reduce the risk of malopposition. The recent clinical data highlights a lower incidence of TLF when applying DK culotte over DK crus in complex left main bifurcation. From a structural point of view, the culotte technique might be considered as more physiological, as it ensures full coverage in all 3 segments, minimal or no new carina, no triple layer, and the tubular architecture of the stents is maintained. Thank you.
It's an excellent demonstration of the DK culotte because that vessel and that bifurcation ankle is ideal for a DK culotte. because you can do a DK crush also in that thing, but it will be a little difficult. But it's not for a tap. Will you consider, only thing is I may consider now, it's after doing drug-coated balloons for a long period, all complex subsets of lesions. Another option is using its smaller vessel, it's down the small size vessel, so both you can have a sequential drug-coated balloon application after preparing the lesion well. That is another option. It's an excellent, you have done it very well, and the demonstration is also good. The difference between the DK kilo and the standard kilo is, as you rightly pointed out, we have additional additional kissing. And this kissing helps the recross much better. And second thing is the protrusion is much less than the standard kilo. The standard kilo is like a 2 trousers. But now we protrude it into 3 or 5 millimeters into the main branch. We don't have a comparative data. Only thing is the Europeans are more fond of the kilo, and the other people are more fond of the DK crush. Any other comments? Any audience? Any comments? Dr. Shal.
DK culotte, that malapposition at the origin of the side branch, it is gone.
That ostium is well covered. The side branch ostium is well covered. Malapposition is not there. So it results most likely in less side branch ostial restenosis. The drug distribution is also better at the carina.
For this case, because we are more of a one-stent strategy people, but the lesion of diagonal, ostial diagonal, it was not that much well prepared, even after dilatation. So we planned that we will move on with a 2-stent strategy.
And not only that, it's a narrow angle, so the chance of the side branch occlusion is high. Yes. I think upfront 2-stent strategy in that particular case is it's a right approach.
Thank you, everyone.
Right. So, next is Dr. Saroj Mishra, left main dissection.
Good afternoon, everyone. Today I will discuss about a case left main dissection, which is a life-threatening complication. First, coming to case summary. Patient 55-year-old male with history of type 2 diabetes mellitus and non-hypertensive admitted with complaint of acute chest pain. EC shows T inversion is 2-3 AVF. His echo was normal. Then we planned for coronary angiography, which shows double vessel disease, and we planned for PTCA to RCA and LCX. This is the angiogram showing pre and post procedure of RCA angioplasty, and the result was good. Then we planned for PTCA to LCX and OM angioplasty. First we did wiring of LCX, and with second wire we tried to open the OM, but in between patient became symptomatic and acute chest pain occurred, followed by drop in BP and single episode of BP occurred. Then we took the fluoro shot. BP video. We took the fluoro shots which showed left main dissection extending up to OM. Then put one wire in LED for support and planned urgently to PTCA to left main to LCX. Quickly we implanted a stent of 4 into 32 mm from left main ostium to LCX, followed by we did the port with 4.5 mm balloon, and then we did the IVAS for proper assessment. IVAS shows malposition of left main stent, and we missed the distal dissection flap. Then we first tried to, then we planned for longer stent to cover the distal dissection flap and distal lesion, but unable to track it even after using guide liner. Then we put a DCB balloon for distal LCX lesion. Then again tried a smaller stent of 3.5 into 14 mm stent, but again we failed it. Then we again tried to post dilate the LCX stent, and again tried a smaller stent, but in meantime we lost the LCX guide wire. Running. Then we wired the LCX again, but new complication developed. A stent became deformed in proximal side after ballooning. Then we again put a stent of 4.5 into 16 mm through a stat and post dilated with 5 into 6 mm balloon. And this was the final angiogram of the cath lab showing TIMI-3 flow, and echo was done with no pericardial effusion, and patient was shifted to cath lab CCU. Then again after 1 hour patient became symptomatic and BP dropped. Then we did his echo which showed pericardial effusion, and after multiple attempts, we through echo guided puncture we just drained through apical site, and finally patient became stable, and patient is in our follow up and doing well. And this is take home message. We should do meticulous catheter engagement, and we should avoid roofing catheter into the vessel wall, and do not inject if the pressure is damped. And if there is coronary dissection is suspected, we should minimize contrast injection and stent the dissectors better quickly. Thank you, sir.
Great case. Really breathtaking, which is not good for the health of the cardiologist. Multiple issues you had.
Yes, sir.
I think it's basically a guide catheter-induced dissection, which happens to all the people who are doing intervention. Even if, even with the diagnostic catheters, we develop these issues. So the most important thing is never lose the wire. It's easy to tell, but it happens sometimes, especially during the pandemonium. If the patient goes into arrest, there is every chance that we can lose the wire. So that is one problem. Second thing is, in these type of cases, always use the stent which is the most trackable stent. Select the most trackable stent, whichever stent you feel that the most trackable, that stent with the size corrected to the distal circumflex or the distal vessels. Then yes, once you fix up the dissection's entry point, then it is easy. Then nothing will happen. Then you can cross over and do all these things. But even at the end, the stent doesn't look that good at the distal part. The proximal left main is okay. Did you do a kiss finally into the LAD?
No, sir.
We didn't see that.
No,
sir. Okay. No. It's most important thing is to keep the patient alive and send him home. No doubt about it. Any comment from?
The guide has to be properly hooked when we start doing angioplasty, and we should not lose the calm. And one thing is that everybody tells that don't let the wire come out, but it always comes out.
It always comes out. There is even most.
And when you say don't let it come, then it will always come out.
It all depends upon how you can keep the calm. If you don't shout at your colleagues, don't create panic, because once the chief operator is panicked and your team feels that the chief operator is panicked, then entire team will collapse. So keep your cool. You may know that sometimes we may lose the patient, but somehow you have to keep the calm so that your team will be comfortable and they'll help. Otherwise, they'll do all mistakes.
And one more thing is that when there is a dissection, choose a stent which is longer, so
yes,
that you cover more part. You cover proximal part also, and you cover distal part also.
Yes, sir.
Always take 4-5 mm more or 6 mm more.
Longer,
yes,
right thing. Longer stent, the most trackable stent. Because you don't have time. Somehow you have to seal the proximal, because it's a huge left main, and he didn't have much disease of the left system except for the circumflex. Luckily his RCA was a big, and the RCA lesion was
tracking
tracking
that when you have to cover the ostium of the left main, you take LAO-cranial view, then you see properly whether it is at the ostium, exact ostium or not. So LAO-cranial view is the best view for left main ostium.
Another thing is, when you are not able to cross or the stent is not going, try to pass in an IVUS catheter and see what is the real issue.
Yes, sir.
The IVUS catheter may go and you will get an idea what it is. Once you are guided, because you have now you have sealed the proximal dissection, you don't have to worry, you have time.
Thank you, sir.
LMCA bifurcation in a critical ACS patient, Dr. Pramod Kumar.
Good evening, everyone. I would like to thank EVC team for giving me this opportunity. So in next few seconds, we are going to discuss about LMCA bifurcation in critical ACS patient. So coming to the clinical profile of the patient was 65 years old female with history of diabetes and hypertension, history of COPD, admitted with complaint of severe chest pain since last 8 hours. The vitals, the heart rate was around 100 per minute, the BP was 90/70 on NORAD support, the saturation was 94%, the patient was on CPAP support, and patient was in CLIP class 2, having bilateral course grafts in. In investigation, the patient having hemoglobin 10 gram, the creatinine was 1.5. The ECG was showing anti-wall MI. In echo, there was RWM in hereditary with moderate LV systolic dysfunction with LVF of 35%. So we took the patient for CAG, and in CAG we found the ostial LAD was almost 95 to 98% stenotic. The distal LMC having mild plaque, and the LCX having proximal LCX 90% stenosis. The RCA was dominant and was normal. So we'll see in the next video. This was the epicardial view, angio. The ostial LAD was almost 95 to 98% stenotic. There was distal TIMI2 flow in the LAD. The proximal LCX was almost 90% stenosis, and in the distal LMC there was mild plaque. The RCA was normal, it was dominant. So in this case, we decided to go for dedicated bifurcation standing DK cross. We taken the EBU through transfemoral route. We pre-dilated the LAD and LCX with 2:10 and semi-compliant balloon. There was thin caliber ramus. Ostial ramus was around 80%. So we tried to preserve the ramus also. So we pre-dilated the ostial ramus with 2:10. Then we taken the Nagumi stent 2.75:28 in the LCX, keeping 2 to 3 mm in the LMCA, and did the crossing with the NC balloon 3.5:10. Then we removed the balloon and wire. Then we recrossed through the proximal strut of the LCX, and we did the first kissing inflammation with 3:10 in the LCX and 3.5:10 in the LMCA to LAD. Then we taken the 4:28 Nagumi stent from mid LMCA to proximal LAD. Then we did the post dilatation in the distal LCX. And then we did the second kissing with 3:10 NC in the LCX and 4:10 into the LED. We did the dot with the same 4:10 and say in the digital LED stand. Then we did the final pot with the 5:10, keeping the dot just at the carina, just above the carina. So this was the final result. Both the LED and LED LCX stent are well opposed. The main part was the post-PCI patient had renal failure, serum creatinine raised from pre-PCI 1.5 to 2.4, then 1.6, then 1.2. The hemoglobin dropped to 9. Patient having initial right side proliferation which improved subsequently. The BP improved to 130/70, ejection fraction improved to 45%. So in this, my case, the take-home message, intracoronary imaging is considered to be provide gold standard guidance for complex bifurcation LMCA PCI with evidence demonstrating superior result to angiography alone. However, in my case, patient was hemodynamically unstable, so I prefer to simplify the procedure. Mechanical circulatory support is worth for complex case where there is no other option but to do the case. And post PCI period is very crucial to win the war after the winning the battle. Thank you. Syntax was less than 23. Patient was, ACS patient was complaining of recurrent chest pain, sir. So we instantly have to go for plastic.
After push, in last slide, probably when you have done pot, you cross the L6 ostium.
Shoulder was crossed, sir. The dot was just.
Please show me.
Very nicely done.
Last
Dr. Pramod. Because your patient was hemodynamically unstable on inotropic support. BP was just 90. Patient was
True problem was this.
Cross the ostium, no?
Actually, the proximal part of the LMCA stent was just around, sir. We taken the minimum length, that is 8 into 10, what we have available that time, sir.
It's okay.
Yeah, sorry.
I would prefer to do IVUS in this case because of two things. One, I can reduce the amount of contrast in an acute coronary syndrome patient where the contrast volume, increase in contrast volume can lead on to renal dysfunction. So IVUS will not take much time. The current IVUS, you can rapidly go in and come out. So IVUS is sufficient, and IVUS is the best predictor. One of the, we have data on IVUS only regarding the prediction towards further outcomes for target vessel, target lesion failure. In acute coronary syndrome, if it is acute coronary syndrome and a thrombus burden is high, I would always opt for the simplest procedure, a crossover from left main to LAD. And if everything is fine, I may wait and call the patient back after 2 or 3 days for completing the bifurcation procedure. Because here the circumflex is big, tight lesion. Or I may go for a TAP. Of course, TAP is not the ideal thing. You have done a wonderful case, no doubt about it. It was good and well done and an excellent result, no doubt. But in all situations of acute coronary syndrome, we may not be able to go scot-free like this. If he develops a slow flow, we are in trouble. We are in trouble. And the MCS, the only MCS available to majority of us is the we have this thing. We don't have Impella. We have only this thing, IABP. Impella is beyond most of our people's imagination. IABP, but sometimes it helps, maybe in certain cases, and the IABP is may be required for only a short period of time. If there is a significant LV systolic dysfunction, and the RCA is disease, I may prefer to put in the IABP prior to the procedure and do the procedure. But here the RCA was good, the LV function was reasonable. It was around 40%, which improved to 45% ejection fraction. What is your opinion? Will you do an IVUS in this patient? If there is no IVUS facility, I'll go for the best dilatation possible and the best port possible. Okay. Because even after IVUS, these are the things that we are going to do. And to reduce this problem of port issue, we can use a port balloon, but the port balloon itself costs 50,000 rupees.
Yeah.
It doesn't have the overhang.
So one more question, sir. The second recrossing should be done from distal strut or from proximal strut?
For DK crush, it is the non-distal strut. It is the strut which is a little away from the carina. The mid strut, we call it as, it is neither the proximal nor the distal. Anyway, it should not be the distal one.
Actually, sir, the new EVC guideline, they told that the first wire recrossing should be done through proximal strut, and the second recrossing should be done through the distal strut. So I want to confirm from you.
Right. The October trial and all, they all went for the non-distal cross. Non-distal cross.
Thank you, Dr. Pramod.
An excellent case. Just one point to make.
You want to make a comment?
Yeah.
Yes, go ahead.
Sir, when we saw the first angiogram, LCX ostium was, I think, it's okay.
It is okay, but down
so in an ACS patient, could we have done left main to LAD, let the patient stabilize? Later on, we would have done distal stenting LCX and left away.
That's an option.
That's an option. Yes.
Another option is,
because
another
ostium
option
was okay. LCX after ostium, there was a good gap. And then there was almost 90% lesion.
I agree with.
And there is another option. You could have stented the left circumflex with a short stent because that ostium is disease free, and a crossover stent. We can call the patient back after 2-3 days, do a re-angio and see.
So same point I was making. So one, these port balloons are very, very effective. Especially in these kind of left main, if you have 6 mm, 5 mm port balloon, they work exceptionally well. And second, like I said, in all ACS conditions, left crossover LMLD always works. Though it was a well done case, but IABP support and provisional stenting would have helped if the patient develops slow flow, something like that. But you did it case very well. Thank you very much.
Okay, thank you, Dr. Pramod. The next case is left main PCI post CPR as bailout. Dr. Deepak Kumar, please.
Good evening, sir, and good evening to organizing team for giving me this opportunity. My topic is left main PCI. Sorry. Yeah. Next. So my topic is osteal left main PCI in a post CPR patient as a bailout. So he was a 50-year-old gentleman, non-diabetic, non-hypertensive. There was no significant risk factor like family history for CAD, and he presented to OPD for cardiac opinion. He developed sudden cardiac arrest in the waiting area. CPR was started by cardiac team. While doing CPR, he was shifted to our cath lab. And this was the ECG, suggestive of global ischemia and bradycardia. So I did the temporary TPI. Patient was having similar episode of syncope for 15 days. He was taken consultation from physicians. He was sent for evaluation of syncope. Previous investigation, he was having normal, suggestive of normal to echocardiogram, normal biventricular function. Trop was negative. His baseline ECG was normal, sinus rhythm, and hemoglobin creatinine within normal limit. So patient was shifted to cath lab, TPI done, and angiogram was done through right femoral route. And this was the angiogram. First one is caudal view, and the second one is So the first one is ये first one. This one. Yeah. Yeah. So this was first one is caudal view, and the second one is a plain AP, and that's suggestive of ostial left main 90 to 95% seen in AP view. So my plan was to do single stent strategy, provisional stent. So the loaded with ticagrelol and unfractionated heparin 75,000 unit given. Then my plan was to take gel catheter and to wire both LAD and LCX by Sion blue wire, and to wire one LAD and one LCX path, and I took a 3.5 cross 20 mm stent from the ostial left main to LAD in AP view, and a stent position done in AP view for brief period to avoid the global ischemia. And then there was slow flow noticed, so I reverted with intracoronary adenosine and CCV because I was having luxury of this TPI in place. And cranial view taken, and this left main is okay, everything is okay, Timothy flow assumed, but there is still, sorry. Okay. So then in mid LAD segment there is critical, is still significant stenosis seen. So another stent of size 3 cross 20 mm taken, and it deployed up to 14 ATM and TME3 flow achieved. So after on follow-up, I noticed there is huge external hematoma since tyrofevan and many anticoagulant, this tyrofevan, heparin and all was given, and so many times of CPR was done. So this external hematoma evacuated by incision and drainage, and this patient is doing well, no symptom, ECG is normal right now and having normal biventricular function. So even after 14 months of this procedure, still he is on ticagrelol and he is doing well. So this is ECG at the time of discharge. So the take-home message is, in this case, take a gel catheter. Coaxial alignment of guide is important to minimize the ostial injury and avoid deep guide engagement. Brief checking is required, and the balloon dilatation, stent dilatation by balloon should be very brief to avoid the global ischemia. Side hole catheter should be avoided so that the false sense of pressure and the injection time should be minimized, and the procedure time should be also minimized. Thank you, sir.
Great case, and you really saved the life of that patient. So what was the blood pressure at the time of procedure?
It was 80 by 60.
80. So did you think of IABP?
I was not, actually this patient was just in front, fell down in front of my OPD. So just I took this, within 5 minutes everything was done.
Right, absolutely, excellent.
So,
These type of situations where the patient develop acute left main occlusion, cardiogenic shock, get in quickly, get out quickly. No further beautification. It is you have to obtain a TME3 flow into the LAD, and then further medical support and all further beautifications later on. And the patient can go for even a surgery afterwards.
And even after this 1.5 years, he is totally in NYHA class 1. He having no symptom and nothing.
Right. You can go for a reduced dose of ticagrelor, 60 milligram twice a day with aspirin.
Even right-sided angiogram was not taken at that time, and I'm not having any.
No, now you can take a re-angiogram and see how your stent do.
Thank you. Thank you.
Next is Dr. Meetu Kumari. she'll be talk on halfway done kilo completed after 5 years. I think that caption itself gives us an idea that in left main, at times, we may do a partial procedure to keep the patient alive. If you go on doing for beautifications in an acute setting, it can create a problem. You save the LAD, establish the flow into the LAD, save the patient, then you have multiple options. You should not lose the patient on the table, that's all.
Respected seniors and dear colleagues, today I will be discussing an IVUS-guided PCI of...
Could you move a little towards the mic? We can't hear you.
Respected seniors and dear colleagues, today I will be discussing an IVUS-guided PCI of LAD D1 bifurcation lesion done at our center last year. It has been named a halfway done culotte completed after 5 years. A 46-year-old male presented to us with unstable angina, and he had past history of PCI to diagonal for lateral wall myocardial infarction 5 years back. He had recent onset rest pain and history of exertional angina for last 3 years. Echocardiogram showed LVEF of 45% with regional wall motion abnormality in anterolateral wall. Previous PCI record showed stent size of 3 into 23 mm implanted in 2020, and no history of being a drug defaulter was there. So coronary angiogram was done, which showed revealed a bifurcation lesion of Medina 111, for which IVUS-guided PCI was planned. These are the angiogram of the patient we did for treating the patient. Coronary angiogram revealed a left dominant circulation with a diagonal stent ISR critical stenosis with lesion in the left anterior descending artery at bifurcation, also with distal circumflex with non-critical stenosis. So he was planned for IVUS-guided PCI, and IVUS of left anterior descending artery revealed diagonal stent struts in main vessel nearly 2 mm producing significant size mismatch and a nidus for ISR. IVUS-guided PCI was started with a 7 French femoral axis under ultrasound guidance, and left main was hooked with 7 French extra backup guide catheter. Left anterior descending artery was wired with run-through wire, and IVUS was done, which showed diagonal stent in main vessel lumen and wire going through the lumen looking like a side branch stent placed in culotte stenting technique. Then stent struts were opened serially by 215 followed by 315 mm balloons. Then diagonal was also wired with BMW wire, and stent ISR was serially prepared with 2 into 15 mm balloon at high pressure followed by 3 into 15 mm Wolverine cutting balloon. After diagonal preparation, there was a significant plaque shift in LAD leading to no flow and chest pain, which improved after balloon dilatation of main vessel again, but led to plaque shift in diagonal. Then a KBI was done with 3.5 into 12 mm and 2.75 into mm in main vessel and diagonal respectively, after which flow was regained in both. LAD was stented with 3.5 into 34 mm drug-eluting stent followed by proximal optimization by 4 into 8 mm balloon. Then diagonal was recrossed through stent struts, and struts were opened by 2.5 into 15 followed by 2.75 into 15 mm balloon, after which significant plaque shift and impairment of flow was seen in main vessel. Again, main vessel was post-dilated with 3.5 into 12 mm balloon at high pressure, following which plaque shift was again seen in diagonal, for which repeat KBI was done. Finally, after alternating vessel plaque shifts, it was concluded to aim for good stent area in main vessel and a flowing diagonal, for which LAD was adequately post-dilated with 3.5 into 12 mm balloon at high pressure, followed by a final KBI with 3.5 into 12 mm and 2.75 into 15 mm balloon in main vessel and diagonal respectively at high pressures. At last, a final pot was done with 4 into 8 mm balloon, and final IVUS run was taken. Final IVUS run revealed adequate stent expansion and apposition with a very good MSA of 11.5 square millimeter at bifurcation side, 14.2 at proximal, and 10.2 square millimeter after diagonal. Final result and take-home message. Final shoot revealed good flow in LAD and TIMI3 flow in diagonal with non-critical residual lesion at its ostia. We learned that side branch ostial stenting is a myth and will always lead to stent protrusion in main vessel and further ISR leading to occurrence of lesion in main vessel. Initially, it was planned to do a drug-coated balloon angioplasty in diagonal and stent in the main vessel, but due to recurrent plaque shift, it was not done. Thank you.
Excellent. Excellent case, well done. And so initially it was only the diagonal issue for which a diagonal stent was put. And currently if there is only diagonal ostial disease, most of the people believe that well prepared, if we can prepare the lesion well without much residual stenosis, if it, after preparation if it is less than 30% residual stenosis, we can go ahead with a drug-coated balloon which can avoid these type of mishaps. And as you rightly pointed out in your slide, precision stenting at the ostium or precise ostial stenting is a myth. Majority of the time, either it undershoots or it overshoots, especially LAD ostium. So this patient, you have done an extremely good job to the LAD. That diagonal ostium is still, it has some disease and some pinch. So why didn't you consider ostial preparation with that cutting, that you use the Wolverine? But I didn't see you cutting the ostium. Did you really cut the ostium well? So when you use the cutting balloon, from the lesion's distal edge, you have to come millimeter by millimeter forward. You have to use multiple cuts, very slow. 2, 4, 6, wait at 6 atmosphere, go to 10 atmospheres, and then cut the entire area, prepare well, and you could have used a drug-coated balloon here, up front. Then put the LED stent. Any take on that, opinion on that? Because it's a big diagonal, you cannot lose that diagonal. And he has only one diagonal, below that there are no diagonals. Any comment from the audience? Okay, thank you.
Next speaker, Dr. Shashank on left main bifurcation.
Good evening, everyone. I would like to extend my thanks to the whole BIC team and especially to Dr. Nishant Tripathy sir and Dr. Ashok sir for providing me this opportunity to present this case. So I will be presenting this. This is the patient, 66-year-old male patient, hypertensive diabetic dyslipidemic, presented with chest pain. He was diagnosed as N-STEMI and coronary angiography revealed triple vessel disease with LM disease, but this was done like in the year 2024. This was the ECG in the year 2024. You can see diffuse disease RCA, distal part is not getting filled. Again, you can see limb disease along with diffuse disease LAD. After this angiography, patient was advised for coronary artery bypass graft 2 years back, but the patient was like he was not ready for bypass. So the patient again presented in the year 2026 after 2 years. This time he presented in pulmonary edema. Patient was intubated and put on invasive ventilation, and the patient was extubated and check angio was again done. This was the X-ray this time with the presentation of pulmonary edema. This was the ECG this time. More or less the disease remained the same. You can see a diffuse disease RCA with CAD TVD with LM disease. So what we went up with PCI of LM bifurcation, PCI. This was the IVUS run test that was taken before the PCI, which clearly shows a fibrocalcific disease extending up to the LM. So using a cutting balloon of 310 Wolverine, it was done to proximal LAD. The side branch, that is a high OM, it was treated with 2.515 NC balloon. And we decided to go with mini crush technique. And the stent that we took was 2.538 in the side branch and a 3.548 in the main vessel. That's LM to LAD. So after deploying both the stents, we did a pot with 4.5 by 6. Then using the 3.5 by 8 balloon, we did the post dilatation to the LAD, and using the same balloon, we did the KBI. After it was another IVOS run was taken. So we were not very happy with the results, so we did another post dilatation using a, actually it's misprinting 4.5 by 8 NC balloon in the main vessel. And this was our final result. This was our final result. That's all. That's it. Thank you, sir.
Why you have selected mini crush?
So since this time after 2 years, the patient was not in a very good hemodynamically stability concerning, and we were like apprehending the procedure time would be longer if we would have taken that decay crush. That's why we opted for a mini crush technique.
Problem with mini crush is all the previous data shows that the chance of recross failure, the failure to recross is higher with the mini crush than with the decay crush. So that's the only problem. And when we crush, usually in the decay crush also, when we crush, it's better to use a longer balloon. Otherwise, if the balloon slips off proximally, then it may not re-enter because of the stent struts. So always use a little longer balloon, and sometimes we may have to use another balloon. But mini crush, you have crushed it with the stent rather than with a balloon,
Yes,
isn't
yes.
it? You crushed it with the stent. Recross may be a problem.
Yeah.
That is why people have shifted towards the decay crush. So that's the evolution of the crush. We started from the simple crush to the mini crush, then to the decay crush, and sometimes for a bailout procedure, a reverse crush also. I don't know in future whether there will be the crush techniques. The crush techniques are all coming down, or whether it bounce back after 5 years. Only time can tell. Thank you.
Thank you, sir.
Thank you.
It is a fantastic session. I think all wonderful cases, great cases, and the most difficult subset of the patient, the left main, because that is the most hemodynamically difficult subset, anatomically challenging, and it puts a tax or a toll on the operator, because the operator and the team is fully on the toes, because one or two of the cases were hemodynamically unstable patient with a large left main, a large LAD and circumflex. This is one of the toughest terrain on which the intervention is walk. And I'm sure, what I have found is that people are doing an extremely good job meticulously preparing the lesion, assessing, selecting the technique, and doing it in the perfect way. Good, thank you. We all have learned a lot.
Thank you, esteemed dignitaries. With this, as of now, we'll pause with the technical session. Quickly, we'll have the stage setup. So we'll take just a 5 minutes break for the stage setup, and then we'll have the inaugural session for the BIC. Kindly bear with us.
We will request everyone to hold on here for the inauguration session. After inauguration, we will move on to the peripheral intervention session.
And for this, may I call upon Dr. Sanjeev Kumar, Professor and Head of Department, Cardiac Surgery, AIMS, Patna, and he's also the President of CSI Bihar, to kindly come on stage and invite the dignitaries on the dais, please. Requesting the honorary presence of Dr. Sanjeev Kumar. ladies and gentlemen, kindly give us 2 minutes. Yeah.
सर बुलाएंगे सर। हाँ हाँ ठीक। So we have the privilege this evening to have our chief guest, none other than Dr. Shashi Shekhar Chatterjee. May I request Dr. Pramod Kumar sir, Rajing Chairman, to please accompany Dr. S.S. Chatterjee to the dais, and both of them please take your seats. Then my call is for the famous and one of the pioneer pediatric cardiac interventionist, Dr. Krishna Kumar R from Kochi. This evening he is our guest of honor. May I request Dr. Shamshad Alam to please accompany him to the dais. Now I request this conference backbone, our organizing chairperson, the famous cardiologist and one of the pioneer in doing the complex cardiac interventions, Dr. Pramod Kumar from Medanta Hospital, to take your seat on the dais. Dr. Ashok Kumar, our secretary, CSI Bihar chapter, is probably not here. So now my call is for our one of the senior most cardiologists, Professor Dr. U.C. Samal sir, to come on the dais. I request Dr. Arvind Kumar to please accompany the legend of cardiology in Bihar. His life itself is a message. So Dr. Shamshad, my call is with respect Dr. B.P. Singh sir, the former professor and head of the Department of Cardiology at IJMS, and is a vital role in establishing interventional cardiologists in Bihar. Dr. Shamshad, please accompany him to the dais. Now I will call the man who has planned these scientific sessions so meticulously and so useful for everybody, the cardiologist, interventional cardiologist from Medanta Hospital, Dr. Shaheen Ahmad. Please come to the dais. Dr. Shaheen Ahmad has worked with me earlier as an assistant professor in AIIMS Patna also. So it's a pleasure to have you on dais. Now my call for the two jewels of Bihar, who is the members of the National Executive of CSI. One, our former President, Dr. Arvind Kumar. May I accompany you to the dais? And Dr. B.B. Bharti. Bharti, sir. He is also the member of the National Executive of CSI, National CSI. Before I take my seat, I request the Dynamic Organizing Secretary, Dr. Shamshad Alam, to please come and take your seat also. Now, it's a pleasure to see Dr. Ravi Kumar Singh, the MD of the Medanta Hospital, Patna. We request your presence for inauguration also, sir. Please come. It's a pleasure always to spend time with you. Before I take seats, and now hand over to
At last, I will invite Sanjeev sir, who is President CSI Bihar. Sir, chaliye.
Thank you so much, sir. Now, for the formal inaugural of the scientific congregation, let us invoke wisdom, knowledge, and enlightenment. May I now request our esteemed dignitaries for the ceremonial lighting of the lamp, followed by the Saraswati Vandana. I would request all the dignitaries to kindly join us for the lamp lighting.
Ya kundendu tushara haradhavala Ya shubhravastra Ya veena varadanda manditakara Ya shveta padmasana Ya brahmachyuta shankara prabhrutibhi devai sada vandita sama patu saraswati bhagavati nishesha jadya paha Shuklam Brahma Vichara Sara Paramam Adyam Jagad Vyapinim Veena Pustakadharinim Abhayadam Jadandhakara Paha Haste Sphatikamalikam vidadhatim
Thank you so much, sir. Now, may I request our organizing secretary, Dr. Shamshad Alam, for a floral welcome and a presentation of memento and shawl to all our esteemed dignitaries on the dais. May I request Dr. Alam to present the bouquet and the memento. To our chief guest, Dr. S.S. Chatterjee. To our guest of honor, Dr. Krishna Kumar. To our organizing chairman, Dr. Pramod Kumar. Now to our organizing chairman, Dr. Pramod Kumar. Now to our President CSI Bihar, Dr. Sanjeev Kumar. Now to our Chairman, Scientific Committee, Dr. Shaheen Ahmad. Now to our esteemed guest, Dr. Ravi Kumar. To Dr. Arvind Kumar. The memento that is being presented is the famous folk art of Bihar, which is called the Tikuli art. That's an appreciation to our guest on the dais, so that they remember the folklore of Bihar through this. Now to Dr. UC Samal, sir. To Dr. B.B. Bharti. This to Dr. B.P. Singh and to Dr. B.B. Bharti. And at last but not the least, may I request our President CSI Bihar and also the Professor and HOD Cardiac Surgery AIMS Patna, Dr. Sanjeev Kumar, to kindly felicitate our Organizing Secretary, Dr. Samshad, please. Ladies and gentlemen, a huge round of applause. This takes a lot of effort to organize such kind of event. Yes, the memento is the Tikuli art, and the shawl has the Madhubani painting instruction on it. Thank you so much, sir. Now may I request our organizing chairman, Dr. Pramod Kumar, for his welcome address, please. Dr. Kumar.
नमस्कार, बहुत बहुत आप लोगों का स्वागत है इस बहुत ही इम्पॉर्टेंट मीटिंग में. It gives me immense pleasure to welcome you all to this 4th edition of Bihar Intervention Council meeting. This 2-day conference is a testimony to the growing importance and need of such meetings. I consider myself blessed for having witnessed the growth of clinical and interventional cardiology in my state. from a single cath lab started by my good friend Ajit and his late father, it has now grown to a healthy 40 cath labs in this state. It's a very encouraging scenario, but puts enormous responsibility on everyone who is practicing cardiovascular medicine. These meetings are vital for our training, our skill development, and most important, our patient care. The eminent speakers from all over the country have gathered here and will be sharing their insights and experience with us. It's a great opportunity for all Biharis, and we are grateful to the CSI for providing us this opportunity. I welcome you all again for a very fruitful second day, rest of the day today and second day tomorrow. Thank you all for coming.
Thank you so much, sir. Now for the welcome address by the Chairman Scientific Committee, may I request Dr. Shaheen Ahmad for his address, please.
Respected dignitaries, the masters of teachers, our teachers, seniors, colleagues and juniors and fellows, very good evening on this 4th annual conference of Bihar Intervention Council 2026. In the last 1 decade, cardiology, especially intervention cardiology, including pediatric and adult, has progressed a lot. And so we are also, but in Bihar we are progressing with the natural pace, and we are competing with the pace of national cardiology progress. But hope so, we are on the right track. And with this aim, we have planned this 4th annual conference in the guidance of our Pramod sir as the organizing chairman and the hardworking organizing secretary, Dr. Shamshad Alam. So on behalf of organizing committee, I welcome you all to enjoy the extravaganza of this scientific program, teach each other, learn from each other, and enjoy the hospitality of our organizing secretary, Dr. Shamshad Alam. Thank you.
Thank you so much, sir. Now for the inaugural address, may I request Dr. Sanjeev Kumar, President, CSI Bihar, to kindly say a few words.
शुक्रिया। CSI बिहार चैप्टर की तरफ से आप सभी लोगों का, खासकर बाहर से आए मेहमानों का बहुत बहुत स्वागत। बिहार चैप्टर के प्रेसिडेंट के रूप में इससे बड़ा गिफ्ट क्या हो सकता है जो हमारी टीम ने आज दिया मुझे। डॉक्टर प्रमोद सर, डॉक्टर शमशाद और डॉक्टर शाहीन अहमद की टीम ने इतना बढ़िया इंटरनेशनल कार्डियोलॉजी का कॉन्फ्रेंस किया, और जिस तरह से आज दुनिया में एज ए कार्डियोलॉजिस्ट और कार्डियक सर्जन 2 चीज़ें हम लोग मानते हैं। एक दुख की चीज़ ये है कि कार्डियक एलिमेंट्स और एक्यूट कोरोनरी सिंड्रोम या सडन कार्डियक डेथ की संख्या बढ़ते जा रही है। खासकर पोस्ट कोविड सिनेरियो में ये संख्या पूरी दुनिया के साथ साथ हमारे देश में ही बढ़ी है। और खुशी की बात यह है कि तकनीकी रूप से आज तकनीक के समन्वय से हमारे कार्डियोलॉजिस्ट इतने आगे बढ़ गए हैं कि जटिल से जटिल और कठिन कॉम्प्लेक्स डिजीज़ के भी इलाज बिना ऑपरेशन नहीं कर सकते हैं। तो ये कार्डियक, एज ए कार्डियक सर्जन, मैं कार्डियक सर्जन हूँ, तो कार्डियक सर्जन के लिए कई बार बोलते हैं कि आपकी स्थिति कमज़ोर होती जा रही है, तो ऐसे नहीं है। हम संकट के समय याद किए जाने वाले हैं। आज स्पीकर्स ने ही बोला कि बैकअप सर्जरी की ज़रूरी है। तो ये जो टीम वर्क है, इंटरवेंशन में बिहार इतना आगे बढ़ा है, ये हम सब के लिए गर्व की बात है। और इस गर्व के क्षण को आज इतना अच्छा मूर्त दिया है इस ऑर्गेनाइजिंग कमेटी की टीम ने कि हम लोग बहुत खुश हैं। उनको भी बधाई और आप सब लोग का पुनः स्वागत।
Thank you so much, sir. Now to share his insights and words of wisdom, may I request the honorary presence of our guest of honor, Dr. Krishna Kumar, to kindly say a few words. Sir, the podium is yours.
Thank you. Thank you. Again, thank you for this invitation, and I'm very pleased to be here and meet up with some of my old friends. The one thing I wanted to make a slight correction, I was introduced as a pediatric interventional cardiologist. I am a pediatric cardiologist who does interventions, and that's an important difference out there that needs to be understood and internalized. We tend to, it's wonderful to see the progress that interventional cardiology has made, and I can see it's a transformation. But that transformation has not touched the lives of children, because children still need the surgeon substantially. The surgeon saves more lives, and we are partners with them. It's a different situation. Yes, when I spoke about intervention, we need backup from the surgeon, but it's much more than that. We are a part of an integral team, and the surgeon is incredibly important, not just the surgeon, the nursing, the intensive care. So my dream for Bihar is that we have an outstanding pediatric cardiac center. I know that it's being set up, it's made its beginnings, and I see a future, but I'm just hopeful that children all across Bihar have access to this. I grew up in the time when I was in All India Institute, to see very large numbers from Bihar thronging All India Institute. That needs to stop. And you need a center of excellence within the state of Bihar that looks after children comprehensively. Thank you.
Thank you so much, sir. Now it's my distinct honor to invite the chief guest for the evening, Dr. S.S. Chatterjee, to kindly address the cohort this evening.
Good evening, everybody. Honorable Professor Krishna Kumar, the chief guest, the guest of honor over here, Dr. Pramod, the chairman organizing committee, Dr. Samshad, the secretary organizing committee, Dr. Sanjeev, president CSI Bihar chapter. Ashok is not here, but Dr. Shaheen, the chairman scientific committee, Dr. Samal, he is our teacher, is a very learned teacher over here, and Dr. B.B. Bharti, a member of CSI, All India National CSI body, and Dr. Ravi Kumar, who is the, chairman at Vedanta Hospital at Patna. Now it's a very momentous occasion for me, for the CSI Bihar chapter, and also for the BIC Council of Bihar. This is all the more memorable because we have amongst ourselves Dr. Krishna Kumar, whom I know since 1993. He was my senior during my DM days at AIIMS Delhi, and under his guidance, I did the first femoral puncture. I must remember, I don't know whether he remembers or not, but I did my first femoral puncture under his guidance, and he also helped me in one of my projects to complete my project work. Now, many people over here do not know the actual the importance of Dr. Krishna Kumar as a pediatric cardiologist in India. He is known all over the world, and you'll be surprised to know that he was invited to deliver a Jones Memorial Oration at American Heart Association meeting, and he is the lead author of an international paper published by World Heart Federation, and the subject is World Heart Report 2026 on congenital heart disease. Now you can understand his stature. So it's a real pleasure for all of us. It's a real honor for all of us that he is here amongst us. I wish and pray for more success and more honors for him in India and all over the globe. On this occasion, I want to remember my guru, late Shivnarayan Singh, and Professor Srinivas, who established Indira Gandhi Institute of Cardiology in those days. And you will be surprised that he has personally written a letter to the then Prime Minister Indira Gandhi to get her consent to name the institute as Indira Gandhi Institute of Cardiology, and he got it from her. I also, in this occasion, I also want to remember my mentors in cardiology in Patna, Dr. A.K. Thakur and Dr. Vishnu Jain. Dr. A.K. Thakur everybody knows, but very few people knows about Dr. Vishnu Jain. I think, I don't know whether any one of you knows his actual contribution to cardiology in Bihar. He was the first trained cardiologist in Bihar. He came to Patna after doing his fellowship in cardiology from Buffalo Heart Institute in early 70s. And he established a cardiac cath lab at Indira Gandhi Institute of Cardiology. And at that time, the cath labs did not have the cine mode. They used to have a large X-ray plates like the CT scans of these days, large X-ray plates underneath the patient's table, and these plates used to move in a quick succession. So you don't have a cine film, you have a multiple X-ray plates, large X-ray plates with different frames of cardiac structure. So, and he had shown it to me. I have seen those pictures, but somehow or other, he could not get the recognition that was due to him. His importance was known outside Bihar. He was close friend to some of the great cardiologists of that time. One of them was Professor Rajendra Tandon, and another was Sushil Munshi. Sushil Munshi, Rajendra Tandon, I think everybody knows. Krishna Kumar is a disciple of Dr. Rajendra Tandon. Sushil Munshi is, many people do not know his name, but Sushil Munshi worked under Paul White. Now, Paul White, anyone who has done anything in cardiology must be knowing the name of Paul White, and his paper on Eisenmenger syndrome is still read by all DM or DNB candidates. So what I will just share a personal experience. This personal experience is to show how great the stature of Dr. Vishnu Jain was. It was in early 90s when I was thinking of going for DM training. I failed in the first attempt, passed the theory examination in second attempt, both at All India Institute and at PGI, but failed in the practical examination at both the places. When I returned after failing, Dr. Vishnu Jain asked me what happened. Then I said, sir, I will not be able to compete unless I work in the tertiary cardiac center. And he kept mum. And he said, okay, let me see. Then I didn't know. He wrote a letter to Dr. S.C. Munshi, who was a cardiologist at Jaslok Hospital, Bombay. And he didn't tell me anything. And you'll be surprised, Dr. Sushil Munshi wrote a letter to me. Then I came to know that Dr. Vishnu Jain has written a letter to him. And Dr. Munshi wrote a letter to me telling me that Dr. Vishnu Jain has approached him for a training in cardiology at Jaslok Hospital for me. And then in the next session, he sent me a telegram. He was not known to me. I've never even heard his name earlier. Okay. And then he sent me a telegram that please come on such and such date at Jaslok Hospital for an interview for senior registrar. I went there. I was definitely not selected. Worked there for 6 months under him. And after that, he offered me a seat for DNB, which I was not interested. I came back, and after that, I was selected at AIIMS Delhi, and there I met Professor Krishna Kumar. So Krishna Kumar was as a well-known person even at that time. He was a post-DM candidate over there, but his stature was that of faculty members. So this occasion, I just wanted to remember the people to remember Dr. Vishnu Jain also, because he was the first really trained cardiologist who worked in Bihar, but he did not get his recognition according to his stature. And this was because of the socio-political situation of that time, and also because he was a very straightforward man. He will always speak a spade. He will never bend to please somebody else. Now, I also want to remember at this stage late Mr. Jwala Pradhan, father of Dr. Ajit Pradhan. He was the one who established the first intervention cardiology center at Bihar at Jivak Heart Hospital, where Dr. Pramod and Dr. Ajit Pradhan, they started the first intervention cardiology and cardiac surgery in Bihar. So when we discuss these things, we must remember the history of development of intervention cardiology and surgery in Bihar. Now, with this preposition, I just want to welcome you all over here. I think we have got a very good clinical meeting today. Most of the speakers were very well read, and they have given their presentation. I wish a great success to the conference and great future for the BIC and CSI Bihar chapter. Thank you.
Thank you so much, sir. Now, to propose the vote of thanks, may I request Dr. Shamshad Alam, Organizing Secretary, to kindly come on the dais.
Thank you, everyone. Having all of you here is a great blessing for all of us in Bihar. So initially, 10 years back when I joined my DM cardiology training, I thought that people from our state, we are not present everywhere on the national platform. So I thought that whether we are lacking that potential. So down the line, in these 10 years, what I have learned that we all of us were having the potential to perform the intervention. The only thing which was lacking was potential to express yourself. And down these line, over the gradual conferences, we have improved that potential, and now that potential to express by this crowd and by the presentations which have been done till now, I can feel that potential to express, it has been improved a lot. Thank you, everyone, and let's continue this academic extravaganza. Thank you. And I thank all the dignitaries, our chief guest, our guest of honor, our organizing chairman, our organizing scientific chairman, Samal sir, Bharti sir, Sanjeev sir, CSI president, Arvind sir, Dr. Ravi, and everyone present over here. I thank everyone for such a wonderful conference. So by these words, I will conclude this inauguration session by national anthem. So I will request everyone to stand up for the national anthem. Thank you.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, ladies and gentlemen. Now we'll continue with the next academic session, that is on the peripheral intervention. For that, we'll take 10 minutes for the stage setup. Sorry.
Last but not the least, a special thanks to Dr. Ajit Pradhan. He is instrumental in getting our guest of honor, Dr. Krishna Kumar, here. So thanks to Ajit once again. Thank you.
Dr. Bipin Kumar, please come on the dais. He has to make some announcement for all cardiologists.
I would like this opportunity to announce our next main cardiology conference, which is of annual Cardiacon of CSI Bihar chapter, which will be held on 31st October and 1st November. And you all are invited in this, and that conference will include clinical cardiology, preventive cardiology, apart from this pediatric cardiology and interventional cardiology. So all are invited in that conference. This is a first announcement. Thank you.
So let's continue our academic session. Sir, we are moving on to peripheral intervention. We will start with talk of Dr. Rajesh Vijayvargiya sir, if he is here. Basically, due to some issues, he was unable to come here. And in this session, we will have talk on TEVAR by Dr. Nishant Tripathy sir. In between, the online presentation is being arranged for Dr. Rajesh Vijayvargiya. We will start the session with TEVAR, Dr. Nishant Tripathy sir. I will like to call the discussants and moderators for this session. Our discussant will be Dr. Sanjeev Kumar sir, Dr. Amrendu Kumar, Dr. Avinash Kumar, Dr. Arvind Kumar sir, cardiothoracic surgery sir, Dr. Sidnath Singh, Dr. Anuj Kumar sir, cardiothoracic surgery. So kindly come towards the desk in between it is prepared for the presentation. It will take 1 to 2 minutes to prepare it. Dr. Anuj Kumar. Dr. Priyaranjan, if he is available here. Dr. Ajit Pradhan sir, we will request you to have you here because this is a peripheral intervention session. So we need our surgeon's support too, aortic intervention. And I will also request Dr. Deepa Shri, she is here to come on the desk because the imaging is very important whenever we do aortic intervention. Now I will call my first speaker, Dr. Nishant Tripathy, boss, and he will also moderate the whole session because Dr. Rajesh Vijayvargiya sir is unable to come, so he will have to moderate the whole session too.
So thank you, chairpersons, and thank you, Shamshad. So after all the exciting coronary cases, we have come to aortic session, and these are actually more gratifying in terms of results of the interventions, because patients are very sick, and what we can achieve with minimally invasive, you can say, intervention. So this was a case summary. Patient 68-year-old, thin-built, very fragile female with hypertension and severe chest, back and abdominal pain. And when she presented to us, symptom onset was like 4 to 5 days, but she was having persistent pain, anemia, creatinine was a bit on the higher side, there was AKI, and so we evaluated her, keeping all the differential diagnosis in mind, and it turned out to be a type B aortic dissection. It was distal to subclavian artery. You can see the still echo images also, the double barrel aorta and the descending thoracic aorta you can see on the left frame in the echo, and the CT aortogram showed a large spiral dissection starting beneath the distal to the subclavian artery and extending up to the iliac bifurcation. In fact, the right, according to the CT, the right renal artery was from the false lumen, and there was slight malperfusion of right kidneys. So we decided, typically we say that type B aortic dissection can be managed conservatively. So at this point, there were 3 options: to wait and watch, to go for surgery, but surgery was, as surgery colleagues will agree in this scenario, surgery is going to be very high-risk surgery with lots of morbidity and mortality. And another was endovascular repair of the aorta. So we decided to go for the endovascular repair, and the CT assessment was done, which showed the spiral dissection in expanding aneurysm. On the right panel, you can see the extent of the false lumen, and true lumen you can see in the lower panel. It was reduced to hardly 13 to 14 millimeter, and right kidney was from the false lumen. But the good point was we had good landing zones proximal to the intimal tear. So we discussed with the team, and we felt, and the CT radiologist also said that there were additional tears also. One was the primary tear at the top, and there were some additional tears also in the descending thoracic aorta. So we planned to do a thoracic stent graft, and this is the steps. So we went from the left femoral, because we feared that the right femoral may go into the false lumen, because the flap was through the right side. We confirmed at each. So we confirmed with the fluoro that we are in the true lumen. This is the true lumen. Right left renal artery is rising from the true lumen. Carefully, we passed a wire, and a left radial access was taken. A pigtail you can see from the left radial to do an aortogram. Passed a multipurpose catheter, do a DSA. This is the DSA from the pigtail showing a tear. You can see how big that tear is, and associated expanding aneurysm. We exchanged the catheter with Landerquist wire. And this is the graft that we use. It is a Valiant thoracic stent graft from Medtronic. It is 224 millimeter in length with the covered segment of 212 mm, which we felt that it is enough to seal the tear as well as cover the main aneurysm part. and we expected the false lumen will collapse after we seal the intimal tear. We took help of our cardiothoracic surgeon who gave us a femoral access, femoral cut down. We passed this 24 French sheath which associate with the stent graft, crossed it in the ascending aorta first. Then we positioned it just distal to the subclavian artery where we had intended to. On the CT image, we had got that safe landing zone. We confirmed it with the DSA. This is it. We confirmed with the DSA, and at this point we have to be very careful. We should not be moving because it's a self-expanding extent. So we should not be moving the table. We should not be very steady with our hands so that it doesn't displace. This is now the release. There is a release mechanism. Now we are releasing the graft at that point. So till this step, you can retrieve, if it has moved, you can retrieve the graft. So we confirmed it that it has not moved with the DSA, and it is there where we had intended to. And then we finally release the whole graft, keeping everything steady. And this step increases the heartbeat for our operator also, but at the end, everything went as expected. Then we released and removed the wire, the balloon. And this is every step was done very carefully. This is the final DSA. The whole we have how we removed everything. So this is the post-procedure X-ray showing the aneurysm has decreased in size. Before the follow-up, it was not enough because the patient came back. This was result was good. Patient recovered. We gave blood transfusion. Kidney function started improving. But she came back after discharge with fever, persistent fever. So we thought there is some another thing going on. We read up about infections, endocarditis, and all those things. We did workup for everything, but it turned out to be a thyrotoxicosis. Her TSH was low. So probably might be thyroid-associated aortopathy or something which led to hypertension and aortic dissection. With treatment of thyrotoxicosis, she improved significantly. Follow-up after 1 year. This is the CT showing absolutely stable graft without any endo leak. Distal aorta has improved in size. False lumen has disappeared. You can appreciate on echo also, those who are familiar with echo, the false lumen has disappeared. Whole aorta is now pristine. There is no evidence of any false lumen. And this is our team saying you all thank you.
Thank you very much, Nishant, for a treatment for a very difficult situation. Yes. This lesion was pre-renal. This lesion, dissection was pre-renal, up to the renal artery.
No, it was in the thoracic aorta.
It's only thoracic aorta.
Distal to subclavian artery, tear was in thoracic aorta. We just sealed the intimal tear and let everything, the false lumen then collapsed, thrombosed, and distal, we didn't do anything in the abdominal aorta. We just sealed the tear in the thoracic aorta.
What would have been the strategy if it goes beyond the superior mesenteric or renal artery?
Sir, the flap, the false lumen was extending up to the almost up to the aortic bifurcation. But here idea is, it is an acute dissection. So here idea is to just seal the intimal tear so that the flow which is going into the false lumen stops and the false lumen automatically thromboses and disappears, which we can see in the follow-up. If it involves multiple channels, then we have to think of other strategies. We have to prepare the grafts, chimney procedures, because then we'll have to prevent the branches. Yeah. So that becomes even more complicated and that takes more time. But only if there is other aneurysms which are involving branches in the abdominal aorta, then only we can do that. Otherwise, in acute condition, this procedure is enough.
Thank you. It's a nice work.
Nishant sir, indeed great presentations. The patient managed very well. We all know very well, being a CTVS surgeon, we know how difficult operating this kind of patients and what are the morbidity and mortality. And the section was extending from the thoracic aorta to the bifurcation of the iliacs. So it was a huge dissections and things was managed very well. Was there any feature of limb ischemia in this patient?
She was complaining of pain, but objectively there was no evidence of limb ischemia. But
You-
she was complaining of pain all the time.
Okay, but there was no obvious
Objective,
fe-
there was
features-
right femoral was a bit weak, but there was no objective
obvious
evidence of
feature of
ischemia.
limb ischemia. Okay, so you used on single stent for this.
Single stent to seal the tear in the thoracic aorta. We just prayed and expected that it will
Yeah,
help,
because-
and that
because-
helped.
Yeah, because many times they suggest we should put another bifurcation stent for this.
That makes the cases more complex, and unless you are sure that there are other flaps and it is that other branches are getting compromised, like renals or mesenteric arteries, they are from the false lumen and they are getting compromised. If you feel, then you should go for those procedures and preserve those branches by chimney procedure and
Yes.
extending the grafts, getting into the femorals. So that can be done, but we felt in this, after the CT assessment and after discussion with the radiologist, the tear is only limited to the dissection thoracic aorta. And once we seal, we followed her up and we can see the result. Yes. There to see.
This is the ideal situation for a
Yes.
TAVR procedure.
Yes.
Because it doesn't involve this. An acute dissection, the main thing is to seal the
Seal
entry
the
point.
tear.
Suppose this is an aneurysm, then the scenario is different.
Yes.
And in those aneurysm, if it involves these arteries, then we have to do a fenestrated graft.
Yes.
So
Yes.
that is a complex procedure, obviously.
That is a different scenario,
Yeah,
and
that is a different
it's very
scenario.
complex procedure.
Yeah.
We have to create holes in the graft, and that takes too many time. So 224 millimeter length, and it is a self-expanding stent, so it takes the size of the aorta.
Sir, when we get aortic dissection in echo lab, then generally we refer the patients directly for surgical correction. So what are the indications for this procedure?
So, I can't. Sorry. Sorry.
Sir, in echo lab, whenever
So indications for surgery in dissection of aorta is mainly the type A dissection involving the proximal ascending aorta with involvement of aortic valve. That is the class 1 indication for surgery, and you immediately. This was a type B dissection where the tear was arising distal to the left subclavian artery. So in type B dissection, you know, it has a recommendation not to send immediately for surgery. When waiting is good enough, you can wait in type B stable dissection, but all those are stable dissection. But nowadays, people are saying that in conservative management of type B dissections, there is aortic remodeling. So the aorta becomes narrower, and later on it causes lots of problems like limb ischemia, and then you will have to do all those complex procedures to save the limb, to save the renals. So indications for intervention in this case was persistent symptoms, subacute sort of presentation, renal malperfusion. If we'd have left, maybe renal artery would have closed. So these are and see how aorta was preserved later on. So to prevent aortic remodeling is also now becoming an indication for intervention in type B dissection. For type A dissection, obviously, you have to send him for surgery.
Sir, to prevent stent dislodgement, sir, we should use high-rate pacing to prevent the dislodgement.
Yes, but those are for shorter stents, like for coarctation of aorta. Sometimes if we are hardly used for stent graft pacing. Not, we use a large structure, right? So it will not move like that. So it's for only shorter things.
In the curve of
curve
the aortic
is,
arch.
that is,
and that is difficult to handle. It's like similar to TAVI.
TAVI also.
Yes.
Once you bend, goes in the arch, that is the only critical step.
In difficult arches, like somebody can put a wire in the LV,
yes,
and even that wire can support it, or sometimes even the wire can be snared from the venous access and septal approach. You can snare it the wire and make a loop, and that can give a very good support.
It's mostly for ascending aorta when you are dealing with ascending aortic. Either you are doing a TAVI with a self-expanding valve, horizontal aorta, where going inside is difficult, then you'll have to do all these maneuvers. Descending thoracic aorta is a straight structure, right? So you can see, and that's why imaging is important. All these cases are everything about planning only. Execution is only 20%. And always take help of surgeons while doing aortic cases.
First of all, I must congratulate Dr. Nishant Tripathy for this pioneering work. He has done a very good work. I have just one query. Do you encounter any neurological problem post-op?
In this patient, no, sir. But obviously, in any whenever we are manipulating hardwares in aorta, because these patients will be having atherosclerosis, so their plaques can go into the cerebral. They do go even in coronary angiography. Plaques can go into the cerebral circulations, and neurological problems can be there. Even in bypass surgeries, you develop some complications of bypass. Even in angiography, some complications of. But mostly they are not clinically relevant. But you may have some neurological issues, which as cardiologists sometimes we are not aware of, like some behavioral issues or some minor behavioral issues, which patients develop after any such procedures where we are manipulating hardwares in aorta.
Thank you, Dr. Nishant.
Thank you, sir,
for a very useful lecture. And now our next lecture is on another challenging peripheral intervention, carotid artery stenting with EPD in a 76-year-old male with recurring TIA. And the speaker is Dr. Ashish Kumar Jha. Ashish, you start your lecture.
So thank you, organizing committee, for giving me this opportunity. I'll be sharing a case of carotid artery stenting in a patient with recent onset personality disorder. Actually, it's a 77-year-old male presented with a history of recurrent fall with seizure and rapidly progressing memory loss and behavioral changes over last 2 months. Known diabetic with a history of NSTEMI 2 years back, for which he underwent stenting at our center, LAD LCX 2024. He also underwent pacemaker implantation way back in 2018. Came to us for pacemaker evaluation, and baseline rhythm was atrial fibrillation with controlled ventricular rate and was already on anticoagulation. Pacing parameters were normal. Carotid bruit was absent. In view of multiple ischemic, CT was done, and in view of multiple ischemic lesion in watershed area of MCA and ACA territory on CECT brain, carotid Doppler was done, which was suggestive of significant lesion in internal carotid artery. So then we did the carotid angiography, and angiography, as we can see in the upper picture, is almost 90 to 95% stenosis at the ICA, at the ostium of the ICA. So we decided to go for a carotid angioplasty. 7F long sheath was tracked over a 6F JR with a Termo. This is the carotid suit which we have taken. Here we can see we initially crossing with a 035 wire, and over that wire we have taken a 7F 6F JR was tracked, and over that 7F long sheath was tracked. Sheath angiography was taken, and which delineated the lesion. So now it appeared to be a atherothrombotic lesion. Moreover, the patient was so this is the lesion that we can see. So this was the carotid angiography, and atherothrombotic lesion, history of atrial fibrillation. So in view of atherothrombotic lesion and history of atrial fibrillation, it was decided to use a embolic protection device, Imbosil NAV6 from Abbott Vascular. So risk of stroke gets significantly reduced in atherothrombotic lesion with use of EPD. Imbosil EPD is a bare wire technology based, allowing independent wire movement. It utilizes high strength 6-strut nitinol based frame which allows good wall apposition and leading to minimal embolic escape, and it is suitable for vessel of 4 to 6 mm in size. So here we can see that lesion was initially crossed with the bare inbuilt bare wire of Imbosil. This here we can see that lesion crossing. So this lesion was crossed, and the distal 3 centimeter of this wire is very important, because that distal 3 centimeter is the 019, it's a thicker part, and so it has to be kept at a C1 level. The recommendation is to keep it at the C1 level. Here we can see that we have crossed this part, and this distal part is kept at a C1 level. And then the delivery catheter of EPD was taken, which was, here we can see, it's a long frame. I will just. So this is the embolic protection device catheter. Delivery catheter is advanced over the bare wire. And the idea is to put this at the tip of the wire is here. And the idea is to put at least 20 to 30 centimeter below this, this is the proximal tip of the increased 019 wire, so that there is no contact between these two systems. Moreover, the proximal part should be beyond the lesion, and that should be at least 20 mm beyond the lesion. So here we can see this is, we are parking it at a C2 level. That is the manufacturer recommendation, that you have to park it at a C2 level. And so here we can see the lesion is here, and that system was parked. And here, sorry, and this is the umbrella of this EPD system. So it is well beyond the lesion. That the whole idea is that. The post filter placement check carotid suit was taken. Here we can see that post, and then it was the lesion was dilated with a 2.5 mm NC balloon, and then it was stented with the exact self-expanding stent, which is 6/8. That is 6 mm at the carotid level, and that is the distal level, and 8 mm at the proximal level. 40 mm stent, and this is a self-expanding stent by Abbott. And stent positioning was confirmed through this suit. It is well beyond the filter. It is the distance between filter and the distal tip was maintained, and then it was deployed. So this is a deployment process. It's we are retrieving the. It's a clockwise on the sheath, and this is post-stenting. There was some waste we can see at this part, which was left as self-expanding stent 10 to further expand. Retrieval catheter was then used to take back this embolic protection device, this retrieval catheter. The idea while taking back is to keep this a bit of this filter into the beyond this retrieval catheter, so that the waste material doesn't embolize. So here we can see this. And after this, the wire was taken out, and this was the final DSA. And this was the final suit, which very clearly shows the middle cerebral artery and the anterior cerebral artery, and this. So the take-home message is ICA stenosis causing ischemic infarct in the waterside area of MC and ACA can cause rapidly worsening memory disturbances and recent personality disorder. Carotid bruit, although is a very specific clinical marker, lacks sensitivity. It is usually absent in stenosis more than 90% due to decreased flow. So a high degree of suspicion is must. EPD should always be used in atherothrombotic lesion, and that was well delineated in the CREST trial, which showed the use of EPD, and that trial was compared CAS carotid artery stenting with CA, and it was found to be useful. Patient was kept on DAPT with anticoagulation for 15 days, then switched over to clopidogrel with NOAC. Thanks. Thank you.
Thank you, Dr. Ashish. Yet another challenging case. But the most fearful complication may be the stroke in these procedures. So before doing the procedure, did you, the radiologist, check the flow from the other side through the circular village to the brain? If something happens and this artery is blocked completely.
Yeah, that was seen already. So CT angio was done, and it was first detected on CT angio only. The other side of the left side was all okay. But it was atherothrombotic lesion, and that's why it was decided to keep a embolic protection device there to capture all the atherothrombotic waste that can go while dilating the lesion, and that's why EPD was used. There was always a chance of stroke. There was a large trial, CREST trial, which showed that what is the advantage of CA. It compared CA versus carotid artery stenting, carotid endarterectomy versus carotid artery stenting. The risk of stroke in carotid artery stenting was around 4%. The overall, there was no difference. Risk of MI in carotid endarterectomy was more. And so overall, there was no difference. But always there is a risk of stroke.
So what may be the etiology in this case, in your case?
It was most probably atherothrombotic, sir. It was, that is the most common reason. Takayasu, we can't suspect in a 74-year-old male. So it was most probably atherothrombotic lesion.
Another small question. Which is more important, external carotid or internal carotid?
No, internal carotid. Internal carotid.
Internal carotid.
Pre-dilated at high pressures.
Yeah.
Usually we pre-dilate at low to moderate pressure just to open the vessel and then put a
just to make us say, because
not at 20 atmosphere.
Yeah, but it was 2.5 mm. It was a 2.5 mm balloon.
That also it should not be done to prevent the risk of stroke.
Small tip only. I mean, for carotid artery stenosis, what I suggest that whenever you get a patient of hypertension or cardiovascular disease, please put your stetho on both the carotids. In 10% of the cases, you will get a murmur, and that may help you in further condition. This is going obsolete. In the previous days, this was the usual phenomenon. For all cardiac patients, you auscultate the carotid. These days, these are not being practiced. But this is the easiest way of diagnosing a carotid artery stenosis by just putting a stetho on both the carotids.
Yeah, carotid bruit, actually I checked initially, but it was not there. Severe stenosis. Okay, thank you.
Thank you very much, Dr. Ashish. Now we move to the last talk of this session. Is about the pulmonary embolism by Dr. Ashish Tiwari from Jabalpur.
So, good evening everybody, and greetings from Madhya Pradesh and Narmada town Jabalpur. And at the outset, I would like to thank Bihar CSI for inviting me here, and such a pleasure to see inaugural talk having jam-packed session. So it's a pleasure being here. So when I was asked about to give a talk about this topic of pulmonary embolism, very close to my heart, and we are working on this since years now. And this is the area where the progress has been not in the tune of where we developed acute coronary syndrome, the way we developed acute MI management, and this has been area of Achilles heel in the most of the cardiologists. So we'll discuss about current guidelines, thrombolyze or not, mixed approach, and embolectomy as a therapy, thrombectomy as a therapy, and how to perform it, and clinical scenario. We will discuss few clinical scenario in the device time. So it presents as a significant threat, and it is still having very high mortality all over the globe with no standardized care. And in recent times, in last 10 years or 15 years, the STEMI guideline has picked up, and we have cath lab everywhere, but still the pulmonary embolism treatment there's no significant improvement. And acute PT still remains a challenge, especially the high risk P, and they get diagnosed late also. So guideline also differs so much in here. With most of the guidelines say systemic fibrinolysis is okay, in all guidelines clear, but most of the guidelines are mum about intermediate risk pulmonary thromboembolism. And catheter-directed intervention in hemodynamically unstable pulmonary embolism patient when systemic fibrinolysis is failed is mostly too late, and then the patient becomes very, very sick, so you are not able to solve them. So even the guidelines are not very much clear about intermediate grade. So PASI score, we take PASI score in these cases, not only classify and prognosticate, but gives guidelines for treatment. So we know when the PASI score is low, low risk P. So when we categorize these patients, most of the low risk patients have less than 1% mortality in 30 days, which is very, very good. But high risk patient, very high mortality. So in a nutshell, when we describe these criteria of high risk of massive P, systolic blood pressure less than 90, need of vasopressor, and low risk patients have no RV strain, dysfunction, and so in between, these patients who have biomarkers positive and some RV strain are there, but they are not hypertensive and there are no need for vasopressor. This is the area which deteriorates very rapidly, and the moment you see these patients, one day they will become unstable, next day they will become very unstable, and you find these patients have sudden cardiac death also. The moment you see that the patient might go home, and recently we had this similar kind of case in Lucknow also. So very high profile patient goes home, gets sudden cardiac death. So this is the area where we have to catheter directed intervention has gained popularity, and intermediate as a bailout when the thrombolysis therapy fails. So current guideline also says so that anticoagulation though remains the cornerstone of treatment across all category, CDI or catheter directed intervention has gained space in last year as important adjuvant, especially with the new devices is there. What we and few other centers are started doing mixed approach, especially in the patient where the bleeding risk is not very high. Like we give after pulmonary thrombectomy, we give leaf pigtail catheter in the place, and we give 20 mg tenecteplase bolus, and rest we infuse 1 mg per hour. So it gives very good results, and it clears residual thrombus burden very good, especially in the cases where thrombus burden is very high, and we are using CAT8 catheter, penumbra CAT8 catheter, which is not the best catheter to use, but because many of the people cannot afford 12 and 16, so then CAT8 catheter works well, and this is the kind of mixed approach, but this has to be, we tried in the patient where bleeding risk is low, not in the patient with bleeding risk is high. So embolectomy, thrombectomy or as a therapy, primary rescue failed, so early versus late. For late, these thrombolysis, the fibrinolysis doesn't work. More than 3 weeks, CAT12 to be preferred. Upfront therapy is very, very useful in the patient where you are very afraid of giving fibrinolysis in this patient. And the failed thrombolysis, only effective way to save the patient is the catheter direct intervention. Late presenter with dyspnea class 3 is probably most effective way to prevent them to CTVS, and we know all these patients, they become very, very symptomatic as they follow up. In next few years, they become right heart failure. They are more symptomatic than ejection fraction left heart dysfunction patients. And most of these people die within 5 years of diagnosis. So I will discuss 3 clinical scenario where we have used out of 9 cases. I selected these 3 cases to discuss here. Failed thrombolysis, upfront thrombectomy, and in RPA thrombosis patient where patient was absolutely symptomatic and there was nothing in the LPA. So case 1 was 30-year-old male, non-diabetic, presented with dyspnea. He, as usual, most of the time these patient was initially treated as LRTI, then diagnosed with the D-dimer and echo based. He was thrombolized and there was no improvement, and he came with a collapsing condition. So he came with 90 systolic pressures and acidotic 91%. You see these changes in the precordial lead. So whenever these patients come with these precordial ST inversions and symptoms, these patients are very sick. And mortality can be 30 or 40% in these cases in next 7 days. So this kind of ECG is very, very dramatic. So he was in AKI, heart rate, tachycardia as we expected, SpO2 room air, and plan of most of these patients when they are acidotic, ABGA, lactate is more than 6. I mostly intubate them and try to hemodynamically stabilize them in few hours. Then I decide to take whether to take it on table or not. But because if the lactate is rising, whatever you do on table, the patient is not going to, we are not going to save them. So next few hours, patient, and we did CTPA in next few hours, and you can see this RP and PA both were cut off. Saddle thrombus was there, and acute saddle pulmonary embolism. This was after the patient was thrombolized outside. So it was a failed thrombolysis case. In next few hours, patient, this was an Indigo system we use for this, and this is a Penumbra system, which is having a very good learning curve. Within a few cases, you can learn how to use this case and how to improve efficacy and how to decrease your blood loss. So it was a severe TR, a very difficult RV entry, but we could enter RV in sometimes. And without any dye, multiple runs based on the CT images. We did thrombosuction in LPA and followed by in RPA, and this is a system. Sometimes I use this additional sheath, cook sheath, which gives support so that multiple times I need not to remove the catheter. And this is a sheath followed by this catheter, LPA pullback in MP and RVA. Multiple pullbacks has been taken and multiple runs then without any angiograms in RPA, and entry into different branches in RP, upper and lower, based on my CT images, which was, we kept that there. So first MP shoot we kept, and we thought the significant thrombus was there, and few more runs where the thrombus was there, and we removed this much removed from pulmonary artery in a very sick patient, and repeat CT after 4 days shows clinically clean arteries, and this was a mixed approach, first case of mixed approach when we used this. And course after pulmonary thrombectomy, on-table saturation did improve a little, and next 8 to 10 hours there was dramatic improvement. Shock improved, tachycardia settles, creatinine to 1.3, and 50 plus urine output improves. So he had a DVT also. So when we are the cardiologists, when we get hope, we try to do best for the patient. So we in the same, next morning we have taken the same patient for lower limb thrombectomy also. So because these devices can be used for both DVT and these, so I take both femoral and popliteal both axes. Femoral axle will be the downwards and popliteal axle will be upwards. So we suck from down from popliteal to femoral and internal iliac. And satisfactory flow established. You can see the flow here. And this was just like a surgical, you remove the surgical folly. And thrombus removed for left DVT, same patient, and course after day 3, he was all fine. Day 4, I already shown the CT, RPA decreased, thrombus was in branch PAs, and he will remain in class 1. Now it is more than 1 year. He is still in class 1 doing absolutely fine. He is on oral NOACs. So case 2 has non-thrombolized late presentation, a 20-year-old. As we see in some of these cases, they develop dyspnea, they get inferior lead change, they get angiogram and discharged. After 15 days, echo-RA-RV dilated, and this was the ECG on presentation. And so you can see the RPA was totally almost cut off. There was nothing in the LPA. So he had only RPA, but he was so sick, he was not able to walk even to the bathroom. So he was in class 3 status. So we just removed this RPA thrombus. Multiple thrombectomy run was done, and to my surprise, this thrombus was removed, and he became asymptomatic, hence his RPA doing well currently in class 1. Case 3 was non-thrombolized early presentation, and this was a class 3 RPA near total occlusion, and this case we did with mixed approach, and he was extremely good results. And all these cases that was done with CAT 8, we tried one case with CAT 12, very good results. So conclusion, in recent times, there is significant improvement in STEMI care, but acute PT remains a challenge. Late presentation, very late diagnosis, high mortality and high residual disease. We see and as we know, the CTPH patient, when they go for surgery, we don't have centers which can give more than 50% result. And even the best hand results are not more than 60%. So they are almost inoperable cases. So thrombolysis has excellent result in first week, but in late presentation doesn't work well. So penumbra thrombectomy and the new system in RE gives an excellent option in cases where previously there was no hope. and can be used upfront in selected cases where thrombus burden is very high. So what can be the area of discussion? Should there be a consensus regarding catheter-directed intervention? First, like in STEMI, we know that catheter is the first thing, especially in the cases of massive, and this intermediate category has to be carefully reviewed again and again, and systemic thrombolysis alone to be reserved only where catheter-directed intervention is not alone or available or possible. So gray areas, thrombectomy, what should be the upper limit for index symptom? But no consensus, but most of the people in high intervention centers, 6 weeks is the upper limit. So I would like to change my topic for pulmonary embolism. Why not to choose mechanical thrombectomy in the cases in intermediate and high risk pulmonary embolism? Thank you very much.
Thank you. Dr. Tiwari, you have saved many persons, many patients in a life-threatening condition. But whenever we do pulmonary thromboendarterectomy,
yes,
in chronic pulmonary embolism, usually the post-operative period is very stormy.
Yes.
Quite a significant number of cases has to go on ECMO.
And Dr. K. Krishna Kumar sir was here, and other center who does like Devi Shetty's unit where I was worked also. The results are 50-60%, not crossing more than say 50-60%, especially in severe cases and with high morbidity also.
So did any patient requires ECMO support in post?
Yes, they do require. These are very bad patients. So in surgical cases, so it's a disease where prevention and early treatment is the best thing, I think.
Hi, Dr. Tiwari.
Thank you.
I have two questions. One about DVT. In the scenario of deep vein thrombosis, when do you feel the medical management is not sufficient and we should switch for intervention?
Yeah, so technically there is no guideline, but preferentially yes. If your heparin therapy is not working and patient is having swelling with pain, I think in those cases should be taken for thrombectomy. Though in few year time, the way the device industry pushes things, I think this will become a routine for everyone. But there also, I think because it does not go below popliteal, it's very difficult to remove thrombus from below popliteal, and you can damage the vessel also. So I think just wait for 1 or 2 days, because up to 1 week crossability is not an issue. Crossability is not an issue. So we should avoid the case where we have taken the case, we have arranged everything, and then we are not able to cross the lesion. So first, if it's possible, try to cross the lesion first. If the patient lesion is possible, then post patient for these thrombectomy cases.
Because what I see in my personal experience, because very frequently DVT patients are coming to us, and we could see that if we start medical management, they respond very well. Approx 70 to 80% patients respond very well with medical management. Even though they don't improve radiologically, but clinically they improve. So, but I personally feel only 20-30% patient may require this kind of intervention.
So same thing I said, symptomatic swelling and painful, they should be taken up front within a few days. Rest of the patient we can wait. But the current, I have read a review article which clearly said, even in medical management, the symptom improves because of collaterals and other channels. Most of the time this artery doesn't get open, right? So imagine a condition where vein is blocked and we are not able to give fibrinolysis because disease is not that severe and risk of thrombolysis is very high. So why not use a catheter which improves the flow, and rest of things taken care by the diotherapy, heparin and Novex. So that will definitely going to come in next future.
So you simply go for thrombolysis, or you just club it with the IVC filter?
No IVC filter in the patients where anticoagulation is not contraindicated.
One more question. What I could see in both of your cases that you cleared from the MPA, RPA and LPA. But what about segmental and subsegmental branches? Clots are there. So
the moment you establish flow and the RV pressure comes down, so basically criteria is 30 to 40% RV pressure. If you bring down 40% RV pressure, it means the patient will do very well. The data shows that, the extract P trial and other trials shows. So the moment you remove these major chunk of thrombus, that's why the mixed approach is very good. In my view, in these cases where the bleeding risk is low. So thrombolysis or fibrinolysis still plays a major part. It's not opposite to coronary, where you can just remove it and a patient does well. Because this vascular bed is very, very big bed. And you might not be able to remove everything.
Thank you so much.
Thank you.
Recently, we had one patient in our ICU where the patient was in septic shock on ventilator, and accidental finding in echocardiography was a long filamentous thrombus in the superior vena cava at the junction of RA. So what should be the ideal treatment? Whether retrieval should be done or surgical will be the better option in those patients?
In SVC thrombus?
Yes,
SVC-RA thrombus?
Most
SVC-RA?
rarely it was attached to the central line because central line was removed. Recently we had this case in our ICU. So what should
So most of these three patients will go for anticoagulation alone. The patient in which we discussed also, we have a SGPGI team also here, in few people. We discussed few cases where RA thrombus was big, SVC thrombus was big. We discussed thrombolysis or fibrinolysis many times, but sometimes this risk of fibrinolysis, the board, the heart team does not agree on it. So most of these patients, they end up having heparin only, and when they get 2 weeks of heparin or 1 week of heparin, most of them thrombus comes down. So this is, especially in COVID era, we have seen a lot of cases, RA thrombus, SVC thrombus, RB thrombus, IVC thrombus, but we could not thrombolize any of them because none of us could agree that patient should be thrombolized. Right.
Thank
Most
you,
of time
Ashish.
they are asymptomatic
I think
only.
we are running late,
Yes.
so we should move on with the next session.
Thank you.
We can discuss these questions during the gala dinner too.
So thank you very much.
Thank you everyone for being on stage and for such a wonderful discussion. Let's move on to our next session, which is on subcutaneous AICD. So I would like to call upon moderator for this session, Dr. Shaheen Ahmad, our discussants, Dr. Shaukat Ali, Dr. Manas Thakur, if he's here, Dr. Prashant Kashyap, Dr. Om Prakash Arya, if he's here. I will also like to call upon Dr. Ishad. He has joined us. Dr. Jyoti Prakash Karn, he came late, but yet he joined us. Dr. Anupam Bhambani ma'am. Dr. Upendra Narayan boss. So over to Dr. Shaheen Ahmad.
We have a topic, the evolving role of subcutaneous ICD in modern practice by Dr. Kush Bhagat, Jaipur.
So a very warm good evening to all of you. So at the outset, I would like to thank the organizers for inviting me to this very prestigious conference, and it's always a pleasure to come to Bihar, especially Patna. So the topic for today's presentation is on subcutaneous ICD. So I think we all have been implanting ICDs day in and day out. But what about subcutaneous ICDs? Have we ever implanted subcutaneous ICD? More importantly, do we even counsel patients that there is an option available like subcutaneous ICD and you can also opt for subcutaneous ICD? So let's start the discussion. So my first case is a 60 years old male patient who had VT, secondary VT, underwent ICD from left side, had 2 episodes of appropriate shock. 6 months down the line, developed infection, device and lead was extracted, implanted from the right side, new device, new lead, but after 1 month, developed infection from the right side too. Question is, what are the options for this patient? Second case, 50 years old male, CKD, DCMP, LB dysfunction, EF 30%, had episode of monomorphic VT, which needs to be cardioverted. So it was planned for AICD. So before AICD, especially in all these patients, we take venogram. Both the subclavian vein was occluded, which is actually quite common in these kind of patients. Now, what do we offer to these patients? So to begin my discussion, what is subcutaneous ICD? Subcutaneous ICD is basically ICD in which we are not taking a vascular puncture. There is no need to take a venous puncture. Device is implanted in the axillary area. It has got 1 lead which passes in the subcutaneous area in the parasternal region. So it can be either the left or the right parasternal area. So it can give shock to the, if patient develops ventricular tachycardia, no need to take venous puncture, no hemothorax, pneumothorax, The problem is that it cannot give anti-tachycardia pacing and it cannot give brady pacing. So why this discussion matters? It's because ICD therapy saves life, but transvenous lead remains the Achilles heel. So a lot of times there are lead failure, lead fracture is there. We usually see, especially with the ICD leads, rise in impedance, fracture, pacing loss, shock impedance rises. Infection is a major challenge in these patients. Venous occlusion is also there because the leads these are stiff and thick leads as compared to the pacemaker leads. Tricuspid valve dysfunction can also there, and it can lead to tricuspid regurgitation leading to RA, RV failure, and cardiac perforation risk remains there. So earlier there was epicardial ICD, then transvenous ICD developed, then obviously CRTD, and now we have subcutaneous ICD. But last but not the least, we have now subcutaneous ICD with leadless pacemaker. So I'll discuss in my coming presentation, which is, we call it as a modular ATP. So lead-related complications drive long-term morbidity and repeat procedures. So if there is any problem with the ICD lead, we have to implant a new lead, and believe me, ICD leads are very difficult to extract. It's not like the normal pacemaker leads in which we can take out very easily. ICD leads are very, very difficult to extract. So concept of subcutaneous ICD is defibrillation without entering the heart, preserve the venous access, preserve the vasculature of the patient, avoid vascular injury, and reduces systemic infection risk. So a lot of trials have already been done for subcutaneous ICD, starting from 2001. So based on these trials, we have come to a guideline. So what does ACC-AHA recommend? ACC-AHA recommends that in patients who meet the criteria for an ICD, who have either inadequate vascular access or at high risk of infection, subcutaneous ICD is recommended with a class 1 recommendation. What about class 2A? So in patients who meet the criteria for ICD implantation, that means any patient who requires an ICD implantation, so subcutaneous ICD is reasonable just if pacing for bradycardia or CRT or VT termination, I mean anti-tachycardia pacing is not required significantly, then we can go for a subcutaneous ICD with a class 2A recommendation. So practically, if we think, then 76% of ICD patients who have at least one comorbidity. So all of these patients, these are heart failure patients, they have renal disease, many patients have diabetes. So these patients have one comorbidity associated with high infection risk. And that is why it has a class 1 recommendation and a class 2A recommendation for all the patients who require an ICD, just when patient does not require a brady pacing. So many patients who have been implanted an ICD, we see in follow-up, hardly anyone requires a pacing indication. Most of them do not require a pacing and implant, and even if they require pacing, then before only we give them a dual chamber ICD option. So in the trials, it was proven that patients who underwent a single chamber ICD, transvenous single chamber ICD, 90% of the patients, they did not require pacing. So only 10% of the patients in the trials, they actually required a ventricular pacing. And so across the major ICD trials, only 10 patients out of 4159, that is 0.2% patients who were implanted a subcutaneous ICD, they actually required pacing, and they were shifted to a transvenous ICD for brady pacing. So just in brief about this Pratorian trial, which was a randomized trial between subcutaneous ICD and a transvenous ICD, it showed that these patients who were implanted subcutaneous ICD had fewer lead-related complications. Atlas trial showed serious lead-related complications were very, very reduced, since there was no lead, no transvenous lead. No risk of pneumothorax, hemothorax, perforation, cardiac tamponade, since we are not even touching the heart and the vasculature. No chance of lead dislodgement. So as far as the efficacy is concerned, so it had got 98% efficacy, shock efficacy. That means if patient develops a ventricular tachycardia, it can terminate that with 98% efficacy. And if we talk about the chances of inappropriate shock, transvenous ICD versus subcutaneous ICD, it was very, very low. In fact, lower than the transvenous ICD. The chances of inappropriate shocks are very low in these patients. So, as I told, infection is major challenge. If we talk about transvenous access, then infection and extraction remains major drivers of outcome. And with the subcutaneous ICD, there is no chance of venous complication or very, very low chance of infection. Now, what about young patients? So if we implant, so we have a lot of patients of HOCM who have VT, we have ARVC patients who have ventricular tachycardia. These are young patients. We implant ICD in these patients. So this ICD lead is going to be in the vasculature since made for long. So because these patients survive long. And problem is that the longer the lead remains in the vasculature, the chances of complications becomes very, very high. So young patients are the patients in whom subcutaneous ICD should be given the option, since these patients, in these patients, we are not touching the vasculature. These are all MRI conditional. So at the tip of the lead, it has got some monitoring device which can monitor for AF as well. Now, problem with this subcutaneous ICD is that it cannot give a bradypacing and it cannot give an anti-tachycardia pacing. So these are two problems with this subcutaneous ICD. So as I already discussed, if we talk about the bradypacing, then very, very few patients actually require bradypacing if in those patients in whom we implant a ICD. And to tackle this problem of anti-tachycardia pacing, so now we have a system in which we combine the leadless pacemaker with subcutaneous ICD. So it is called as a modular anti-tachycardia pacing. So this is the actual subcutaneous ICD device with this lead which goes in the parasternal area, and this is the leadless pacemaker, the Boston leadless pacemaker, which comes by the name of Empower. So it interacts with this subcutaneous ICD, and whenever patient has ventricular tachycardia, this leadless pacemaker gives anti-tachycardia pacing. So almost similar system like the Medtronic and the Abbott one. So it has already been published and it is already being used in US, the Empower as well as the subcutaneous ICD. Now if I talk about device size, so device size is bit larger than the normal ICD. But the beneficial part is that it is implanted in a location which is easier to conceal, a factor that may be especially important for female patients, because we are implanting it in the axillary area, which can be very well concealed in female patients. So this is the subcutaneous ICD in the axillary area, and this lead we have to tunnel it and to the xiphoid area, and then from the xiphoid area to the parasternal area. It can either be a left or a right parasternal area. So as far as the measurement is concerned, so it is basically, if we talk about, it is large, but thickness wise it is same. The pulse generator thickness is same like the transvenous ICD, but it is bit larger. And since we are implanting it in between the muscles, so we have an intermuscular technique in which the device goes in between the serratus anterior and the latissimus dorsi, which makes it more cosmetically better, reduced risk of pocket infection, better device positioning for defibrillation threshold and impedance measurement. And this is the intermuscular device implantation technique. So, so it is easier to conceal. That is why it is better in female patients, and intramuscular technique is far better to conceal the device. So who should receive this subcutaneous ICD? So actually, frankly speaking, every patient should receive this subcutaneous ICD. Those patients who are candidate for ICD and those patients who do not require a bradypacing. So young patients, HCM, ARVC patients, prior infection patients, CKD patients, difficult venous access. So prior infection, difficult venous access, we have no option for these patients. These patients have to be implanted as subcutaneous ICD. But even if prior infection is not there, difficult venous access is not there, in young patients, we should go for the subcutaneous ICD. So proposed treatment algorithm, if patient requires an ICD and he requires a CRT as well, that the patient has LBBB or patient has pacing indication, we have to go for an CRT. So if patient does not require a CRT, patient does not require a pacing indication, just a monomorphic VT, we should consider subcutaneous ICD first. So SICD has evolved from just nice therapy to frontline ICD strategy. So thank you for this presentation, and any questions about this ICD is welcome.
Very nice presentation. I have 3 questions basically. Yes, so can you highlight some screening for subcutaneous AICD, and whether for the procedural point of view, GA is mandatory, or and third one is defibrillation threshold is mandatory after implanting the device?
Fine. So coming to the second question, sir, it hardly takes 30 to 35 minutes. So implanting a subcutaneous ICD in expert hand, it takes lesser time than a transvenous ICD, because we don't have to take a puncture. So many times puncture is, difficult in many patients.
GA.
No GA.
So tunneling and all.
No GA, not at all. It's very, very easy procedure. Procedure-wise, it is very, very easy. It's not a challenging procedure. So before implanting a subcutaneous ICD, so we have to screen the patient. So Boston team will come. They will screen the patient in the OPD, and so there are 3 vectors in these patients. So they have to screen for the vectors. So even before implantation of the ICD, I mean in the OPD basis, they will screen the patient whether the patient is fit for ICD or not. Fit means whether the vectors will match or not. So if vectors will match, then only they will tell that, sir, this patient, you can go for ICD. Otherwise, they will straight away refuse that this patient is not at all suitable for an ICD. And what was the third question, sir?
Defibrillation threshold.
Yes. So we usually do defibrillation threshold in these patients. Yes. We induce VT, give shock to the patient. This gives us confidence that it will work fine.
Without checking this?
We can do that. So we have done cases without checking that as well.
What about defibrillation?
Just about vectors should be there. So we have 3 vectors. If we have good vector, 2 vectors out of 3 vectors are matching, then it's perfect.
What about defibrillation threshold when compared with the normal ICD? Is it higher or something?
So basically, it gives a shock of 80 joules. As compared to the normal ICD, which gives, I think, 30-40 joules shock, it gives a shock of 80 joules. It has only one option of giving 80 joules shock. As I said, that it has no Brady pacing. It cannot give anti-tachycardia pacing, but it can give post-shock pacing in a VVI mode for 30 seconds. So post-shock, it will see that if patient does not develop a rhythm on his own, it will give pacing for 30 seconds. So this is there. That will be a transcutaneous pacing, the device and the lead. So that both will synchronize and give transcutaneous pacing to the patient. So it has pacing, but it is only a post-shock pacing with an 80 joule shock.
And usual battery life?
Yes. So the usual battery life is around 8 to 9 years. So in US, they have a device. Already they have a device which has a battery life of 10 years, and they are still working on newer devices which will have a longer battery life.
So one had to take the help of surgeon?
No need of surgeons, sir. No need of surgeons. So even for pacemakers, we don't need surgeons. And but yes, if we take help of surgeon, then there's no harm in taking help of surgeon.
Just one question, Dr. Kus.
Yes, sir.
In pacemaker, what we have seen, the most common infection is a pocket infection.
Yes, sir.
When you are putting a subcutaneous ICD, means I don't have any idea, just a query.
Yes, sir.
Because that is a long tunnel. Will the infection rate, will it be lesser? Because the most common infection is a pocket infection. It's not beyond that. And when you are putting a subcutaneous ICD from whatever this space to this parasternal area, it will be a long subcutaneous tunnel.
So the tunnel will be only of the lead, sir. Pocket is only in the axillary area. And then we are tunneling and then entering in, but we're not entering in the vasculature. We are just in the subcutaneous area. So I'm not saying that pocket infection cannot be there in subcutaneous ICD. So in all the trials which
you said that there are some trials which showed nil pocket infection.
Not nil, sir, but significantly less pocket infection if we compare subcutaneous ICD versus the transvenous ICD. But pocket infection can be there, but not 0%, but lesser than the transvenous ICD.
Addressing his query, so tunneling is not a major surgical procedure. Pocket is a procedure you dissect the muscles, but tunnel you can pass a subcutaneous tunneler and pass the lead through it.
Yeah,
so
but
it's a very less space is there, and chances of infection is very, very less.
Yeah, but so intermuscular, I think
it's
it will
not
be.
Intermuscular.
Subcutaneous.
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 So tunneling.
So we do grafts by tunneling. So it doesn't increase the chances of infection.
And for your second question, CKD patient bilateral subclavian occlusion, and if vector is not appropriate for subcutaneous, then what is the option?
Then we have an option of extravascular ICD, which is called it as EB-ICD. So for EB-ICD, so this basically I told that this lead needs to be placed in the parasternal area. So this is above the sternum in the parasternal area. So now we have EB-ICD as well, which is in which the lead has to be placed behind the sternum. And for that, we don't need to screen the patient. It can be implanted in each and every patient. But just that it is a bit costly.
Dr. Kush, axillary area is more unhygienic than the infraclavicular area.
Okay, sir.
So there is more chance of infection through hair follicle in comparison to the infraclavicular area.
It's a point taken, but just that the trials didn't show that. But then we have a lot of vascular complication risk, which is reduced since we are not entering the vasculature. And systemic infection risk is 0%.
I am talking about the local infection.
Yes, sir. Yeah, I got it, sir.
Actually, subcutaneous ICD is not in the axilla. It is much below.
Very below the axilla. I mean, in the axillary
area. In the latissimus dorsi area, not in the axilla.
But still, it is very unhygienic in comparison
in
to
the fifth and sixth intercostal space, much away from the axilla.
That is why we place it in the intramuscular area, sir, in between the two muscles, which makes it more friendly to the patient.
I also disagree with you because this is the area, infraaxillary area is the line of incision for the minimal invasive procedure, cardiac procedure. So it cannot be considered as a major infective area.
So I think we should have surgeon with us always.
So one question, Dr. Kush, please. Since the magnitude of shock required here, it is 80 compared to 35
yes,
what is in the transvenous ICD. So does it cause more pain, and
yes,
especially
it
because
is more painful.
Yeah, because it
Yeah,
is
yeah,
skeletal
it is more
muscle, more nerves there.
Absolutely
so
right. It is more painful, ma'am. Thank you so much, everyone.
Thank you, Dr. Kush.
Thank you so much, Dr. Kush. With this, we close this penultimate session.
Thank you everyone for being on desk. We will close this session, but the program will be ongoing. Now we will move on to the banquet dinner. After banquet dinner, we will be having nightmare session, which will start at sharp 10 p.m. That will go up till 11:40 because we have 6-7 speakers who will show their nightmares. So I welcome everyone for banquet dinner. I welcome all faculties, all presenters, all discussants to move on to the Darbar Hall for faculty dinner, and to to Kautilya Hall. I will welcome all the delegates, all the technicians and industry people for banquet dinner.
कैसे आप लोग कैसे लग रहा है? थोड़ा साउंड कम है, इसके लिए मैं माफी चाहूंगा। हम लोग को लाउड साउंड में बजाने लगा।
Thank you for such a wonderful moment. I think everybody had his dinner. So now we move on to our next session, that is the nightmare session. We have planned it in such a way that we will proceed after dinner. And the main moderator of this session, Dr. Vijay Trehan sir, his flight is delayed, so he is unable to arrive till now. He will arrive in between, the session is ongoing. So I will request everyone who is present outside the hall to gather in the hall so that we can start this session. For discussant, I will like to call Dr. Shaheen Ahmad on dash, Dr. Vineet Kumar, Dr. Pratap Kumar sir, Dr. Chandra Bhanu Chandan, Dr. Mahim Saran Bose, I will also like to call Dr. Amit Kumar, who is here on stage. In between, he will be presenting his case too. And for being a discussant, I will call Dr. Ashish Tiwari. He is here. So kindly be on stage. Dr. Pawan Kumar Singh, he is here. Dr. Pratap sir is coming here from the room. It will take 2-3 minutes for him. Dr. Deepankar Vats is sitting over there. Kindly come on stage. So we will start this session with first speaker, Dr. Chandmani Adhikari. Initially, his topic he submitted for the nightmare. Basically, it was a coronary case.
Thank you very much for the invitation. I am from Kathmandu, Nepal, and I am an adult intervention cardiologist. I started my career as a coronary interventionist, but these days I do congenital and structural intervention in adults. So I have completed 10 years of my AST, or you can say congenital heart intervention career. So I started in 2016 with the help of Dr. Kumar and team, and from that onwards we do more than 300 AST device closure, more than 150 PDA device closures, and also TAVI and other things in my hospital. So I'd like to share my experience on AST device closure tips and tricks. So my presentation will be in two parts. So first one is how I do. Secondly, in simple case, what we usually do, and when the cases are challenging, what we need to do, and last I'll share 3 short cases. I'll try to finish on time. So before I start AST device closure, what we do is we do echo and TE to look for an indication and contraindication, proper echo or TE to evaluate the size of the AST, and transmissible echo to evaluate rims, especially in adults. So how to select the ideal AST device size? Ideal way is use a sizing balloon, but in third world country like ours, it will add cost. So how it's done is 1 to 2 mm bigger than the sizing balloon diameter stop flow diameter. So that's the ideal way to do, but because of the financial reason we don't follow this. What we usually do is we use a simple formula. If the AST is less than 60 mm, same size, or you can oversize by 1 or 2, 70 to 32 AST size plus 2 mm more, and if it's more than 32, AST size plus 4 mm. But if there are limited rims, just like in some cases there will be very floppy rims, or especially the aortic rim is absent, you can add some more. So that's how it's done. So after we decide the ideal size of the AST device, device closure process starts in the cath lab. Even they do in China, they do without the cath, or outside they do in the echo lab also, but usually we do in cath lab. And selection of the suitable delivery system based upon the device size. So in the standard approach for simple AST, the LA disc is deployed by pushing the cable over the delivery system. Once the LA disc is formed, the whole system is pulled towards the septum. After the LA disc reaches the septum, the delivery system is pulled. RA disc is formed in RA, and the RA disc is gently pushed towards the septum. So this is a simple procedure. So this is how it's done: femoral vein cannulation and pressing a sheath, then reaching the left atrium from the right atrium, then amplatzer superstrip wire in the right upper pulmonary vein. Usually many prefer to do it with the left upper pulmonary vein, but my approach is I always go from right upper pulmonary vein. Then we introduce a amplatzer superstrip wire in the right upper pulmonary vein in the JR catheter. Then a required delivery system is introduced. Through that delivery system, a device is introduced, and then we just LA disc is deployed, we retract the whole system, and as it comes near to the septum, then what we'll do is we peel off the delivery system and then push the right disc. This is the standard way. Before release, always look for echo. In selected cases, even we don't require echo, because the image itself will confirm that the device is in position. Not only that, we can, as I said, regularly it's done from the left upper pulmonary vein. It's almost the same. But the thing is, we wish that the LA disc will come to us the IS in a parallel way or at the 90 degree, but it's not the case. This is the ideal way. But in most of the cases, it doesn't happen like this. What will happen is the LA disc will slip towards the RA. So if we deploy in this way, that this device would get immobilized. The reason is when we pull, it should come parallel to the septum, but the thing is somehow the disc, the LA disc gets slips towards the RA because we cannot have an ideal pull. We cannot pull the device at parallel to the septum. For that, in those cases, it's known as a complex AST device closure. In simple, it's a small AST, single AST, all rims are present and the rims are good, means it's not floppy. In complex means large AST, especially if it is more than 25 mm of device. Multiple AST is 1 or 2 or device AST are there, deficient or absent rim or floppy rims or enraged rims. Then the device closure will get complicated. What are the techniques for this complex AST? There are 4 ways. Change the orientation, slide out technique, use a different sheath, or use an additional hardware. The simple way is, the first maneuver is just make a clockwise rotation so that the device comes parallel to the septum and the LA disc doesn't slip towards the RA. And there is a grip maneuver and in situ tulip bud technique. It helps to prevent the LA disc prolapse into the RA. So these are the simple techniques by which the procedure can be done in the complex setting. And the other one is the slide out technique. Most commonly used is the slide out technique. It prevents the LA disc to prolapse into RA before the RA disc is formed. There are 2 techniques, pulmonary vein techniques and LA roof techniques. In pulmonary vein also there is a left upper pulmonary vein technique or right upper pulmonary vein techniques. So how it is done? The delivery sheath is placed in the pulmonary vein or LA roof. The LA disc is deployed in the pulmonary vein itself, not in the LA. And the sheath is swiftly withdrawn to deploy the RA disc. The device resembles as an American football and the LA disc springs out of the vein and slaps onto the septum. So this is how it is done. In the regular one, the LA disc will be deployed in LA, but in this case, the LA disc is deployed in the left upper pulmonary vein before the RA disc is formed. Then only the LA disc comes towards the septum. This is the difference between the regular and the left upper pulmonary vein. And the same technique we can deploy from the right upper pulmonary vein. So when to use left upper and when to use right upper pulmonary vein. If the device is small, go for right upper pulmonary vein. If the device is bigger, go for the left upper pulmonary vein technique. This LA roof technique, same like the previous one. And we can use additional sheath, but it needs cost. Cost is involved. Just like hand roof sheath technique or SSH technique or Kuti method, you need to buy a new device or you need to change the device delivery system, which we usually do because all other procedure can make the procedure simple. You can use the additional hardware, just like wire assist technique, catheter or dilator assist technique, balloon assist technique, but this needs additional vein cannulation, not only from right but also left. So in the wire will prevent the LA disc to prolapse into RA and the procedure will be easy. In the same way, we can use the catheter. It prevents the same LA disc to prevent into RA. And then other technique is balloon assist technique, in which the balloon is used so that the LA disc doesn't prolapse into RA. And not only that, sometimes if you are experienced, you know that the anterior superior part of the LA disc is slipped towards the RA. So in this case, what we do is we usually gently push the cable so that the LA disc will prolapse towards the LA. Before you push it, it will be on the RA side. But once you give a gentle push or a strong push, then the LA disc will, the anterior superior part of the LA disc will prolapse towards the LA. And in some cases, you need to combine both techniques. Just like in this case, it was absent aortic rim in Nepal. Most of the, almost 70% of the cases, don't have anterior superior rim or aortic rim. So what we do is we combine the procedure. Just like in this case, we started from right upper pulmonary vein technique, but the thing is, we came to know in this image only that the anterior superior part of the device got prolapsed towards the RA. So what we did is we gently pushed it and the procedure got successful. So multiple AST, if there are 2 AST, what you need to do is, if the distance between the 2 AST is less than 7 mm, you can do it with a single device. If it is more than 7 mm, then you need a 2 device. or you can use a cupriform device. This is for multi-frequency AST. So this is the first case we have done, 2 AST, you can see on the left upper part, and then we did with the 2 devices. But in this case, you can see there are 2 devices separated by a thin rim. So what we did is this is a video, and in 3D also we confirm that there are two AST. You can see there is a thin rim in between, and we completed the procedure with a single device. So there are 3 short cases, so I'll complete it. This is AST device closure in dextrocardia with situs inverse totalis. Unless you have a good anatomical knowledge, you will not be able to complete this procedure, because this is a very rare case. We have done 3 cases so far, and 2 got successful, and in 3rd case device got embolized. So we published this. You can appreciate that we did it in the dextrocardia. And we, being adult interventional cardiology, we can combine these procedures. Like we combined the AST device closure and BPB. We did the BPB first, and after 1 month, we called the patient, and again, then what we did is we did AST device closure. So this is the case. And also, as I do coronary intervention also, what we did is we found that patient had AST and there is a coronary disease. What we did is we deployed the device first, and in the same setting we did the PCI, and then came out. So in conclusion, AST device closure for a simple case is very straightforward. Complex AST requires extra effort. With extra effort, many difficult AST cases can be closed. And it's a great honor to present AST device closure tips and tricks in front of my mentor, Dr. Kumar, who is here as a moderator. Thank you, sir, for being here and mentoring me in last 11 years. Thank you, sir.
Any question from audience? Okay, thank you, Dr. Chandamani.
Thank you.
So I think the rest of things are absolutely fine. Very good cases. Only thing, when the ASD and PCI to be done, it should be done in separate setting. There's no need to. After PCI can be done, ASD in a separate setting, because
it can be done.
2 elective procedures should not be done simultaneously because risk of complications is already there.
That's previously we have done few cases on the separate setting.
No, nothing else. You can do 100 cases without any issue, but there is no need to do it simultaneously. That's the only thing.
Actually, which are the cases where you just tell that these are the cases not to be done?
So usually what I don't do in those cases where rims are absent, just like not only, I'm going to explain, just like if aortic rim, in most of the cases, aortic rim is absent, okay? But apart from aortic rim, if other side of the rim, just like anterior superior, anterior inferior rim are absent, in those cases, don't do it, because the chance of embolization is very high. If the rim, especially AV rim, is very small, less than 5 mm, don't do it, because it will create a problem on mitral or tricuspid valve. That's the one. And if the IVC rim is absent or very small, don't do it, because the chance of embolization is very high.
How big you can close with device?
So currently in Nepal we have just 42 mm device. The maximum size available is 42 mm. So I have closed up to 36 mm of AST, but there are some custom made devices. It comes up to 52 mm. So in that case you can go up to 42, 44 also. But so far I have done 3 cases with a device of 42 size. It's not available with the Amplaza device, it's available with the Chinese company only.
Actually, we should appreciate that Chandramani Adhikari started the device program in Nepal, and that is, he has done more than 200 devices in a year. That is actually tremendous work done in this country. KK, any comments, please? Any comment from the...
No, actually, I did not start, but I did it in the different way. Previously, my seniors, they used to do AST device closure under general anesthesia. So in 2016, I started without general anesthesia. It's local anesthesia. So after that, we do nearly 300 plus cases in a year.
Actually, he changed the paradigm of that country as such. The pediatric interventions have gone in a very high level. If there are no more questions, we can go to the next presentation. Thank you, Chandramani.
Our next speaker is Dr. Amit Kumar from Gaya. A piece of cake until it was not acute vessel closure.
Good evening, everyone. So I'll be presenting a piece of cake until it wasn't an acute vessel closure during routine PCI. So, a 46-year female presented with chest pain for 5 days. ECG, there was acid depression, vital stable, top T was positive, echo was normal. So it's a case of NSTEMI with EF 55%. Angiography was done. So we can see that LED had only mid 90% for tubular lesion. L6 OM has 70% proximal and mid to 60%, and RC had only mild plaquing. So plan was to do focal stenting to mid LED. So I just used a very floppy wire, BMW wire, crossed pediatration with Sapphire SC at 8 ATM. And the vessel had opened up with the good flow. Just after that, patient complained of severe chest pain. So, and ST was up, and there was spasm just distal to the pit dilatation. So I gave vasodilator, Nicorandil, NTG, but still the spasm was not going and patient had severe chest pain. So, and she was becoming hypertensive, so I had no option, so I just did prolonged balloon dilatation with 2.5, again SC for 32 seconds at 3 ATM. And after that, we can see that there is a spiral dissection flap which is visible, which the flap is visible in the mid is straight, that is parallel tract, and distally there is transverse tract. So it was a NHLBI grade T, that is spiral dissection. So in this case, I had to stent because patient was having severe chest pain and she was getting hypertensive. So I just took a 2.75 into 24 mm stent distally deployed, and again we can see that after stent deployment the dissection was again increasing. There was filling defect proximally, distally there was spasm, and patient again had severe chest pain. And we can see that in the last video that there was no flow and proximally the dissection was increasing. So I had to again put another stent of 3 into 36 mm to distal, and after that there was good flow distally and patient was stabilized, and we can see there was good flow distally, and proximal there was disease, so I had to put one other stent. So I had to put 3 stent. Actually the plan was to do 1 stent, but because of the complication of dissection I had to place 3 stents. So 3 into 28 mm disc deployed proximal to mid LED, and postdilated with 3 into 12 proximal to mid and proximally 3.5 NC. So after that there was a good flow in the vessel, we can see. So actually it was a case of single stenting, but at final we had to do 3 stent. And yeah, but the diagonal was compromised with me 1 flow. So what are the differential of acute vessel closure? So it's either dissection, coronary or atacoronary, thrombosis, embolization, either thrombus, plaque, air, side branch occlusion, spasm, pseudolesion, or equipment entrapment or internal hematoma. So most important is that we have to maintain Y position, we should determine the cause, and we have to have good hemodynamic support and treat accordingly. So for spasm, we can give intracoronary vasodilator, we can give prolonged balloon inflation, or thrombus, we can give GB2B3A. And most important is dissection. If it's more than grade C, then we have to do angioplasty. And one is differential is IMH, that is sudden vessel narrowing after balloon inflation and distal propagation after further balloon dilatation. So this is the strategies. So my case was of more than stage C, so I had to do angioplasty. So next case.
So 65-year male with inferior MI and EF of 40%. Angiography done, so LG had very mild plaquing, 30-40%. And we can see, yeah, but RCA was very tortuous RCA. We can see the tortuosity of the RCA. Distal was 100% occluded, and mid to distal there was 70% lesion. We can see the tortuosity of the RCA. It was taking it to bend. So it was a tortuous RCA with twin shepherd crook, where varied with the proximal part of RCA takes a tortuous upward course, shepherd crook. So approach is either we can use body wire guide extension to increase support, increase guide backup with AL, macrocatheter, or hydrophilic wire like whisper, specialized balloon, meticulous vessel preparation, and short insert stents. So I used body wire. I just crossed the 2 wire, and after that I did pre-dilatation. So after that the vessel got straightened, and there was spasm. That according effect was seen. There was good flow distally, but proximally there was a spasm. And after wire straightening, we can see the concertina effect. So as vessel was tortuous, I had 2 stents planned. So I just took a small stent of 3 into 23, and after that I deployed the stent, and stent was deployed, and after that patient again had very severe chest pain. We can see that there was complete no flow. So I was not knowing whether it was a dissection or a concertina effect, because at that time I cannot withdraw the wire and see that whether it is concertina effect. So I had to put another stent. So after that I just put another stent, and we can see that after putting the stent there was some flow distally into the vessel. So after that I just put another stent, and there was good flow distally. So the vessel got straightened, and there was good TME3 flow. So a steady hand begins with the patient mind. Thank you.
Can I have the first case?
Yes, sir.
Looks like spontaneous coronary artery dissection. So
Yes.
once you put stent, the dissection, the hematoma which was in the intima,
Yes, sir.
gone proximally and be occluded the artery.
Yes.
So you need to put 3 stents.
Yes, sir.
Make
It was
it,
case of single stent, but I had to place 3 stent.
and second case, the
Tortuous
between the
RC.
2 area stent, I think it's under expanded. Otherwise, we cannot do with the Judkins. We always do AL.
AL, yes,
AL is
sir.
my choice.
Yes, sir.
And if required, guide extension.
Yes.
मैंने क्योंकि लास्ट में ज्वाइन किया, आई डोंट थिंक आई विल बी एबल टू इन ए गुड पोजीशन टू कमेंट, बट व्हाट आई अंडरस्टैंड इज ये टॉर्चस नाड़ी है. टॉर्चस नाड़ी के अंदर ना एक इसी प्लान करना चाहिए पहले आपको. अगर प्लान नहीं करोगे तो फिर हाफ वे थ्रू बड़ा मुश्किल. अब सी व्हाट यू हैव डन इज फाइन, लेकिन आपने वो सिलवटों के ऊपर स्टैंड लगा दिया.
ACS था
वो ये दिस इज ए फैक्ट. आप प्लानिंग कैसे करनी है इस तरह के केस की? कभी कभी अगर मान लो ऐसा हो गया, डरना नहीं है. आपके पास माइक्रो कैटर होते हैं, दूसरी तार होती है, माइक्रो कैटर डालो, दूसरी तार डालो. आप इसी जो जैसे तुम्हें समझ नहीं आ रहा कि आगे भी डिसेक्शन है, थ्रोम्बस गया क्या, समझ नहीं आ रहा कुछ.
Yes, sir.
एक कोई सा बैलून लो, उसको थोड़ा बैलून को पंक्चर करो, उस बैलून को इसको ऊपर ले जाके आगे देखो सर्कुलेशन फटाफट दिख जाएगी. सर्कुलेशन क्या आपको. समटाइम यू कैन जस्ट प्लान सच ए केस बाय हैविंग ए सॉफ्ट गाइड एक्सटेंशन. ये सारी कहानी जो तुम्हारी, आई हैव जॉइंड वेरी लेट, बट इफ यू हैड ए सॉफ्ट गाइड एक्सटेंशन तुम्हें सब कुछ दिखता है एंड तक. और ये था ना डर में मैंने एक छोटा लगा दिया स्टैंड, फिर एक छोटा लगा दिया, फिर बाद में एडजस्ट कर रहे हैं भी कैसे देंगे दूसरा स्टैंड. उसको पेशेंट को तो हमने एक के लिए बोला था.
Yes, sir.
Such area, such vessel can be very easily stented with a guide extension with a 60 mm stent. एक स्टेंट से आपका सारा काम पार हो जाता है. अगर आपके पास एक्सटेंशन हो, आप डिस्टल एरिया आराम से देख सकते हो. फंस जाओ और आपके पास कुछ भी नहीं है तो खैर ठीक, बड़ी वायर कैन हेल्प यू.
Yeah, here in very tortuous artery, no, recrossing also require plastic coated wire. like whisper or so. So
I use
whisper,
that bar only. I use
whisper extra
bar
support,
only. Yes, sir.
but extra support will cause concertina, but you have to remember that which area was not disease and which area was disease. Only then you can stent, because proximally you stented, that area was accordion effect.
Yes.
Concertina, so there is no
Yes,
need.
sir. Yes.
And always do with the L.
Yes,
L is my choice.
Yes. Thank you, sir.
प्लास्टिक कोटेड वार लो लेकिन relatively non support वार लो, उससे कंसर्टिना का effect relatively कम होता है.
Yes, sir.
But still
Sometimes you just take a micro catheter and a soft wire, वो चला भी जाएगा, and because a soft wire जिसकी body relatively less supporting है,
yes, sir,
वो you'll be able to see the whole vessel despite the fact you have a wire very distal. And second thing is जब आप इस तरह के केस को देख रहे हो, see your lesion was all proximal, क्रक्स से पहले है सब कुछ, जो भी कुछ है, tortuosity भी पहले है, सब कुछ उससे पहले है. So you do not necessarily need to have your wire far deep, especially अगर आपके कोई extension अच्छा है. If you have a right Judkin, you do not have an extension, then you will fight. अगर आपका guiding अच्छा है, M+ type है और आपके पास extension है, then you don't necessarily need to be very far off. And if you are not very far off, तो आपका concertina अपने आप ही कम हो जाएगा. You want to take the support, you take the wire very deep. If the wire goes very deep, the stiff part of the wire,
yes, sir, and there is concertina, yes.
Then it becomes difficult.
Thanks.
While stenting, actually, we should remove that gelled wire. The both wire was in place while doing the stenting.
Yeah.
Ideally, we should remove the
support because of the increased support. So if
no, what he's saying is once you have अपना स्टेंट वहाँ पहुँचाने के बाद ना फिर सपोर्ट की जरूरत है ना.
Yes, sir.
फिर खींच लो.
Our next presentation, Optimizing the Error, RCA Plasty by Dr. Kamlesh Kumar.
Namaskaram.
I'll request the discussants to intervene.
In between, yeah.
So
Yeah.
I feel that there is a point which needs to be clarified, because these people who have come here, everybody, including me and everybody, wants to learn everything. So they feel that there is a point which needs to be clarified. I request them to stop.
Heading भी तुम्हारा optimize the error मतलब.
Like sir. So like this case is about like one acute inferior wall MI like some 6 months back. So I also reviewed this CD, like the CD was of 6 months back. So that
देखो
was
तुमने
my
CD बहुत ज़्यादा अपनी stretch की हुई horizontal.
Sorry.
इतना horizontal कर दिया, इसको पता नहीं लगना. This is more like a cartoon. कार्टून में एक नाक बड़ा कर दिया कुछ चाहिए, वो ये split it horizontally, ये बिल्कुल गलत है.
Fine, sir. So this case was like, we took up this case, and like when we brought this case, like so this we planned and we took this case for RCA plasty. So thus hooking was difficult, although after fine. So after slight negotiation, I was able to hook with JR catheter, and this was like this picture is different from what we actually saw the CD like which was of 6 months back. So since we already hooked, we planned to do it like, and we started with workhorse wire BMW, but we could not negotiate. So
इस तरह के रीजन में पॉलीमर जैकेटेड वायर बिकॉज यू डोंट नीड एनी सपोर्ट. यहाँ तो आपका चैनल में गलत नहीं जानी चाहिए. पॉलीमर जैकेटेड वायर यानी कि व्हाट प्रताप इज यूजिंग फॉर रेट्रोग्रेड, यू कैन यूज एन XTR है सॉफ्ट वायर, बिकॉज उसकी चोंच छोटी सी बना के आराम से निकल जाएगी. एक चीज़ है सिर्फ वायर प्रॉपर क्रॉस करना इसमें.
I will tell you that these type of cases, when you get any wire, the wire goes to a small branch is also very good. Then you can take the next wire and then that stabilizes the first. That is the first and foremost thing.
The guide looks tapered. What's the reason? You see, tapered guide, I have not seen tapered guide.
वो taper ऐसे हो गया ना, मैं उसने लंबा कर दिया ना, इसकी length ऐसे कर दी तुमने.
This should not be. I can't believe.
So maybe sir, like not ETO, new only, but like I think it took a lot of like I took a lot of time to hook actually. So maybe deformed while hooking. So this we took whisper.
Fatigue of the tip of the catheter happened. That is why it is.
I have never seen like that. That's why I am worried.
To see a lot.
So with slight negotiation and balloon support, this wire actually went, and we ballooned it with. This is whisper wire, sir.
देखो balloon support generally इस तरह के केस में वैसे अवॉइड करनी चाहिए. जब तुम्हें एक रास्ता दिख रहा है ना, तो उसमें तो सिर्फ आपकी ये फिंगर मूवमेंट चाहिए, एंड द वायर शुड हैव ए गुड कोट ताकि अड़े नहीं कहीं. बैलून सपोर्ट से कई बारी ये स्लाइट किंकिंग जो बीच में आपको ट्रिचरस सा कोर्स है, वहाँ पे 70 मल एक बार चलिए फिर काम खराब हो जाता है.
हाँ जी सर.
दिस इज नॉट एन एरिया अकॉर्डिंग टू मी which needs a balloon support for crossing. I will almost never take a balloon support.
Okay sir.
That's very good. Micro catheter रख सकते हैं आप पीछे, लेकिन आगे वायर आपके बिल्कुल सॉफ्ट होनी चाहिए. ये तो क्रॉस हो गई है, बट इट इज पॉसिबल कि दिखा रहा है कि क्रॉस ही नहीं हो रही.
It crossed easily only, sir. With only slide balloon support, actually it went easily. And like so we ballooned it with smaller size balloon, and then we took 3 into 38 stent size, and while deploying it was like I felt I am almost at the ostium, and we inflated it.
You think the disease was starting from the os or not?
Sorry sir.
ये इसका disease os से शुरू हो रहा था नहीं हो रहा था?
सर जो सीढ़ी हमने देखा था द लास्ट
नहीं, उसको छोड़ो यार. अब तुम जो देखो ना, अभी तुम्हें यू मस्ट नो द लैंडमार्क्स. अगर डिजीज ऑस से शुरू हो रहा है तो तुम्हारा स्टेंट ऑस पे लैंड करना चाहिए और 1 मिलीमीटर इनटू द एओर्टा.
No, actually,
और अगर ऑस से लैंड करना चाहिए तो दिस इज नॉट द करेक्ट वे.
The lesion actually which we saw actually was not in the os sir, like it was in the proximal segment.
Okay, it was very capacious os. अगर capacious os नहीं है, then you cannot say disease not at the os in the absence of imaging. See, the worst thing is एक स्टेंट लगा दिया, उसके ऑस पे कुछ रह गया, स्टेंट थोड़ा बाहर आ गया, अंदर आ गया, या करके भेज दिया, 6 महीने के बाद पेशेंट स्टेंट के 3 मिलीमीटर प्रॉक्सिमल लीजन लेके आ गया, कहीं और चला जाएगा, वो जाके तुम्हें गाली देगा, और 3-4 मिलीमीटर का लॉन्ग 3.5 मिलीमीटर का स्टेंट लगा के वो बड़े खुश होता रहेगा. मतलब फॉर ए वेरी स्मॉल लिटिल मिस्टेक विच यू डू समटाइम्स इन द फर्स्ट प्रोसीजर, you may have to pay heavy price. According to me, when you are deploying a stand, you should be very sure कि आप कहाँ लगा रहे हो stand.
So yes sir, the same mistake actually we did actually. So like after seeing this, like distally also in the mid segment also there was some lesion. So we deployed one more stent there also. After deploying this stent and taking out the wire, now we are seeing like one more ostia is missed. So this we took sir one LAO caudal view also. So, oh yeah, while deploying also probably we missed sir, like this ostium we missed actually sir. So and this time we are out with wire also, but fortunately enough, like we did NC for both of the stents at this stage. So we took the wire again and took this time we took the stent and deployed in a hanging JR. This time we took 3.5 into 12 stent. And
why don't you keep a floating wire? सेपल वायर टेक्निक होती है ना इसमें कि यू पुट वन मोर वायर, पुरानी सी वायर अपने हर लैब के अंदर जो वायर आपकी बिल्कुल ख़राब हो जाए उसके ऊपर फ्लोट वायर लिख के उसको रिसाइकिल करके रख लो, बिल्कुल टिप विप जिसकी बिल्कुल ख़राब हो, जिस बिल्कुल खत्ते में फेंकने वाले वायर हो उसको रख लो. Then what you do is, while trying to deploy this stand, pass that wire alongside this, let it get out of the tip of the guiding catheter and float in the aorta. Now what will happen is, this wire especially अगर इसका soft part काफ़ी दूर चला गया और stiff part आ गया tip के पास, मतलब soft काफ़ी दूर है, tip के पास stiff part आ गया. Now this wire will not let your guiding catheter jump into the vessel. Left हो चाहे right हो कोई सा भी, वो aorta को छोड़ के ब्रांच के अंदर यानी कि राइट या लेफ्ट कॉर्नरी आर्टरी के अंदर नहीं घुसेगी. एंड दैट आल्सो गिव्स ए वेरी गुड लैंडमार्क. समटाइम योर फ्लोट वायर इज गोइंग नीचे से, वो नीचे जाके ऊपर जा रही होती है, एंड योर रूटीन वायर इज गोइंग टू द मेन वेसल. तो उसका जो एक बाइफिकेटिंग पार्ट होता है वो भी आपको बता देता है कि यहाँ, एंड वहाँ कंट्रास्ट भी डल जाता है, मतलब इट गिव्स यू ईज, आसानी से डल जाता है. बिकॉज आई एम नॉट, पहले में हो सकता है ना हो, लेकिन जब मिस हो गया ऑस्टियम और फिर ऑस्टियम पे लगाना है तो फिर तो रखना चाहिए. There are special methods also, special techniques and special stents जिसके अंदर आप बिल्कुल ऑस्टियम पे एक फूल सा फुला कर लगा देते हैं. But those things are not available in India. That is known as osteopro.
Special balloon. That is an
नहीं, balloon is osteoflash balloon, that is to funnel up the ostium. But there is a device known as osteopro device. उस डिवाइस में क्या है कि जैसे आपका गाइड एक्सटेंशन है इसी तरह से हो जाएगी. गाइड में से बाहर निकलते ही उसके 4 ब्रांच यानी कि 4 ब्रांचेस ऐसे निकल जाती, मींस दे विल कर्व आउट ऑफ द गाइडिंग कैथेटर. अब वो चारों ब्रांचेस जब फूल सा बन के बाहर आ गई, वो फूल अंदर नहीं घुस सकता कॉर्नरी के, तो दैट विल प्रिवेंट योर गाइडिंग फ्रॉम जंपिंग इन. बस उसमें तो फूल जहाँ से आपका डाइवर्ट हो रहा है वहीं स्टैंड लगा दो बिना देखे.
One basic thing is actually, as Dr. Pramod told, you should have checked in 2 projection to understand that whether the vessel is, before standing you should understand from where you should start and from where you should end. This is to be understood in one more projection. Because everything was running in one projection. That may be the reason that you would have missed that. Probably in the first injection, probably the ostium, you are thinking that it can be 2 millimeters away from the ostium.
And ostium of RCA is best seen in LAO caudal view. Give 20-degree LAO and make caudal.
No, he did LAO caudal also, but that LAO caudal is for a normal takeoff of the right coronary artery. About 15-20% people will not have that normal takeoff, and in those cases, your ostium may be defined in steep LAOs or lateral views, and sometimes just in the AP view. So let us, one very simple way of finding the ostium is, मेरा एक simple तरीका है, आप याद कर लो. Let a balloon get out of the tip of the guiding catheter. बलून आपका गाइडिंग की टिप से बाहर निकल रहा है, उसका प्रॉक्सिमल एंड ऑफ द बलून आप गाइड के बिल्कुल टिप पे रख लो, डिस्टल एंड इनटू द आर्टरी. ठीक है. नाउ यू सी हियर, दिस इज अ प्रॉक्सिमल एंड व्हिच इज कमिंग, ये मेरा गाइड है, गाइड में से प्रॉक्सिमल एंड निकल रहा है बलून का, ये डिस्टल एंड है. अब ऐसे करते जाएंगे तो दोनों एंड्स आपके नजदीक आते जाएंगे, फोरशॉर्टन हो जाएंगे. सो ट्राई टू मेक एन एंगल लाइक दिस वेयर यू फाइंड द प्रॉक्सिमल एंड द डिस्टल एंड ऑफ द डिस्टल मार्कर्स ऑफ द बलून सेपरेट विद द मैक्सिमम. जहाँ मैक्सिमम सेपरेट हो रहे हैं, ये आपको बिल्कुल ऑस्टियम डिफाइन करेगा. आई थिंक आई एम नॉट क्लियर, दोबारा बताता हूँ. गाइडिंग में से बाहर जा रही है आपकी कॉर्नरी आर्टरी के अंदर, आरसी में जा रही है, एक बलून ले जाओ, बलून के 2 मार्कर हैं आपके पास, 10-15-20 मिलीमीटर का जो भी बलून ले लो आप. प्रॉक्सिमल मार्कर को गाइडिंग टिप पे रख लो.
ओके.
डिस्टल मार्कर इन द कॉर्नरी आर्टरी. नाउ यू ट्राई टू गिव एंगुलेशन फ्लोरो वाइज, जिस एंगुलेशन के ऊपर आपको प्रॉक्सिमल एंड डिस्टल मार्कर्स सबसे दूर मिलेंगे, लॉन्गेस्ट मिलेंगे, दैट एंगुलेशन टेल्स यू वेयर इज द ऑस्टियम. नहीं, गाइड बाहर करने के बाद भी, यानी दिस टेक्निक आई यूज्ड टू यूज फॉर रीनल आर्टरी. रीनल आर्टरी में वी नो दैट एलएओ के अंदर आपको ऑस्टियम बड़ा अच्छा दिखता है, बट यू पुट ए स्टैंड फ्रॉम एओर्टा इनटू द रीनल आर्टरी एंड देन कीप changing the angle. Whichever angle you find, the stent becomes the longest. See, जिस एंगल पे स्टैंड शॉर्ट फोरशॉर्टन हो जाए तो गलत है, इसका वो तो ऑस्टियम देख ही नहीं रहे तुम. ठीक, जिस एंगल पे वो लॉन्गेस्ट हो रहा है उसके अंदर आप डाई मार के देखो और आराम से, कभी गलती नहीं होगी.
Does
Fine.
this guide is JR?
Which one? This one?
Yes.
He will tell it.
No, but we have to see the shape and diagnose what is the kind of guide it is. So for me, it looks like extra backup RCA guide from Medtronic, or it looks like hockey stick.
But none of them will explain the taper.
Huh, that's the which I caught.
The main intriguing point is taper.
Yeah. No, that will not make taper. Guide. No, never.
Chalo. Next.
Thank you. Are you having one more case?
This is JR only, so like.
So Dr. Kamlesh, we have any more
he's-
cases? No,
Yes.
this was the last case. Right? So I think we have wonderful learning by sir, and so I think crux is that when there is osteo disease, I think there is no hurried plasty. We have to give time. We have to put a supple wire, and that's it. Thank you very much for this case. Thank you. Next case.
Next presentation is by Dr. Shiv Kamal, ventricular septal rupture closure in myocardial infarction.
Good evening, respected seniors, and very thankful to the organizers for giving time, and I am feeling very honored to present this case to my respected HOD sir. Ravi Vishnu sir is present here, and I had completed my DM just now, and this is my first presentation. After that, presently I am working as an associate consultant in Medicity Gurugram. This 90 years old gentleman having hypertension presented to the local hospital after 5 days of having chest discomfort, fever, cough, breathlessness, and there he was diagnosed as a acute inferior wall STEMI. At that hospital, coronary angiography was done, showing left main normal, LED having made 50 to 60%, LCX 30 to 40%, and RCA, mid RCA is 100%, and there coronary angioplasty under IVS guidance has done, and this still image showing that mid RCA has having 100%. Now that patient having post procedure developed shock, having pulse of 98, BP 90, Y42 mm of Hg and decreasing output. Then the doctors, they suspected patient having something VS, something different. So the immediately echo showing that basal VSR of size 11 mm, having left to right shunt and LV dysfunction of 40%, and IVC was full, and pulmonary artery systolic pressure of 60 mmHg. That patient was electively intubated and put on the IABP and shifted to the Medanta Medicity, Gurugram. Now, this is the if a patient
टेक्निकल पे चलते हैं, ये सब जानते हैं.
Yes. Now the clinical course, the day 0 patient having inferior STEMI, and after that day 5 shock and VSR detected, and at the day 7 transcatheter closure of VSR was determined, sir. So from the right femoral root, femoral vein, we have TPI. From right femoral artery, we have IAPP. So, and through the left femoral artery, we had 6 French sheath for the AV loop, and through the right interlongitudinal vein for 7 French sheath for AV loop to create rail for the closer for the device deployment, sir. So the procedural step, with the 6 French JR catheter with the floppy tip wire, thermo wire, we have crossed the ventricular septal defect, and through the right IGV through the snare, the flop tip wire was snared to the right internal jugular vein, and this thermo wire was exchanged with the stiff wire, and after that we have deployed the device, sir. So
Can I have a question?
Yes.
That means you snared twice.
That means?
That means you snared from the internal jugular twice. One, you snared the thermo, and then you took out the catheter from aortic side to the internal jugular vein, and then only you exchange, or you have to do the snaring of the extra stiff wire.
So what happens is
because we don't do that. We sometimes do with the extra stiff wire. Otherwise, because it will also tear, so we always keep a wire.
Cut through के chances होते हैं, तो इसलिए मतलब
इसमें सर क्या होता है कि once we cross the VSD and we park the wire in pulmonary artery or in the SVC if it crosses, and then what we do is that we advance the JR or the multi-purpose which we have taken to direct the wire across the defect. So once we are snaring, the cutting effect of the wire across the ventricular septal rupture comes down because the catheter is across the VSD. I'll tell you, I'll answer your question also. Once we have snared the wire out of the internal jugular, now we have a railroad. Over that wire, we put in another catheter and we cross the VSR antegradally from the IJV and then put in a stiff Amplatz wire over there. And after that, we put a railroad. So that single from the single snare. Only a single snare, and then we put in a stiff wire. Over this, we put in a sheath, and then we deploy the device. It is only a single snare.
No, actually, see, it really doesn't matter. What is important is, while you are traversing with the VSR part, there should be no stretch. Yes. And in fact, even if you are trying to protect a wire from slicing by covering it with a guiding or a diagnostic catheter, even that tries to get through because it's a weak part hota hai. So it's a friable area, and if you are like doing near the end of the first week, तो बहुत ज़्यादा इनका. So sometimes some of the VSR you will get them after 1 month. उनके edges relatively मतलब healthy हो जाते हैं, उनकी fibrosis काफ़ी आ जाती है. But any case which you are doing in the first week, I think you are very vulnerable to suddenly increase the. In fact, we have seen चौथे पांचवें दिन तुमने डिवाइस लगाई, सब कुछ ठीक ठाक है, 8वें दिन ढीली होनी शुरू होगी, 10वें 12वें दिन निकल गई वो डिवाइस, एंड क्यों निकल गई? वो सारा टिश्यू नेक्रोस हो गया. वो टिश्यू जो अपने आप नेक्रोस हो जाएगा, दैट टिश्यू इज मच मोर लाइकली टू गेट torn with any stretch. So stretch should be avoided, but snaring once or twice probably that probably is not important. Yes. If you catch something rather than pulling, you push, then that slicing effect नहीं होता इतना ज़्यादा.
You can.
The same thing is true with Pratap is there. When you externalize any retrograde CTO, the fundamental is when you are externalizing whether R3 or RG300, then you catch it with a snare in case you are using a snare. Then you don't pull with the snare. The only thing is you push from the feeding side and let it gently come into the recipient side. Anyhow,
we deliver the delivery sheet, say 10 French or so, or 12 French, whatever required, depending on the size of the VSD. Usually maximum device which is available is 24. Now another company has made 26. That goes with the Amplatz goes with the 10 French device. So we use that. Mostly I have done more than 16 cases. I have failure, death. And sir, you cannot wait because these patients develop pulmonary edema and they can't tolerate shock. So you have to put on IBP.
Agreed.
And do the
so the question was of snaring. I think you could.
Whatever, but you have to save during the period. You will put the IBP and keep for another week or 2 weeks. Yes.
So most of the case series shows
even
mortality up to
required,
80%.
even surgery required,
in
they do
device
emergency
cases.
surgery. It's an emergency surgery.
So, Dr. Shiva, I have one question at this point of time for your presentation. In all these cases, yeah. The only question is that in all these cases, where if the patient is not in complete heart block, we avoid putting TPI in this because the maneuvering is there. So I just wanted to ask why the TPI was there.
The patient shifted from the previous hospital.
तो स्टेंटिंग के बाद उसको आरसी स्टेंटिंग के बाद TPI डली होगी ना.
That's okay, but at the time of procedure we remove or keep in IVC, but keeping in the RV at the time of procedure it generally hampers the procedure because we have to have maneuver in
TPI
that.
is pretty, मतलब 5-6 फ्रेंच की TPI आपकी 10-12 फ्रेंच की शीट को कुछ नहीं करती, पड़ी रहेगी साइड में. For me, I think it will be like पड़ी रहने दो, कुछ नहीं फर्क पड़ता.
Sir, I want to make one comment. Sir said that we'll put on IABP for 1 or 2 weeks and then we can wait for the patient to
Actually, there is, let me tell you, I probably have much more experience than most of the people here, and I started closing them way back 30 years ago, and we had initially closed some 8 VSRs in 90s, and ये खटा मीठा इसका experience रहता है. The largest experience was from a European group. Majority of the people were from London. उनके 54 केस थे, and वहाँ पर भी यही था. Natural selection is a way to pick up those cases which are likely to succeed. But if you try to naturally get them selected, you lose many patients on the way. So generally, it is felt that अगर एक patient एक महीने तक select हो गए, ठीक ठाक चला है, फिर जरूरत क्या close करनी है? कोई जरूरत नहीं है. So VSR ideally should be closed, according to me, as soon as possible.
As soon as diagnosed.
However,
and जो शुरू में तो पता नहीं लगता, because it's not a hole, it is like a crack. धीरे-धीरे करके सीप करता है वो, and सुबह थोड़ी मरमर आनी शुरू हुई, वो कुछ घंटों के बाद मरमर बढ़नी शुरू हो जाती है. 2 दिन पेशेंट वैसे ही निकाल जाता है, थोड़ा प्रेशर बढ़ा देते हो. ये तीसरे चौथे दिन में जाके पेशेंट का मल्टी सिस्टम स्टोरी खराब होती है. तो much before your multi-system problem starts, I think we should intervene. However, intervention does not mean that you intervene with your sutures or with your device. According to me, the first intervention is you unhook the left ventricle. And IBP, जितना मर्जी को बोलता रहे, IBP is a very, very good device in such cases. It's very helping. And in fact, I'll say कि आपके पास अगर patient की habitus allow करता है, तो 50 milliliter वाला balloon रखिए, which is very good. And letting the patient be on IBP for some time definitely gives you a better pitch to play on. But to continue with IBP for a longer period of time, I do not have any scientific evidence at this point in time to say in favor or against. There are points in favor and there are points against. Nevertheless, you are trying to let the patient be on IBP for anything longer than maybe first 5-6 days, उसमें भी दिक्कत होती है. We have seen these devices staying in हमारे जैसे भी system है, उसमें sepsis के बाकी चीज़ों के भी chances काफ़ी होते हैं. I think we'll have to take a very, very careful and a gauged decision. And sometime, see, you should not, in such cases, should not aim at closing it fully. Even if you kind of close it with some residual defect, उसमें कई बार hemolysis भी होती है, लेकिन prognosis definitely better हो जाता है. So the only issue in such cases is a basal defect. You are very close to the conduction system. You are very close to the AV valves. Issue होता है इसमें. If you are close to the apex, then ये बिल्कुल इस जरा सा भी issue नहीं होता. But then you close to the free wall. Sometime we have closed the apical VSR, patient छुट्टी होके चला गया और 10 दिन के बाद device is lying the pericardium. जैसे तुम्हारा stent था ना pericardium. We have seen device getting into the pericardium. So इस तरह के cases में ये तो रहेगा ही. It is not like even surgeons. If you look at our surgical colleagues, उनके results भी इतने बढ़िया नहीं है. Probably the largest volume is from B.K. Sharma from Ludhiana. He is using cyanoacrylate in addition to the patch. Some 15 years ago, I was there as an examiner. I suggested to them कि हम कभी-कभी जो injuries होती हैं heart की वहाँ glue लगा देते हैं. So he has been using these glues, and nowadays he says his results are very good. I will say this is one of those things which where we should. This जहाँ आपको सर्जन के साथ मिलके एक टीम बना के काम करना चाहिए, and being very hesitant and prolonging the story probably will also have counterproductive effect. But however, I सारी story को short करते हुए important points मैं बोलना चाहूँगा. Tip deflecting sheath, very important. आप अगर कोई भी दूसरी शीट लेके जा रहे हो, उस शीट के लिए आपको ये स्टिफ वायर्स की ज़रूरत है. अगर आपके पास टिप डिफ्लेक्टिंग शीट है लाइक फू स्टार, तब इतनी खाने की जरूरत, आपकी वायर होनी चाहिए, वो तो आप बस उसको ऐसे करके आराम से चली जाएगी वो. सेकंड, इफ द डिफेक्ट इज नॉट वेरी लार्ज देन सम टाइम you can use your EP, only one EP guy is there. You can use Agilis you can deflect. Sometimes you can close a VSR through a transeptal approach. आप सोचोगे transeptal approach से क्या है? Yes, you can go transeptal and go to the ventricle. उसमें आपकी LV disc will open to the RV site. इसमें कई बार आपकी manipulation में आपको advantage हो जाती है. But this is a field about which चाहे आप किसी ने कितने भी cases किए होंगे, कोई randomized trial भी नहीं हो सकती. I think anecdotally है. I mean, this is a difficult wicket to bat on. I think whatever was the result, we should congratulate you. We like to listen to some of the salient and important technical point from you. तुमने तो बोल दिया ना डिवाइस लगी, पहले उस चीज़ों में इंटरेस्टेड नहीं हम.
The procedural step, the amplifier delivery catheter is advanced integrated.
You see, once you are advancing your sheaths, sometime sheath की tip जो है ना, this is what 10-12 French. What is the sheath size? 12 French.
Yes sir.
12 French की sheath जब आप ऐसे RV से LV की तरफ जा रहे होते हैं ना, and infarcted myocardium होती है, तो कई बार इसकी जो tip of the sheath बड़ी injuring होती है. So one of very simple ways in such situations is जब आप वायर के ऊपर, the moment your tip of the sheath has entered the chamber, जैसे आप ट्रांसेप्टल जा रहे हो तो आरवी में आ जाए और ऐसे जा रहे हो तो एलवी में चली जाए. द मोमेंट इट हैज गॉन देयर यू शुड विड्रॉ योर डायलेटर, क्योंकि डायलेटर से इंजरी होती है बहुत ज़्यादा. एंड मैनी टाइम जस्ट एडवांसिंग ए पिगटेल अलॉन्ग साइड हेल्प्स यू, बहुत एडवांटेज देता है आपको. वो टिप वाले पार्ट की इंजरी को काफ़ी कम कर देता है. एंड लाइक इफ यू सी इट देयर, इट मे बी फ्री इन दी टिप, मे बी फ्री इन दी एलवी कैविटी, मे नॉट बी फ्री इन दी एलवी कैविटी. But if you have a pigtail getting out of it, that gives you some kind of a protection.
An amplifier occluder is deployed and released.
Which occluder? Amplifier तो तीन तरह के वैसे occluder हैं और VSR के लिए special VSR occluder है.
But our size was 11 mm and in the VSR the size of occluder need to be
नहीं VSR का तो साइज बड़ा 18 मिलीमीटर तक आता है.
1.8 to 1.5 to 2 साइज का डबल साइज का लेना रहता है. बट हमारे पास जो डिवाइस साइज था 20 का अवेलेबल था, बट वो डिप्लॉय हमने किया था सर, बट वो निकल गया. फिर हमने एएसडी डिवाइस, फिर हमने डिवाइस साइज ऑफ 24 mm डिप्लॉयड अक्रॉस एज VSR डिवाइस for as the device size was not available. And
24 ही maximum आते हैं.
post MI VSD 24, maximum is 24.
हमारे पास
another company made 26. I think Merrill has made 26.
Lifetech या Merrill क्या, I don't know, one of them. Anyhow.
And
so once a device is bigger or a smaller device has slipped, especially a ventricular device which is specially made for it, then the other alternative is to choose for the septal occluder. Atrial septal occluder has been used. We used it some 30 years ago. आज भी यूज कर सकते हो उसमें. थोड़ा सा उसका ये है कि उसकी AV valve के पास दिक्कत करती है. Agreed.
Recently we have published article of our center's transcatheter device closure of post MI ventricular septal rupture single center experience, and Dr. Praveen Chandra.
17 cases.
Yes sir, 17 cases. And the take home message of this procedure is salvageable if reached in time, and urine output is the key, and a prompt diagnosis is must, and wait for few days in support for the septal viability, and oversize by 25 to 35%, and judicious use of MCS, especially ECMO, is life-saving and gives time for septal strengthening, and survival depends on the heart team decisions, sir.
How many of them done by ECMO? You see, this is VSR, one VSR and acute MR. These two are clear in acute MI with cardiogenic shock. IBP is the indication, not the impella, you know, or ECMO. ECMO cardiogenic shock, no benefit, more harm. So how many of them done with ECMO? Go with the data, your data. So,
yes, sir.
How many of them done with the? You see,
IABP,
come out anything.
IABP was present on 4 and in survivors and 10 from non-survivors, sir. And recently, no.
And how many of them ECMO?
दो तीन मरीज हो सकता है. See, sometime your patient is not saturating well, and you might have to take the help of ECMO also over and above your IBP. Means
recently 2 to 3 days back,
even danger shock. Yes. There is no inclusion of BSR or acute MR.
One again a patient of BSR had came admitted in Medanta, and we put impella and ECMO.
I think the simple and loud message ये है कि आपके पास अगर भी VSR का पेशेंट हो तो उसको जल्दी से एक ऐसे सेंटर में भेजो जहाँ इस तरह की फैसिलिटीज अवेलेबल हो, एंड लेट द टीम डिसाइड कि वो सर्जरी करना चाहती है या ट्रांसकैथेटर क्लोजर करना चाहती है. ट्रांसकैथेटर क्लोजर करने वाले जो लोग हैं उनके पास अच्छी शीट्स होनी चाहिए, सब तरह की डिवाइसेस अवेलेबल होनी चाहिए. वन शुड बी रिलेटिवली लेस एग्रेसिव, मतलब ट्रोमेटिक आपका एटीट्यूड नहीं होना चाहिए, कहीं पुल पुश ज़्यादा ना करो, एंड ट्राई टू डिलीवर अ डिवाइस, एंड इवन इफ सम रेजिडुअल डिफेक्ट इज देयर उसको आप एक्सेप्ट करो. एंड IBP इज अ वेरी इंपॉर्टेंट बैकअप hematology support.
Sir, if you need bigger device, I have used PDA. PDA comes up to 28 size. So above another
Life Tech 28 आ जाती है.
Life 28 आती है. So I have used 28 Life Tech in post MI VSD.
VSD, but why should you use a PDA device once you have VSD?
Because it makes on the RV side there is no umbrella, so it closes better because it compresses the hole and it.
Actually, Oculotech had made a device which was specially for VSR. This was a novel device क्योंकि ये सुराख कभी गोल नहीं होता. It's like a rent. तो इस रेंट के अंदर जब आप कोई भी डिवाइस जिसकी वेस्ट गोल होती है तो वो एक साइड में तो जो शॉर्टर डायमीटर है उसके लिए ओवर हो जाती है और जो लॉन्गर डायमीटर है उसके लिए अंडर हो जाती है. इसलिए डिवाइस फिट भी अच्छी नहीं होती और इसलिए रेजिडुअल डिफेक्ट भी होता है. दैट Oculotech की जो कैपेला डिवाइस थी वो क्योंकि बड़ा अनकॉमन है यूज़ होना, वो कमर्शियली वायबल नहीं थी, उन्होंने विड्रॉ कर लिया है. दैट डिवाइस वाज अवेलेबल सम 15 years ago, बट दे हैव taken it back because of the commercial reasons.
Sir, PDA device also advantages because the umbrella on the left side, on the LV side, the rim above the shaft is more, around 4 to 6. Bigger size you will take, it is 6. Whereas if you take post-MI VSD device, maximum 2 millimeter.
So there you can use ASD device, septal occluder can.
ASD device, no shaft is only 4 millimeter. So that will stretch like, it will form like a dumbbell. It will not close as
that is there, but we have seen. So this was an ASD device which you used, and it has sat well. No, this was an ASD device. If you look at it, it has sat very well.
Sir, we are running short of time.
Actually, he told ASD device and ASD or VSD?
ASD device was
ASD device.
VSD
that looks like this. If it is there at the atrial septum, it looks like this only.
No, sorry, that was ASD device.
Anyway, I think we should give all of us should give him a big hand. I think he's presented very well. Thank you very much.
सर पोस्ट एम आई VSD क्लोजर के पहले क्या पॉलिसी थी?
Good evening to all the respected seniors, friends, and special thanks to Shamshad boss for giving me the opportunity to speak here. My case is lost and found, stent and wire loss, and a snare to rescue for a lost stent. My patient is a 69-year-old female.
See that technical पे आओ.
Yes sir. So acute MI, one avial mesh elevation, lateral wall MI. Yeah, coming sir. But a bit off picture. This is the angiogram of my patient, acute MI, lateral wall MI, LAD critical, LCX critical, 99% stenosis, LAD also 99, and RCA was CTO in my patient. These are the cranial lesions, and RCA CTO lesion is this one. So the plan was very simple. This is routine acute MI case. The plan was to do PCI to circumflex and LAD, and after that RCA CTO, because this is acute interlateral wall MI. So I began radial approach, 6 French EBU 3, because this was a female patient. So this is a curve of 3. Wired both the lesion, because the left main was quite short, I was not very confident with the position of the guide. So I wired LAD also, because eventually I have to do intervention in LAD and LCX also. Prepared the lesion with a Wolverine balloon of 2.75 millimeter into 10. Inflated it. Lesion preparation was good. However, while positioning my stent, the stent was placed distally. When I was trying to reposition it to the proximal part, my stent was degloved, the balloon came back into the guide, and the stent was still there hanging from left main to distal sulc. Now what to do? The first thought which came into my mind was to pushing that drug.
But वैसे अगर देखो,
yes sir,
if you look at it, you are in a female की ये छोटी होती है इसलिए डर के तुमने 6 French ले लिया. बट आई थिंक सच के जब तुम्हें लग रहा है एनाटमी ऐसी है, थोड़ा लंबा सा लीजन है, भी वहाँ पे दिख रहा है साथ में, तो मतलब एंड देन 36 मिलीमीटर का स्टैंड, मतलब गुड रेसिपी है उतरने की. चला जाए, लेकिन अगर तुम 100 स्टैंड लगा रहे हो, 100 में से अगर 5 या 7 स्टैंड उखड़ जाते हैं, आज के डे में 5-7 स्टैंड अगर उखड़ रहे हैं, बहुत हाई परसेंटेज है. अकॉर्डिंग टू मी विद दिस काइंड ऑफ एनाटमी एटलीस्ट 5-7% आपके स्टैंड उखड़ेंगे. अगर 5-7% उखड़ रहे हैं, आई थिंक योर इज नॉट करेक्ट. अगर था इसमें गाइड एक्सटेंशन लेके जाओ.
No,
so
employees are straightforward. Upon the stent company also, which company has mounting?
Agreed. But if you look at it, मतलब if you're going radial, you're taking 6 French, and then there is a long path with your stent, then it is possible कि तुम्हारा 20-25-30 मिलीमीटर चला जाएगा, आखिर के 6-7-8 मिलीमीटर आपके रह जाएंगे, फिर धक्का मारोगे, फिर कुछ उतर जाएगा. See, I am telling you because I'm in this business for almost 40 years. तो मतलब इस तरह के केस अगर मुझे आज की डे में मिलेगा, तो मैं थोड़ा रिलेक्टेंट हूँ इस तरह से स्टार्ट करने के लिए. आल से या तो फेमरल जाओ, अगर फेमरल नहीं है तो इसके साथ एक्सटेंशन लेके जाओ, अदरवाइज उखड़े आकड़े और फिर बहुत मुश्किल हो जाएगी कहानी.
सर आई वाज एक्सपेक्टिंग सम प्रॉब्लम, दैट्स व्हाई आई टू वन मोर वायर इन एलईडी की हमारा गाइड वायर नहीं हिट करेगा.
नहीं, वो वायर का कोई रोल नहीं है जब तुम सर्कमफ्लेक्स में कोई चीज पहुंचा नहीं पा रहे हो.
बल्कि there was no problem in delivering balloon, pre-dilatation balloon or even cutting balloon. Cutting balloon was also reached easily.
कटिंग balloon की लेंथ 10 मिलीमीटर है, ये 36 मिलीमीटर का है.
That usually I avoid 36.
इसी तार को तुम सर्कमफ्लेक्स में डाल देते, हो सकता है जो तुम्हारी एलईडी में, तो it would have helped you.
So what I did
anyhow,
was,
let's see it.
The first thing which I did was to push the stent, because the stent got degloved, to push the stent from left main to the desired place. Then I will inflate that stent that moment only. However, my stent moved, but there was clear deformation of the stent. You can see the proximal part of the stent is deformed now by pushing from the balloon, which I was trying to reposition it into the LCX so that I can deploy it wherever it is. But now what were the options at this moment with me? The wire was in situ and stent was degloved, there was no balloon. So the one thing was to push it, I already tried it. The second one is to inflate a balloon proximal to the stent, push whole assembly inside. Third was
inside
to snare it. Yes, sir.
Push whole assembly inside means?
Sir, inflating a balloon proximal to the stent and pushing the balloon and the wire inside so that the wire deformed stent also goes inside. And then I'll inflate it
inside
there only.
Inside the artery, inside the guiding.
Yeah. Inside the artery, sir. Pushing it anti-grade.
देखो जाएगा नहीं कभी भी, ये सिर्फ मतलब ये शेख चिल्ली वाले सपने हैं. स्टैंड जो आगे नहीं जा रहा था वैसे, सुनो एक सेकंड बेटा, जो तुम्हारा 36 मिलीमीटर का स्टैंड, इसके साथ 38 या 40 मिलीमीटर का बलून होगा, 1.5-2 मिलीमीटर फालतू बलून होगा. इतना लंबा बलून जो है वो उसको पकड़ के नहीं आगे धक्का मार सकता, तो छोटे बलून को धक्का मारेगा नहीं जाएगा कभी, डिफॉर्म कर देगा, जाएगा नहीं कभी भी. सिर्फ ये है कि प्रॉक्सिमल एंड उसका और थोड़ा मुड़ जाएगा. आगे चलो.
उसमें आप छोटा बलून लेके उसको
अभी सर वो भी किया है सर. I have tried that.
चलो अभी चल रहा है.
I have tried everything here. So the other option was to I can take and snare. अभी हमारा stent is deformed, stent is still inside LCX. I will snare it on the same wire. It is easy to.
देखो ये सारी कहानी करते हैं. अब तो गाइड एक्सटेंशन डाल लेता बेटा.
सर दो
अगर अब गाइड एक्सटेंशन डाल लेता तेरी सारी लाइफ फिर आसान हो जाती.
सर मैंने सोचा नहीं.
See, ये जो तुम्हारा जो गाइड है ना अभी, ईबू.
Yes sir.
ईबू is a most useless guide according to me. हम लोगों का गाइडिंग है जिनको कुछ नहीं करना आता, क्योंकि ये एलईडी के लिए भी ठीक है, सर्कमफ्लेक्स के लिए भी ठीक है, कमिटेड किसी के लिए नहीं है.
Okay.
EBU guide is not neither for LED good, not for
Sir,
circumflex.
this is XB by cord, is not EBU by Medtronic.
एक ही
one in the
तरह
same
कर
thing.
तो सेम ही है उनका।
No, sir,
जब तुम्हें सर्कमफ्लेक्स के लिए जाना है
No, no,
तो
no,
तुम्हारे को साइनस सपोर्ट लेके टिप उसकी इनटू सर्कमफ्लेक्स होनी चाहिए
Sir,
प्लास
यहाँ
टाइप।
सर सपोर्ट का इशू था ही
तो
नहीं।
इसलिए आज की डे में अगर तुम इसमें एक्सटेंशन
Guide
डाल
है
दोगे
क्या?
ना तो
डाल-
ईबू बन जाएगा इसका अपने आप ही, नीचे सपोर्ट देगा, ईबू बना देगा वो आराम से। दैट विल बी ए ईबू with a long tip which will walk into the vessel. आपकी लाइफ वैसे आसान हो जाएगी।
I was not expecting so much difficulty in this simple case, but problem ये था।
All of you should आने वाले टाइम में जरूर एक्सपेक्ट करना, मतलब इसने एक्सपेक्ट नहीं किया है।
मैंने एक्सपेक्ट नहीं किया था।
Sir, Cordis XB guide is more stronger guide, more better support.
More होगा तो stronger नहीं यार, या तो stronger है, more है।
हाँ, and then EBU. EBU is more soft because lumen slightly bigger in EBU from Medtronic. So I don't use EBU at all, zero. But this.
No, for routine cases, extra backup is a good thing. सब आराम से केस हो जाते हैं first class, LED circumflex दोनों में हो जाते हैं। But whenever you sense केस में शायद ज़्यादा support की जरूरत पड़ेगी, तो then I'll say कि for LED go for a Judkin, for this go for this, and always आज की day में extension use करो।
AL also you can take. AL also very good support.
Please.
So the other option was to take multiple wires, then wire and take out the.
ये सब बेकार की बातें हैं, multiple wire इतने लंबे स्टैंड को नहीं खींच पाएंगे।
So what I did was to.
अब तो तुम्हें
I passed a small balloon now.
अब तो सिर्फ तुम्हें मेरे ख्याल से सिर्फ इसको लगा दो इसको। बिल्कुल खींचने का कोई भी तरीका वो गलत होगा क्योंकि आधा खींचेगा आधा फिर रह जाएगा।
वो सर हुआ क्या कि I thought कि अब चलो जब तक कि snare was being searched in the lab, so I passed.
अब the mistake which can be done is कि आप balloon distal ले जाके फुला के खींचो।
बस यही गलती।
अगर खींचोगे तुम अपनी प्रॉब्लम अपनी गर्दन पे तुम फंदा डाल रहे हो।
So I did the same thing which you told. I inflated a balloon distally, tried to pull it. Stent came halfway in. However, then again there was a significant jerk, and my balloon and wire both the came outside. And now my stent is lying in left main.
आधा लेफ्ट मेन में आ जाएगा, बाकी सर्कमफ्लेक्स में पड़ा होगा, तार निकल जाएगी।
अब
प्रॉक्सिमल हिस्सा थोड़ा फनल अप हो जाएगा पहले से।
अब ये सब इतना हो गया ना, what else I could have done? So immediately जब ये loss हो गया वायर का, so what I did.
पहली बात तो इस सिचुएशन में अच्छा सा लंबा सांस लो, घबराओ नहीं बिल्कुल नहीं घबराना। सबसे पहला स्टेप है इस तरह की सिचुएशन में अपने साथी को बोलो भी को और सीनियर बंदा है कि नहीं है, बुलाओ उसको। नंबर 1, सर्जन को बिल्कुल मत बुलाओ क्योंकि आज के डे में सर्जन को तुमने एक बार बुला के एक बार ठीक करा लिया, 1 साल लगान देनी पड़ेगी तुम्हारे को उसको। ठीक है, बिल्कुल नहीं बुलाना सर्जन को।
सर्जन है
नंबर 1।
नो सर्जरी बैकअप।
नंबर 2, इस तरह की सिचुएशन में क्या हो सकता है, ये स्टेंट पड़ा हुआ ही छोड़ोगे बंदा मरता नहीं कभी भी। सबसे पहले चेक करो एंटीकोगुलेशन। अगर बंदे की एंटीकोगुलेशन जरा सा भी है नहीं तो बता रहा हूँ ना, इसीलिए बोल रहा हूँ। सबसे पहला स्टेप है चेक करो एंटीकोगुलेशन, एसीटी चेक करो और अपनी तरफ से बंदे का एसीटी वो ला के रखो जो डॉक्टर प्रताप रखते हैं रेट्रो के लिए 350-400 के बीच में। ठीक है, अब उसके बाद जिस ग्राइन से जहाँ से तुम रेडियल फ्रीडल से कहीं से भी जा रहे हो, सोचो कि मेरा ठीक है एक्सेस या नहीं ठीक है। नहीं ठीक है क्योंकि सब कुछ तो बाहर आ गया, अब तो खोने को कुछ नहीं है। अब एक बड़ा सुराख करो ग्राइन के अंदर। ठीक है, 8 या 9 फ्रेंच का सुराख करो और दोनों साइड से सुराख करो तुम। नाउ ट्राई एंड हैव ए गाइडिंग जिसमें जान हो और खुला बड़ा गाइडिंग हो, उसके पीछे फिर एक गाइड एक्सटेंशन रखो। ठीक है कि नहीं। अब अगर तुम रखोगे ना, तुम्हारा जो मान लो स्टैंड पड़ा हुआ है लेफ्ट पेन के अंदर थोड़ा सा, इसमें से कुछ नहीं करना तुम्हें, इसमें से तार डालो जहाँ जा रही जाने दो, उसमें से निकल के जहाँ बलून जा रहा जाने दो, इन्फ्लेट करके खींचोगे सब बाहर आ जाएगा।
So now sir जब वायर भी लॉस हो गया then I had limited.
अब तो दोबारा वायर डालनी है, दोबारा वायर is very unlikely to go through the stand.
What happened sir, the wire went into some subintimal space. Now wiring was not possible.
नहीं subintimal या स्टेंट के अंदर बाहर।
मतलब सर स्टेंट के बाहर गया पता चल नहीं रहा था, तो वायर बट डिजिटल वेसल में नहीं जा रहा था।
ठीक है।
So
नहीं बट अब तो तुम वायर कोई now you can push the wire through the stent into the LED.
No sir, now the stent is in L6. My
part of the stent is in the left main, ना?
Yeah, part of the.
तो बस उसको तार को now you don't try to take the wire into the circumflex. Try to अब तो थोड़ा सा तुम्हारा proximal stent थोड़ा
क्रम्पल हो ही गया है सर।
तो आप उसमें से तार को डाल के aim towards the LED.
हाँ।
अब तो तुम्हें बाहर निकालना है, LED की तरफ तुम aim करते हो, then you try to take a balloon through it. बलून्स के थ्रू ले जाके जैसे स्टेंट स्टड्स के बीच में से अगर तुम्हारी बाहर एलईडी में जाती है, बलून तुम्हारा एलईडी में जाता है, बलून खुला के खींचो।
Yeah. So sir, rather than doing this, what
but you were trying to go into circumflex. Fine.
I tried
to
went into circumflex also, but wire was not
अब वायर की कहानी क्या है कि वायर को भी बहुत अच्छा ल्यूमन मिलेगा नहीं, कभी अंदर बाहर होती
यही हुआ सर, बिकॉज कटिंग हो चुका था, डिसेक्शन हो चुका था, वायर स्टेंट के पीछे से होते हुए डिसेक्शन फ्लैप में जाता था।
कोई बात नहीं, अब तुम्हारे पास स्नेर है?
अब पेशेंट ये सर आ गया, अब पेशेंट को सर चेस्ट पेन हो रहा था, तो व्हाट आई डू आउट ऑफ डेस्परेशन।
अगर तुम्हारे पास स्नेर नहीं है तो क्या करोगे?
सर अभी एक और वायर डालेंगे, कोशिश
नहीं, ऑल ऑफ यू शुड नो हाउ टू मेक अ स्नेर। सबको कैथलैब में स्नेर बनाना चाहिए, और ये पेशेंट जो है बड़े आसानी से हैंडमेड स्नेर से मारा जाएगा, इसमें स्टेंट।
इसके बाद सर हमने क्या किया, जो वायर डिसेक्शन में ही था हमने उसी पे स्नेर करने की कोशिश की कि भाई लेट अस डू स्नेर एंड टेक इट आउट ऑफ डेस्परेशन, हाउएवर इट डिडंट कम। व्हाट आई डिड नाउ, आई टेक अनदर balloon, crush that stent. जो stent was hanging in the left main and nostril L6, I crushed it so that I get my wire again into the L6. Again I'll get some time, my patient's flow will increase, the blood flow increase, patient's hemodynamic will get better. After crushing that stent, my wire crossed after knuckling it into the distal LCX. Once the wire was present there, now I have to do only snare. I snared the stent, caught the fish, और उसको snare कर
अगर
दिया।
तुम्हारी वायर डिस्टल सर्कमफ्लेक्स में चली गई है,
अगर
पार्ट ऑफ द स्टेंट तुम्हारा क्रश हो गया लेफ्ट मेन में, you can still deploy the stent there in the circumflex, and the crush जो तुम्हारा stent पड़ा उसको LLM to LED stent लगा दो, and this you can finish
next
like
plan
this.
यही था कि अगर नहीं निकलेगा तो हमने crush कर दिया, I would have stented it so that wire हमारा हो गया। This is the stented, this is the
अब इसमें जो बाहर निकला हुआ है, ये बताओ कि जो लेफ्ट पार्ट है जो relatively intact है, ये डिस्टल था, ये
डिस्टल था,
डिस्टल था, ठीक है।
जो प्रॉक्सिमल वाले को तो सर मैंने डिफिनेट करके वी कैन क्लियरली सी, जब स्नेर किया तो वो थोड़ा सा प्रॉब्लम दे ही रहा था। आफ्टर दैट दिस वाज इजी केस अगेन, as I thought initially there was dissection, my wire was there in true lumen, I did an angioplasty with 2 stents, there was TIMI3 flow, very good result।
तो यही कहानी जब तुम्हारा इस तरह का हो जैसे ये था, अगर मान लो लेट अस से you have no implants, you don't have a guide extension, but you are sensing things are not very good, 36 का स्टैंड नहीं लो बस। इसी 36 का स्टैंड सेम कहानी तुम अब छोटे स्टेंटों से कराया ना, 2 टुकड़े लेके लगाया हो।
जनरल रूल which I also follow is I never take stent longer than 32, but सर ये पेशेंट थोड़ा पुअर था तो I thought कि 36 से हो जाएगा, एक ही से कर देते हैं।
देखो पेशेंट की पॉवर्टी को, we should all be rich enough, अगर को हमारे पास गरीब रह जाता है,
eventually sir I
should all be rich enough, कोई बात नहीं, लेके लगा दो, बाद में देखेंगे।
Eventually I deployed 2 stents only, one has to be done, एक deform हो गया। So my take home message is that if the stent is lost, wire is lost, we always have thought. The whole process which I did took only 3 minutes for me. Immediately wiring, losing, snaring, and everything, it went off because the patient was acute MI, RCA was 100%, LED was diseased, L6 I closed it. So most important is that time here is most important. Your strategy should be immediately switching. You should think at your spinal level, switch your strategy immediately. Keep all the hardwares. You should know all the hardwares where it is kept. Most important, because when you are there as single operator, technician should also know where the hardware is kept, because I know that technician often forgets it. Always let them know that there is 2 systems in snare with 1 delivery and 1 with snares, and we should always know about our hardware, what hardware we have, what type of micro snare has to be used.
चलो ठीक है, thank you very much Dr. Ajay, it was a nice presentation. I think you saved the patient.
Micro snares should always be there, at least 4 millimeter micro snare.
हाँ, but कई बार कैथलन में इतना सामान नहीं रख पाते हैं, तो मतलब आई थिंक हमारा फाइनल टेक ऑफ जो इसमें मैसेजेस यही हैं कि डिफिकल्ट विकेट थी है, इस डिफिकल्ट विकेट में डिवाइड एंड रूल कर लो तो ठीक रहता है। उसको डिवाइड एंड रूल का मतलब 2 छोटे-छोटे लगा लो, डिवाइड एंड रूल हो गया, लंबा एक लगाओगे बस हो गए।
Recently we have similar problem, so we used AL guide and easily
तो स्टैंड स्टक एंड इंटरवेंशनल नाइटमेयर।
Good evening everyone. Before starting, I'd like to thank Dr. Samshad sir for giving me this opportunity. So, presenting a case, 46-year-old male patient who presented to us with Agrawal MI with ejection fraction of 40%.
And Agrawal MI कब हुआ?
24 hours. Hello?
When was MI?
This was an acute MI, less than 24 hours duration. We can see there is ostial LED lesion followed by there is a lesion in the LCX and almost distal TIMI2, TIMI3 flow. So we went ahead and wired the LED followed by pre-dilatation and I put the stent, tried to do ostial LED stenting, and it was a good result. Patient was apparently fine, TIMI-3 flow, and we discharged the patient. Followed by, we planned a staged PTCA to LCX.
देखो तुम्हारा स्टैंड जो है ना अभी थोड़ा लेफ्ट मेन के अंदर पड़ा हुआ है.
हाँ सर, लेफ्ट मेन में है.
तो फिर सर्कमफ्लेक्स में जब घुसोगे रास्ते में नहीं आएगा वो.
I knew that. तो
मतलब ये इसका मतलब तुम you were planning to present a case in the Bihar intervention. थोड़ा छोड़ दिया.
So like you told sir कि मुझे लग रहा था कि LCX में स्टेंट जाएगा नहीं. So I wired and I pre-dilated the ostial part.
What was the stent which you deployed from in the LED? क्या stent का नाम क्या था?
Oh sir, Boston का था.
Why I'm saying is because Merrill stent अगर आप डालते हो ना, Merrill stent का जो cell size है वो proximal and distal छोटा होता है. तो अगर वो मान लो आपको Merrill stent के through मान लो let's say you have wired this part of the stent which is lying in the left main, let's say your wire goes through the stent into the circumflex.
Okay.
तो कई बारी उस छोटे सेल साइज में से कुछ नहीं जाता, छोटा बलून चला जाएगा उसके बाद नहीं जाएगा, कहीं बार स्टेंट अड़ जाते हैं.
वही एक्सपेक्ट कर रहा था मैं सर, इसीलिए प्री डायलेट किया हमने.
So if it was a Boston stent के सेल साइज बड़े होते हैं, आराम से निकल जाता है.
Can I have here you see if you have a disease in the LED and you want that your stent should come to the ostia and circumflex is also disease, do the stenting of the circumflex first.
नहीं सर, ये acute MI था. First was an acute MI where we did only LED and this is the staged procedure. Then after 15 days.
Then you have to position the.
This was the staged procedure. This is being done after 15 days of the first procedure.
Because stent is in the left main. And,
yes.
And you lost. If you are coming from the left main, you have to cover the disease area in the left main. Because in left main there is a disease.
Left main में.
Yes, you go. So the.
नहीं left main disease 50% left main तो है ही है ना.
Yeah. So you have to come.
Shaft disease है इसका काफी.
I did not expect any significant lesion in the left main. So.
नहीं left main disease है.
Significant नहीं, यहाँ पे you have to across the.
Okay sir.
If not all.
No, there is no need to accept all. What I do, I practice. I am telling. I may be wrong, but.
Yes. So anyways, I pre-dilated and I thought that I could be able to pass the stent, but it was stuck. I pre-dilated the LCX, the balloon went smoothly. LCX was pre-dilated and followed by a disaster. So this is a, previously the stent was 36 millimeter, this is a 48 millimeter stent, which is, you can see it is stuck right from the catheter here up to here. And
देखो ये सोच ही गलत है जो जब तुम्हें पता है ऑलरेडी तुम्हारा थोड़ा सा स्टैंड वहाँ पर था, एक छोटे से बलून से हल्का सा रास्ता बना के फिर उसमें से लंबे लंबे स्टैंड लेके जाओ, जाएगा नहीं कभी भी. Also you must realize it is this left main is of relatively reasonably good length. छोटे लेफ्ट मैन का साइज हो ना लेंथ वाइज तो चला जाएगा सब कुछ.
yes,
अभी लेंथ जो अगर लेंथ देखो इसकी 13-14 मिलीमीटर करीब लेफ्ट मैन की लेंथ है.
yes, sir.
तो इसमें होगा क्या, तुम्हारा थोड़ा स्टैंड चला जाएगा उसके बाद जाएगा नहीं. फिर पहाड़ी के ऊपर जैसे बस होती है ना, इधर को जा रही ना इधर को जा रही, ना पहाड़ पे चढ़ रही ना नीचे गिर रही है,
ना आगे जा रहा है
ना फंस जाओगे तुम, ना आगे जाओगे ना पीछे आओगे, यही होगा तुम्हारा.
So this is the place I was completely stuck, panicked, and there is no surgical backup. I am all alone in the city. We have functioning cath lab and the only operator there. So this was.
इसको बोलते हैं खड़ी लाठी.
हाँ सर, पूरा ही फंस गए. फिर पैनिक क्या करें, तो बॉस को फ़ोन किया सर बीच केस में कि अब क्या किया जाए. So what are the options that were available? That is a small balloon technique where we can pass a balloon.
What is the size of this stent?
48 millimeter.
तुम्हारा स्टेंट लेफ्ट मेन से बाहर कितना है?
सर ज़्यादातर तो बाहर ही है.
प्रिपेयर अच्छा से मतलब यू सी सर्कमफ्लेक्स में इतना लंबा स्टेंट डालने के लिए यू हैव टू प्रिपेयर द अकॉर्डिंगली
यहाँ तक है सर कैथेटर में
एंड गाइड एक्सटेंशन कैथेटर रहना चाहिए. इट लुक्स लाइक जेटकिंस आई थिंक कैथेटर जेटकिंस है
सर.
हां
स्टेंट
नहीं कैथेटर गाइडिंग कैथेटर क्या है?
XB.
ये एक्स्ट्रा बैकअप है.
ओके
एक्स्ट्रा बैकअप है और ये सी एक्स्ट्रा बैकअप कैथेटर विल नेवर गिव ए बैकअप फॉर अ लॉन्ग स्टेंट थ्रू द स्टेंट इनटू सर्कमफ्लेक्स.
ये यहाँ पे है सर स्टेंट. इट इज मोस्टली इन द कैथेटर.
नहीं वो मैंने सरकास्टिकली पूछा था तुम्हारा अप्रॉक्सीमेट कहाँ तक है कि तुम बोलो सर वो तो सारा इधर पड़ा है. यू सी
ना कुछ भी कर लो देयर इज नो मूवमेंट. ना आगे जा रहा ना पीछे आ रहा.
वन ऑफ द सिंपल ट्रिक्स one of the simple tricks in such a case is जो तुम्हारा अपना स्टेंट आधा तुम्हारा गाइडिंग अंदर पड़ा हुआ ना.
हाँ
इसके बगल में एक बलून लेके जाओ
सर. वही
उसको बलून को फैलाओ ये उसको ट्रैप करेगा निकाल लो.
हाँ वही सर. क्या क्या ऑप्शन थे तो मैंने बॉस को फोन किया कि सर क्या किया जाए ऐसे ऐसे फंस गए हैं. सर ने बोला फीमोरल लाइन लो छोटा बलून लेके जाओ एंड ट्राई टू इन्फ्लेट इट एट द प्लेस वेयर इट इज स्टक और फिर सारा निकाल लो. Other options were snare, twisted guide wire, just to deploy the stent, but आधा stent तो बाहर था तो we could crush the stent और send the patient for CABG. तो हमारे CABG सेंटर भी 8 घंटे दूर है.
CABG कभी मत भेजो, 1 साल लगाने देनी पड़ेगी.
नहीं सर, मैं अकेला ही हूँ वहाँ पे. तो anyways पैनिक में हमने कोई भी शॉट्स नहीं लिया तो कुछ दिखा नहीं सकता. The thing is
we believe you.
I went the femoral way like sir suggested. I pre-dilated with a small balloon. Even after that, कुछ भी वापस नहीं आ रहा था. तो ऊपर वाले का नाम लेके जोर से खींचा, सब बलून सारा कुछ सब कुछ बाहर आ गया. And then actually क्या हुआ कि यहाँ पे रेडियल में आके सारा कुछ फंस गया.
नहीं यहाँ तो फंसना ही था ना.
बलून वायर सब निकल गया, सिर्फ स्टेंट हाथ में रह गया.
कॉर्नर से बाहर निकलते तुम्हें सांस लेना चाहिए था. उसके बाद तुम्हें यहाँ नीचे नहीं लाना चाहिए था. उसको सारी चीज़ को नीचे डिसेंडिंग ऑटा में डालो, नीचे से 7-8 फ्रेंच का एक शीट डालो, उल्टा पकड़ के खींच के निकाल दो. उसको ऊपर देखो एक जगह से तुम बच के आ गए हो. फिर दूसरी जगह क्यों फंस रहे हो? कैथ लैब के अंदर एक चीज़ होती है, पहली प्रॉब्लम से बच जाओगे तुम, पहली गलती से बच जाओगे तुम, दूसरी करो, तीसरी करो, चौथी करो, फिर ऊपर वाला बोलता है इतने गंद घोल रहे, जाने दो इसको. इसलिए पहली मिस्टेक के बाद सेकंड थर्ड फोर्थ अगर आप अवॉइड कर लो तो आपकी दिक्कतें कम होती हैं हमेशा. जैसे तुम्हारे यहाँ से बाहर निकला था.
लर्निंग प्रोसेस है सर. तो अब हमने स्नेयर ले लिया फाइनली, कैसे कैसे करके इसको बाहर निकाला. सो आफ्टर दैट जब सब कुछ बाहर आ गया, देन वी रियलाइज्ड कि एलईडी वाला स्टैंड भी बाहर आ गया.
वो तो आएगा 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 तो हमें क्या बात है.
तो ये जो पुराना डिप्लॉयड एलईडी स्टैंड था वो उसके ऊपर जो LCX स्टैंड स्टक हुआ तो उसने पूरा का पूरा इन्फ्लेटेड एलईडी स्टैंड जो मैंने 15 दिन पहले लगाया था उसको भी निकाल लिया और नया स्टैंड भी पूरा बाहर आ गया और वो भी टूट गया. कैसे कैसे करके बस निकाल लिया. एनीवेज देन लाइक यू टोल्ड सर LCX पहले करेंगे तो आई फॉलोड प्रोटोकॉल, LCX किया.
So now there is nothing to obstruct at the LM bifurcation.
वही सर. फिर जैसा सर ने बोला कि लेफ्ट मेन में लीजन है तो ठीक है भाई, लेफ्ट मेन टू LED भी डाल दिया. तो फाइनली पेशेंट सर्वाइव्ड, आई सर्वाइव्ड.
LM स्टेंट अभी वेल एक्सपेंडेड नहीं है. LM में लग गया स्टेंट, एक्सपेंड नहीं हुआ. नहीं लग गया, एक्सपेंड नहीं हुआ.
हाँ पॉट किया था सर 4 से.
Patient has lot of trust on you.
Okay sir.
So we are.
Or you go say 4 millimeter, you can go 20, then it will become same.
Okay sir. Okay sir.
So we are eagerly waiting for the Vijay Tirhan sir presentation. Sir, please. It's a real nightmare at the midnight.
पहले इस ऑन कर दो, पावर बोर्ड देते रहना बाद में, ऑन कर दो। पावर इधर से ये लो, ये लगा लो, HDMI ये ले लो। हाँ?
एक मिनट वायरलेस ऑफ कर।
क्या हो गया, हाथ रहा स्टार्ट करो। तो बिल्कुल जैसे केसेस यहाँ दिखाए गए हैं उसी तरह से बिल्कुल मिलता जुलता केस है, और आई थिंक 24-25 साल पुराना केस है ये। एक्यूट MI नेक्स्ट नहीं चल रहा, यहाँ से चलाते हैं। चलो, तो थ्रोम्बोसक्शन की गई, कुछ जेंटल बलूनिंग की गई। चला यार, क्या रहा है? चलेगा? अच्छा, so some thrombosuction and some gentle ballooning, and I don't know why the second part is not playing. It was a decent result in the right coronary artery, which is, I don't know why it is not showing. But the problem was, it was like this. तो तार सीधे तो चली गई थी, going straight, तब पता भी नहीं था बंद आर्टरी कहाँ जा रही, तार चली गई। लेकिन मेन आरसी में जो एवी ग्रुप के अंदर आरसी पड़ी है, ये वाली, यहाँ नहीं तार जा रही, तार वाज गोइंग इन दिस डायरेक्शन। तो क्या करें? तो कई तरीके हैं, ये तार ऐसे चली गई, मेरे को इधर तार डालने मुश्किल हो रही थी। सो आई थॉट बलून ओक्लूड करते हैं, बलून ओक्लूजन से हेल्प होती है, कहीं बार आप बलून ओक्लूड कर दो, उससे कुछ नहीं बना मेरा काम। देन व्हाट आई डिड वाज आई टुक ए थ्रोम्बोसक्शन डिवाइस। थ्रोम्बोसक्शन का जो थ्रोम्बोसक्शन ल्यूमन है, उसको मैंने एक तरीके का ड्यूल लुमन कैथेटर बना के उसके थ्रू से देन दिस वायर इज टेकन इन, इट गोज इनटू द एवी ग्रुप। चलो अब कहानी तो आसान हो गई है, बट फोकस एट द बाइफिकेशन। तो बाइफिकेशन पॉइंट के अंदर आपको एक आरवी ब्रांच की साइड में डिसेक्शन दिख रही है, और जो एवी ग्रूव है उसमें थोड़ा ऑस्टिल डिजीज है, और ये डिसेक्शन कैप लग रही है, लेकिन कैप नहीं है, मोस्टली हैज़ टू बी काइंड ऑफ पार्ट स्पायरल डिसेक्शन, क्योंकि ये इनर बॉर्डर पे और आउटर बॉर्डर पे जा रही है। स्पायरल डिसेक्शन का मतलब ही होता है कि एक साइड से शुरू होकर दूसरी साइड में जा रही होती है। दिस इज़ नॉट क्लियरली स्पायरल बिकॉज फ्लो तो बिल्कुल ठीक ठाक है, बट समवेयर इन बिटवीन डी काइंड ऑफ ए डी डिसेक्शन जो NHLBI स्कोरिंग सिस्टम है। अब क्या है कि इधर को स्टैंड डाल दें, बहुत बढ़िया है। इफ यू लुक एट नॉट आरवी ब्रांच सप्लाइंग अ लॉट ऑफ एरिया, इधर का अगर आप स्टैंड डालोगे तो आपकी वायर इधर जो जाएगी वो जेल हो जाएगी, और वो जेल वायर जो है एंगुलेटेड ब्रांच में है। अगर वो जेल हो गई तो उसको निकालना बड़ा मुश्किल होगा।
Because artery is
You
the
see,
like this.
इधर डिसेक्शन है।
सर उधर डिसेक्शन रहने दीजिए ना, आप उसमें वायर है, वी हैव वायर देयर एंड यू स्टेंट अक्रॉस द ब्रांच एंड देन recross and
चलो
this.
मैं आई एम जस्ट गिविंग यू ऑप्शंस। सो इफ यू स्टैंड लाइक दिस, यू लीव अ जेल्ड वायर इन द एंगुलेटेड ब्रांच, वो जेल्ड वायर को निकालना मुश्किल होगा, नंबर 1। और दूसरा, अगर आपने निकाल भी ली तो पहली बार डाल दिया आपने तो दूसरी बार बता दें, दूसरी बार ही हो सकता है डले या ना डले, मुश्किल हो जाए।
So stent the difficult one first.
सो स्टैंड द डिफिकल्ट वन फर्स्ट, तो ओके। तो हमारा यह था कि चले डिफिकल्ट वन जो हंस गया इसमें स्टैंड डाल देते हैं। इसमें अगर हम स्टैंड डालेंगे तो हमारी ये वाली जेल्ड वायर जो है वो रिलेटिवली स्टेटर ब्रांच में रहेगी। अगर वो स्टेटर ब्रांच में रहेगी तो वो एक तो इट इज लेस लाइकली टू गेट ट्रैप्ड बिहाइंड द स्टेंट एंड इट विल ऑल्सो बी ईजियर टू पुल इट आउट। ऑल्सो जब तुम निकाल लोगे उसके बाद अगर आपने ऐसे स्टैंड डाल दिया तो इसमें से आपको वायर डालनी भी आसान होगी। तो ये सारी स्टोरी को देखते हुए हमें लगा कि क्योंकि इसमें से रीवायर करना भी आसान होगा, इसको निकालना भी आसान होगा, तो आई थिंक बेटर विल बी हम इसमें डाल देते हैं। और इस तरफ ये था कि जो थोड़ी डिसेक्शन है, हालांकि कुछ थोड़ा सा इशू है, बट आई थिंक सफिशिएंट ल्यूमन है, डिस्पाइट इट बीइंग ए स्पाइरल डिसेक्शन, हम डाल लेंगे तार को। सो ओवरऑल आई थॉट इट इज बेटर टू स्टैंड लाइक दिस इनटू सो कॉल्ड डिफिकल्ट डिवीजन। ये स्टैंड रख दिया हमने, उस समय बॉस्टन का स्टैंड आए थे, तो ये स्टैंड रख लिया हमने। 38 मिलीमीटर का स्टैंड है, ठीक सी पोजीशन में पड़ा हुआ है। व्हाट शुड बी द प्रिकॉशन व्हाइल डिप्लॉइंग द स्टैंड? You have a wire, jailed wire into the dissected RV branch. तो क्या प्रिकॉशन रखनी चाहिए? Anybody? जेल तो रखी हुई हमने, हटाई नहीं। हम तो स्टेंट टिका दिया हमने, अब वो पूछ रहे हैं भी स्टेंट लगाते हुए क्या ख्याल करें, एनी प्रिकॉशन?
स्टेंट नहीं स्टेंट लगाइए, लगाने में क्या दिक्कत?
लगाइए और फंस जाइए, और फंस जाइए उसमें।
How you can you can
नहीं, इसमें एक सिंपल प्रिकॉशन होती है, मैं आई जस्ट टेल यू, तुम कल से फॉलो करना, मुश्किल नहीं होगी। दैट सिंपल। हाँ, यस यस यस, यहाँ से किसी ने बड़ा अच्छा सा विस्पर किया। ऐसा स्टैंड जब लगा रहे हो ना, क्योंकि इतनी आफत नहीं है, अब इसको लो प्रेशर पे स्टैंड लगाओ, क्योंकि बाकी चीज़ें जो बाकी वाला काम है पार्ट कर करके एक एक तार डालते रहो, दूसरे निकालते रहो, ऐसे करके अपना सीक्वेंस रखो। नेवर एवर ट्राई टू डिप्लॉय दिस स्टैंड लाइक इन वन गो। जैसे 12-14 पे लगा दे तो मत लगाओ बिल्कुल। जैसे तुम्हारा स्टैंड फूलना शुरू हो, 4, 5, 6 जितने पे भी हो, उसके बाद तुम थोड़ा सोचो कितना करना है। तो इतनी मुझे समझ थी उस समय, आज से 25 साल पहले, मैंने इसको लो प्रेशर पे लगाया। यहाँ पर इसको मैंने थोड़ा छोड़ दिया नेक को। मुझे था कि एक तो साइड ब्रांच के अंदर जो छोटा ल्यूमन कम है, हालांकि डिसेक्टेड में ल्यूमन है लेकिन फिर भी कम है। डिसेक्टेड एरिया के जो इधर से एग्जिट निकल रहा था, दैट वाज अराउंड 40% ऑफ द ल्यूमन, रेस्ट ऑफ द एरिया वाज डिसेक्टेड। तो मुझे था कि चलो ये कम पकड़ेगा, और साथ में जो मेरी वायर पड़ी हुई है उसको भी उतना तगड़ा जेल नहीं करेगा, निकालनी थोड़ी आसान होगी। मैं बाकी रीवायर कर लूँगा, उसके बाद फिर फुला देंगे पूरा, क्या दिक्कत है। सो इट्स अ डिसेंट रिजल्ट आफ्टर दैट लो प्रेशर इन्फ्लेशन। एंड इफ यू लुक एट डिसेंट रिजल्ट, इस डिसेंट रिजल्ट में थोड़ा सा अंडर एक्सपेंशन यहाँ पर है। यहाँ का जो डिसेक्शन है वो विद ए वायर लिटिल डिस्टल, दिस डिसेक्शन इज काइंड ऑफ पार्टली टैक्ट। अब तो आसान काम है, अब कोई मुश्किल नहीं है।
सर यू कैन recross the side branch now.
हाँ, अभी हम बता रहे हैं आपको, बहुत सारी चीजें हैं इसमें, ये तो छोटी सी चीजें जो तुम बोल रहे हो, इसमें कुछ नहीं है।
And then go high pressure and dilate those areas.
पिक्चर अभी बाकी है। तो ये था कि इस अब जैसे थी तार, या तो इस तार को निकाल के इसमें डाल दें, स्टैंडर्ड वे होता है, निकालो उसमें डाल दो। दूसरा तरीका है कि तार आप ऊपर से यहाँ डालो, जो ऊपर से तार डालो वो हो सकता है आपकी नवी थर्ड वायर हो, एक ऑलरेडी वायर इधर पड़ी है, जेल वायर इधर पड़ी है, ऊपर से एक इधर वायर डालो, जब इधर वायर चली जाए तो जेल वाली वायर को निकाल लो, फिर कहानी करो अपना आराम से। सो दिस इज अ स्टैंडर्ड वे, लेकिन मुझे था कि इतनी आराम से डाल लेंगे, ऐसी क्या बात है, तीसरी बार क्यों खराब करो। कई बार आपका ये कैथला में होता है डाल लें यार, ऐसी क्या बात है। तो मैंने वो तीनों ऑप्शन बताई, बट द ऑप्शन विच आई फॉलोड वाज लाइक आई वाज फार मोर कॉन्फिडेंट दैट टाइम, मुझे था कुछ नहीं है, कह रन कर लें, इसमें क्या दिक्कत है। सो आई थॉट नो नीड टू वेस्ट अ थर्ड बार, इसको निकालते हैं, मैं इसको निकाल के डाल दूंगा, इसमें क्या होता है। मतलब
ऊपर वाला में डाल,
माई कॉन्फिडेंस वाज इवन मच अहेड ऑफ योर्स, माई कॉन्फिडेंस वाला, इसको जरूरत नहीं, इसको भी निकाल यार, इसी को डाल दें साली को।
नो नो नो।
सो तो क्या दिक्कत होगी, जाएगी नहीं दोबारा से तार।
वो मार्कर है ना सर, हमारे को कहाँ
जरूरत नहीं ना मार्कर की। विद माई लेवल ऑफ कॉन्फिडेंस सम 25 years ago आई वाज डैम कॉन्फिडेंट, कुछ नहीं मैं आराम से कर लूँ, मुझे कोई दिक्कत नहीं, मैं पट्टी आंख पे पट्टी बांध के भी कर लूंगा। सो मुझे कोई इशू नहीं था बिल्कुल भी। बट फॉर मोस्ट ऑफ यू आई विल से प्रोबेबली दैट इज नॉट करेक्ट। बेस्ट विल बी कि आप तीसरी बार लेके ऊपर से नीचे जाओ, इसको भी मत खींचो, कई बार निकल के दोबारा से नहीं जाती होती, इसको वहीं पड़ी रहने दो, तीसरी बार डालो, इसके बाद इसको निकाल लो, फिर अपना काम करो। बट आई थॉट एक बार सेव करते हैं और मैं आराम से कर लूँ, कोई इशू नहीं है। नाउ द प्रॉब्लम स्टार्ट्स। एनीबडी कैन टेल मी व्हाट कैन बी द प्रॉब्लम? नहीं, मैं तो इसको तार इधर डालनी है, ये निकाल के इसमें डालनी है।
प्रॉब्लम क्या हो रही है
पूछ रहा हूँ, आप बताओ। जैसे हम लोगों के केस देख के एंटिसिपेट करके बता रहे थे बेटा यहाँ फंसेगा, अब तुम बताओ कहाँ फंसेगा।
No, does your stent goes through the between the studs and wall? That's so it
Anybody, अब कोई किसी ने बताया नहीं अभी तक।
Vessel closer sir.
Vessel closer, yes, there is a reasonable possibility, क्योंकि टैग्ड अप है, वेसल क्लोज हो सकती है, दोबारा बाहर नहीं जाएगी। वेरी गुड। हाँ नहीं से इट अगेन, समझे नहीं क्या बात।
स्टड से जा सकता है rather than through lumen. No, you
नहीं
sir,
वो तो
sir go, you see proximal part of the stent before bifurcation is expanded enough, so you make a loop in the wire. ऊपर से जब वायर दूसरी वायर लेंगे, तीसरी,
वो ठीक है, these are standard ways, these are standard। anybody बताओ कोई। हाँ क्या हुआ? नहीं अभी वो बताने लगा हूँ कि अभी वॉट एवर यू जज प्रॉब्ली दैट, वो कुछ नहीं है, वो तो बता ही रहे ना, इसको यहीं रहने देंगे, इसको निकाल के डालें। विच वायर पुल वाली बात क्या है इसमें? वो तो उसी को निकालना है, क्या करना है? सी नाउ है, बोलो।
आइडियली
आपने इस स्टेंट को जब लगाया, अभी भी स्टेंट आपका एक्सपेंडेड नहीं है, तो आप जेल वायर करोगे नहीं करोगे, पहले बताओ। डिसेक्टेड ल्यूमन में छोड़ोगे नहीं छोड़ोगे वायर को? छोड़ोगे। और अगर छोड़ दोगे और आप स्टेंट हल्के प्रेशर भी, इससे ज्यादा क्या कर सकते हो तुम?
सर लेट मी टेल यू, आप 18 एटमॉस्फेयर फिर डायलेट कर दीजिएगा ना, द साइड ब्रांच जो वायर है उसको आप आसानी से निकाल सकते हैं।
कैसे?
नेवर, आई हैव नेवर प्रॉब्लम इन।
अच्छा खैर, नाउ लेट अस सी हुआ क्या कि
वायर बिकम इंट्रैप्ड।
So now this
stent happens, it comes out easily.
Anyhow, this stent was deployed at 5 atmosphere and you can clearly see this stent was not very well expanded, क्योंकि ये नॉच पड़ी और यहाँ पर कोई कैल्सिफाइड लीजन नहीं था, ये बिल्कुल सॉफ्ट टाइप सा लीजन था। दिस इज यंगिश पेशेंट, सिंगल वेसल डिजीज, फीमेल।
आराम से पोस्ट डायलेट कीजिए,
अब
कीजिए एंड रिक्रॉस कीजिए।
अब स्पॉट आसान था। जनरली क्या होता है, जब आप वायर कोई स्टेंट के बाहर पड़ी होती है, उसको निकालने के जो तरीके हैं, व्हाट ही इज सेइंग इज प्रॉब्ली नॉट, दिस इज अ वेरी वाइल्ड स्टेटमेंट। द फर्स्ट थिंग इज व्हेनेवर यू वांट टू पुल आउट अ वायर इज पुल आउट द गाइडिंग कैथेटर। एक सेकंड, धक्का नहीं मारेगा, पुल आउट द गाइडिंग कैथेटर, क्योंकि जब आप तार खींचोगे गाइड अंदर डाइव करेगा। सो फर्स्ट स्टेप इज पुल आउट द गाइडिंग कैथेटर। सेकंड स्टेप इज वायर को कभी ऐसे मत खींचो, अगर आप वायर को खींचोगे तो गाइड अंदर सक करेगा। So you try to spin the wire, take the static resistance off by producing a dynamicity. जैसे रोटा होता है तुम्हारा, रोटा जब ऐसे घूमता है तो आराम से चला जाता है, जब ऐसे नहीं घूम रहा होता तो वहीं खड़ा रहता है बिल्कुल। तो जब आप उसको वायर को स्पिन करोगे तो वायर के निकलने के चांसेस ज़्यादा होते हैं हमेशा, और वायर बड़ी आसानी से निकलेगी विदाउट डिस्टर्बिंग द स्टेंट। सो व्हाट वी डिड वाज, नहीं सेपल की जरूरत नहीं है, इफ यू वॉच तुम्हें पता है, नहीं वो रख सकते हो, वो रख सकते हो, लेकिन जब तुम्हें पता है तो तुम आराम से उसको बाहर खींचो। है? नहीं नहीं नहीं, एक जरा पहले इनकी सुन ले। हाँ व्हाट वायर, चलो खैर एनी वो कुछ नहीं हुआ इसके अंदर, जो तुम वो तो नॉर्मल चीजें हैं, वो कुछ नहीं हुआ इसके इसमें। सी व्हाट हैपेंड वाज के आई थॉट कि तीसरी बार डालने की कोई जरूरत नहीं है, इसी को निकालो, निकाल के इसको डाल देंगे, कोई इशू नहीं है बिल्कुल भी, क्योंकि हमने लो प्रेशर पे लगाया है। अब हमने जब इसको ये देखा कि वैसे भी बड़ी शॉर्ट है, नॉन फ्लो लिमिटिंग कैप डिसेक्शन है, और फिर भी जो इसका ल्यूमन बचा है वो रिलेटिवली ठीक ठाक है, तो मेरे ख्याल से कोई ऐसा मेरे लिए थ्रेट नहीं है। Means ideally is to take a third wire, but if you want to save a wire, then for me even 25 years ago it was nothing, आज भी कुछ नहीं है, मतलब अगर वायर सेव करनी हो तो मैं आराम से निकल जाऊँ, कोई इशू नहीं है मुझे बिल्कुल भी। So I, as a standard method, I pulled out the guiding catheter. Now I am trying to rotate, spin the wire from outside, as I am pulling this wire which is in the RV branch, which is trapped behind the stent. ये वाली बार जो है इसको खींचना, ये मोस्ट लाइकली आई डोंट एग्जैक्टली रिमेंबर, बट मोस्ट लाइकली उन दिनों में हम बॉस्टन की चॉइस फ्लॉपी बार इस्तेमाल करते थे। दिस मोस्ट लाइकली इज ए चॉइस फ्लॉपी बार। नाउ आई रियलाइज कि ये खींच लिया, मैं खींच भी रहा हूँ, पूरे ढंग से नहीं खींच रही है, तो जब नहीं खींच रही है तो इसका मतलब कहानी ठीक नहीं है। नहीं अभी कुछ नहीं हुआ, अभी कुछ नहीं, अभी तो सिर्फ थोड़ी सी स्ट्रेच हुई है, कुछ नहीं हुआ, अभी जरा सी स्ट्रेच हुई है, कुछ नहीं हुआ। अब जरा सी स्ट्रेच हुई है, कुछ नहीं हुआ, तो आपके पास नेक्स्ट स्टेप क्या होता है, आप क्या करते हो कि एक छोटा बलून लेके चले जाते हो उस वायर के ऊपर, यू ट्राई टू गो ऑन दिस वायर। नहीं डॉक्टर यादव, यू कैन स्पीक हियर, द मार्क दिस इज ऑन यू, यू कैन स्पीक हियर। सो स्टैंडर्ड तरीका होता है कि अगर आपकी गाइड बाहर कर लिया, रोटेट करके निकालने की कोशिश की, नहीं निकल रहा, so then what you do is you try to give a support to this wire, take a small balloon, इस small balloon को you can advance this balloon on this wire and you can keep making a space outside the stent and keep advancing this wire, निकल आते हैं। So we tried this, unfortunately छोटे से छोटा balloon गया नहीं, नया। फिर हमने माइक्रो कैथेटर ट्राई किया इसके अंदर, माइक्रो कैथेटर भी नहीं गया, उस समय हमने ट्रैप करके माइक्रो कैथेटर ले गए थे, बट देन माइक्रो कैथेटर आल्सो डिड नॉट गो। अब बताओ क्या करेंगे, मतलब यहाँ हमारा ना छोटे बलून से ना माइक्रो कैथेटर से, वी आर नॉट एबल टू टेक द वायर विच इज ट्रैप बिहाइंड द स्टेंट। नाउ व्हाट टू डू, केस इज ओपन फॉर डिस्कशन। मेरी ट्रिक मैंने चलाई थी, मैंने लगाई थी इसमें वेज़ोडाइलेटर वाली ट्रिक, मैंने दिस आई हैड शोन मेनी केसेस, I had used this, didn't work. Warm water, चाय बनानी अंदर।
So actually आप 5-6 एटमॉस्फेयर पे डिप्लॉय किए हैं, and still your wire is not
नहीं आ रही, this is what I, इसीलिए तो केस प्रेजेंट हो रहा है, ऐसे थोड़ी ना मैं प्रिपरेशन की थी बिहार इंटरनेशनल कॉन्स्टेंट, 25 साल पहले का केस है। So it is not coming out.
Over the wire balloon micro catheter doesn't
नहीं
go
गया,
over there.
कुछ नहीं गया इसके अंदर, बहुत कोशिश की हमने, नहीं गया। हाँ गाइड एक्सटेंशन उस समय थे नहीं,
उस जमाने में नहीं।
लेकिन अगर गाइड एक्सटेंशन होते भी तो क्या करते, एंड तक ये लो चला गया, ये गाइड चला गया एंड तक, बताओ वो देखो सामने, वो देखो सामने यार, गाइड का ग्रैंडफादर, गाइड एक्सटेंशन का ग्रैंडफादर चला गया वहां तक, तो क्या करेगा?
Most likely there is a calcium at bifurcation, sir.
Yeah, there is a nodule which is in trap.
नहीं रोटेट क्या करोगे, ये तो वायर इज बिहाइंड दिस स्टैंड ना, कुछ नहीं कर सकती, रोटेट करके क्या करोगे, कुछ नहीं होगा।
So calcium at bifurcation, I think.
कुछ हो सकता है, but we did not exactly see any calcium, at least angiographically.
Under expanded stent, so we post dilate.
No, under expanded is because हमने deliberately 5 एटमॉस्फेयर पे लगाया,
And still not coming.
हाँ नॉट कमिंग, नहीं थर्ड वायर क्या करेगी इसमें? नो, योर वायर इज बिहाइंड द स्टैंड ना, थर्ड वायर क्या, थर्ड फोर्थ फिफ्थ जितने मर्जी डालो कहाँ जाएंगे, बिहाइंड द स्टैंड दे कैनॉट गो, इनसाइड द स्टैंड दे विल गो. नहीं, सेकंड थर्ड फोर्थ क्या, तुम 15 वायर डाल दो, वो कहाँ जाएंगे वो, दे कांट गो बिहाइंड द स्टैंड, दे विल वॉक इनसाइड द स्टैंड, फिर क्या करेंगे वो. नो,
you pulled out.
किसको, वायर जब बिना स्टैंड अभी फुलाया नहीं तब नहीं वायर निकल रही, तो क्रश करने के बाद तो बिल्कुल निकलेगी.
नहीं सर, वायर यदि नहीं निकल रहा है तो इट्स बिकम लॉन्गर.
हाँ, अब और खींचोगे तो लॉन्ग होगी वो.
तो लॉन्गर बनाइए और टूटने दीजिए.
अब अगर नो, दिस इज व्हाट डॉक्टर यादव इज सेइंग इज प्रोबेबली द ओनली आंसर, कि आप इसको लंबा बनाइए और टूटने दीजिए. लेकिन अगर इसको लंबा,
इसके बाद मैं बताता हूँ, इसके बाद रीक्रॉस कीजिए थर्ड वायर.
नहीं, नो सी, नो. अब अगर आप इसको खींची जाओगे तो द्रौपदी चीरहरण की तरह है, आपको क्या पता है कहाँ टूटेगी,
कहीं जो पतला हो जाएगा टूट जाएगा,
कहाँ टूटेगी आपको नहीं पता.
हाँ, वो पता नहीं.
हाँ, अगर आपकी टूट के गाइड में रह जाती है, आप उसको गाइड निकालते हो, वो उसका छल्ला बन के वो लेफ्ट कॉर्नर में चले जाएगा, थ्रोम्बस बन जाएगा, पेशेंट विल डाई. One case was reported in 1996 by Chris White in Cath CV, where similar thing had happened in the right coronary artery, and they tried to do it like this. Stent का छल्ला बन गया. The patient died after 7 days, and postmortem के अंदर right वाली artery का जो निकला हुआ unraveled wire थी, it flew into the left, and the patient formed thrombus after 7 days and died.
You don't leave that fragment. You what is seen is the distal part, and that you snare out. You go with, sir, जहाँ रह गया रहने दीजिए. Take third wire, cross it, dilate that area, and snare this wire from that.
So, Pratap, looking very funny to you. So now what are the options? You are trapped behind the stent. नहीं, बलून तो ये वायर स्टेंट के बाहर है, बलून स्टेंट के बाहर नहीं जा पा रहा. ये तो वही नहीं जा पा रहा था, यही तो पूछ रहा हूं मैं. बताओ आप. मैं अभी सब चीजें एक्सप्लेन करूंगा बाद में, अभी तो मैं पूछ रहा हूं. Anyhow, so now let me go ahead. So now what is happening is, so now what, एक तो चीज पक्की है कि जब आपकी तार स्ट्रेच होनी शुरू होगी और वो बिल्कुल स्टेंट के बिहाइंड आपका, इफ यू लुक एट इट, दिस इज यहाँ से यहाँ तक जा रही है, तो आपको कहीं ना कहीं उसको तोड़ना पड़ेगा तार को. और अगर उस तार को आप ये आरसीए के ओरिजिन से लेके यहाँ तक कहीं भी तोड़ दो, कोई इशू नहीं है, बिल्कुल कोई इशू नहीं है. अब इसको यहाँ से यहाँ तोड़ने के क्या क्या तरीके हैं? एक तो वैसे सिंपलेस्ट तरीका है कि आप इसके ऊपर एक स्नेयर ले जाओ, और स्नेयर ले जाके यहाँ ले जाके स्नेयर से पकड़ के इसको खींचो, यहाँ ले गए, फिर वापस जाओ, फिर ऊपर जाओ, फिर वापस जाओ, फिर ऊपर जाओ. सो यू कीप स्ट्रेचिंग देयर. दिस इज वन वे. बट व्हाट आई डिड इन दिस केस वाज, नाउ two wires are going through the guiding catheter. One wire has gone outside the stent, the other wire has gone inside the stent. Okay. So as you try to pull the wire, your guide jumps into the coronary artery and almost touches the stent. तो जब मेरा ये यहाँ गाइड जाके टच करता है, तो मैं जो एक हीसी का जो बलून था, उस बलून को मैं इसके अंदर फुला देता हूँ. My balloon inflates, and this balloon has a wire which is going inside the lumen of the balloon and is going here. ये जो दूसरी वाली वायर है, ये बलून के बाहर है. तो when I inflate this balloon, this traps the wire, it acts like a snare. जैसे snare उसको वहाँ से पकड़ रहा है, ऐसे snare को यहाँ से पकड़ लिया, and then you try to pull it, यहाँ तक चले गए, थोड़ी stretch होगी, फिर दोबारा चले गए, ऐसे चले गए, फिर दोबारा चले गए. So I try to do it as many number of times as possible till the time मुझे ये था कि मेरा गाइड खींच रहा है और वो मेरी तार टूटी नहीं है. You see it here. ये तार जो यहाँ से खींच के कुछ आ गई यहाँ तक with this process, यानी कि वो जो अनरेवल के बाद भी उसमें जान खत्म नहीं हुई, थोड़ी थोड़ी खींच रही है, वो पूरी खत्म नहीं हुई उसमें जान. Now you see, this is what is a Draupadi Chirharan. Look at this is what has come on the table. और ये जो ऐसे ये कांप रहा है ना, ये हमने कुछ नहीं किया, सर एसी चल रहा था, एसी की हवा के अंदर ये तारें हिल रही हैं अपने आप ही. कैन यू मेक आउट? और कैन यू सी कितना बड़ा मेज, कितना बड़ा जंगल है ये? इफ यू सी इट, इट वाज लाइक दिस. दिस इज दैट इंसर्शन ट्यूब टूल जिसमें से आपकी पीटी से बाहर जाती जो ये है, ये इंसर्शन टूल है, ये पीटी से बाहर है, और ये आपकी अनरेबल्ड वायर है. नाउ यू कैन अंडरस्टैंड कि अनरेबलिंग होके कितनी थिन हो जाती है तार. वो 1 मीटर के 25-30 मीटर बन जाते हैं. You can see it here. This is a routine PTC bar, and this is a unraveled bar. That is for comparison, and you see it here. Mace. This is just that small part of the wire जो catheter tip और stent के बीच में जो distance था, उसी को खींच के हम लंबा किए जा रहे थे, and finally it broke. इस केस का हमने IVS भी किया था. अनफॉर्चुनेटली IVS इमेजेस आर करप्टेड, बट व्हाट वाज सीन हियर वाज कि जब IVS हमारा इस वायर के ऊपर लेके गए हैं तो यहाँ पर हमें वी कुड सी दैट देयर इज ए स्टेंट के बाहर एक फुल फ्लेजेड रेडियोपेक वायर पड़ी हुई थी एट द डिस्टल मोड एंड ऑफ दिस स्टेंट. फुल फ्लेज वायर थी. कोई नोड्यूल नहीं दिखा हमें, नथिंग. देन दिस बिकेम ए लिटिल थिन हेयर. इतने हिस्से में हमें कुछ नहीं दिखा, और यहां भी हमें कुछ नहीं दिखा प्रॉक्सिमल टू द स्टेंट. सो दैट मीन्स वो वायर यहां टूटी है. मतलब स्ट्रेच होती गई एंड अल्टीमेटली जो फिलामेंट अब वो था वो यहां था. इंटैक्ट वायर इनटू द आरवी ब्रांच थी. ये वाला स्टेंटेड हिस्से के अंदर कोई तार नहीं थी. स्टेंट से पहले भी कोई तार नहीं थी. So what are the options?
Yeah, so I will go with the snare, a side branch with the another wire.
Okay, कराने हैं पहले मैं अपनी बताता हूँ फिर देखते हैं. So one option is stent from, क्योंकि proximal RCA में और even proximal stent के अंदर कुछ नहीं है, तो कोई लंबी कहानी करने की जरूरत नहीं है. आप सिर्फ osteo proximal RCA से लेके into RV branch stent डाल दो, जो आपकी वायर बाहर चली जाएगी. उसके बाद तुम फाइनली किसिंग करके बाहर आ जाना. This is one which is, क्योंकि relatively straightforward तरीका. The other is you try to retrieve. Now I am saying try to retrieve क्योंकि it is possible you try to retrieve, you add to the problem rather than solving the problem. एक वो तार जो जिसका बिल्कुल थोड़ा सा फिलामेंट डिस्टल एंड ऑफ स्टेंट के बाहर पड़ा हुआ है, बाकी वायर एक आरवी ब्रांच में पड़ी हुई है, उसको फ्रैक्चर्ड वायर को आप निकालने की कोशिश करो. Tedious. Now let me just ask you, should I follow this or this?
I will solve second, because
So opinion is divided.
Because even the radioepic part of the stent wire which you will entrap with the stent will cause thrombosis later on.
No, if you just put a stent like this, I don't think it should do anything, because you can always trap a wire behind the stent and leave it. And proximal vessel में कोई वायर नहीं है, मतलब proximal stent में वायर नहीं है, पर RCA के अंदर तो है ही नहीं बिल्कुल भी. And that was checked. So I think this is a very fair option to do this. But somehow I was trying to put it, and one of my assistant who was also a professor at that time, and he said के वो हमें प्रोफेसर समझा करता था, बड़ा था, कि बॉस निकालो तुम नहीं निकालोगे तो और कौन निकालेगा. तो कई बार यू शुड नॉट लिसन टू योर असिस्टेंट. तुम सुनते हो तो काम खराब होता है, वो आपको हवा देता है तो आप शुरू हो जाते हो उसके अंदर. सो वी चोज दिस ऑप्शन. हाउ टू डू दिस? I wired into this RV branch. Wire करने के बाद I took a microcatheter into the RV branch, and then through the microcatheter I was able to take a snare, micro snare into the RV branch. You see that's a micro snare. Then as you pull the micro snare, this can possibly go over this wire, which has gone over this wire possibly or not, I don't know. पकड़ोगे तो पता लगेगा. इसने शायद पकड़ लिया. एंड देन यू ट्राई टू पुल इट. अब जब खींचने तो कुछ हिस्सा जो स्टेंट के बाहर है उसने रोका इसको, एंड द गाइड हैड टू बी काइंड ऑफ टेकन डीप इन. नो प्रॉब्लम. सो इट वाज टेकन आउट. वी रीवायर्ड द साइड ब्रांच एंड डिड ए किसिंग, एंड फाइनली दैट वाज द रिजल्ट. सो व्हाट आर द टेक होम? Take home is, we know jailing in the calcified and tortuous vessels is a problem. We also know that if you jail between the two layers of the stent, it can be a problem. We know that if you take an ox wire into an angulated branch, it is a recipe for getting into trouble. If you do a high pressure deployment, again you can be possibly into trouble. But these things are already known. What is take home from this case?
Sir, just the entrapped wire, I don't use.
इस केस की टेक ऑफ बताओ यार, टेक होम क्या है?
No, you
इस
have-
केस का टेक होम ये है कि sometimes just a long length, जो आप भूल जाते हो कई बारी,
Jailed segment.
long length of a jailed segment, and especially after the long length, if the wire has an angle, तो कई बारी वो प्रॉब्लम क्रिएट करती है. एंगल का क्या मतलब है? तुम ये देखो, ये आर्टरी थी, ये ऐसे एंगल था, इसमें हमें दिक्कत हो रही थी, और स्टेंट डालने के बाद ये जो टेढ़ी थी ये तो सीधी होगी, और सीधी वाली टेढ़ी होगी, ये सीधी होगी, ये टेढ़ी होगी. These are anatomical alteration which occur in an artery when you stent them. Many time सीधी आर्टरी टेढ़ी होती है और टेढ़ी वाली आर्टरी सीधी हो जाती है. Which actually, if you see that, तुम्हारे सामने इसके अंदर कुछ बेंड आ गया, इसका बेंड, ये वाला बेंड बिल्कुल खत्म हो गया after the stenting. So if you have to pull out a wire where there is a very long segment of the wire which is trapped, it is possible कि 25 मिलीमीटर का स्टैंड चला जाएगा लेकिन 30 का नहीं जाएगा. It is possible कि 20 मिलीमीटर ट्रैप वायर निकलेगी लेकिन 30 मिलीमीटर नहीं निकलेगी. So you should be careful about trapping a very long segment of wire, which happened in this case. और उसके बाद कुछ निकली भी, सारी नहीं निकली. Now to avoid a guiding catheter sucked in, we know it that we have to pull it out, which was done in this case. Also, if you try to give torque to the wire which decreases the friction in the long axis, which was done in this case. Advance the smallest possible new balloon over the unwrapped wire or a microcatheter over it, which was done in this case. You can advance a micro snare over this unraveled wire and catch it as close to the inlet, which was done in this case. We did not catch the wire with the help of a micro snare close to the stent, but we caught it with the help of a balloon close to the inlet of the stent, and we did it ample number of times. Snare हो सकता है उसके ऊपर ना चढ़ता. अनरेवल्ड वायर के ऊपर जब स्नेयर लेके जाओगे तो उस पर सेरेशन है, बलून तो फिर भी चढ़ जाएगा. This wire could be pulled to some extent by this snaring. And if you look at it, ये बलून पड़ा हुआ है, ये बलून इन्फ्लेट हो गया. And then इस इन्फ्लेटेड बलून से क्या हुआ है, एक आपकी यहाँ जो वायर पड़ी थी, एक ये प्रॉक्सिमल एंड है, ये इसका डिस्टल एंड है. जैसे आप गाइडिंग को ऊपर खींचते हो तो ये प्रॉक्सिमल एंड, ये वाला एंड यहाँ पहुँच गया, डिस्टल एंड वहीं का वहीं फिक्स पड़ा हुआ है. तो ये जो तुम्हारी तार थी, ये ट्रैप वायर, ये लंबी हो गई तो पतली हो गई. एंड वंस वी वर रिपीटिंग दिस थिंग, एक के बाद एक हम जब करते गए तो फाइनली इट केम टू अ ब्रेक पॉइंट, यहाँ टूट गई. एंड एट द एंड दिस थिंग गॉट पुल्ड आउट. ये हमने खींच लिया इसको बाहर, और जो बच गया वो ये हिस्सा रह गया. इतना हिस्सा बिहाइंड द स्टैंड था और ये वाला हिस्सा इनटू द आरवी ब्रांच था. यू कैन सी इट हेयर. इफ यू सी क्लियरली, ये वाली तार जो है इसकी रेडियोपेसिटी कंपेयर टू द तार विच इज ऑन दिस साइड इज ऑलरेडी लेस. सो दैट मीन्स ये यहाँ भी खींचना थोड़ा शुरू हो गई थी.
Sir, can I also comment?
Also, the inference from here is a microcatheter can pull out material from distal coronary arteries even if you walk through the stent into a side branch. Yes, Dr. RD.
Sir, instead of you pulled the wire through the stent.
Which wire?
With the micro snare. Instead of pulling, you go to the till it is seen, vessel part till radio opaque part is seen. You go there and catch. ऊपर से कैच करके आए हम, यहाँ आके बेसल पार्ट पे कैच किए, and then don't pull. You just push the micro catheter.
You see these.
Just a minute, sir. Let me understand. And then push, and then it will disengage, and then take out.
You see, these are only mechanical thing. तुम ऐसे करना टेबल के ऊपर कभी माइक्रो कैथेटर से, सुनो, जब माइक्रो कैथेटर से तुम पकड़ोगे ना किसी चीज को, पकड़ के बाद पुश करके देखना. माइक्रो कैथेटर्स, these are like this. You cannot push it. You cannot push a wire. You see, if there is a lathi and you catch with a lathi, you can push it. But if it is a micro snare, you try to do it on table. Next time we'll try to see it.
Sir, you are.
I'll give this case and you put a bench test on it.
सर एक चीज नहीं समझ में आई.
हाँ जी.
लास्ट में जो स्नेयर किया आपने,
हाँ.
तो जो पार्ट ब्रोकन था वो स्टिल बिहाइंड द स्टेंट. And
वो
you went through
no.
the stent.
You caught it from the intact part of the wire. And as you pulled it, जो behind the stent था broken वाला part, उसको जब वो नहीं आ रहा था तो इसीलिए तो गाइड बहुत अंदर गया. फिर जब ब्रूट फोर्स लगा तो वो निकल आया।
तो उसने
स्टंट्स को भी खराब
हुआ
किया
ना, डिफॉर्म हुआ, स्टैंड डिफॉर्म हुआ, लेकिन
वो
बलून से
correct
रीसेट
कर
हो
दिया।
गया।
सर मेन फॉर्मूला है, if you want to avoid, you have to gel in bifurcation. I never gel these floppy coil wing wired.
See,
I always gel with
मैंने
the
शुरू में सबसे
whisper
पूछा,
wire,
सबसे
whisper
पूछा
wire.
कि जेल करें ना करें, सबने बोला कि रखो तार को एक।
नहीं रखो,
So now,
plastic
if
coated
you
wire
ask me
रखो।
now, the same case, if मतलब अगर मुझे कोई पूछे ये केस आपको दोबारा से करना तो आप कैसे करोगे? The only thing which I'll do is, because I know कि डिस्पाइट वो जो मैंने 6-7 फैक्टर दिखाए थे, उसके सिवा एक और भी फैक्टर है। वो फैक्टर है कि अगर आपकी लंबी जेलिंग होती है तो प्रॉब्लम होने के चांसेस होते हैं। एंड जेल ऑफ कोर्स अगर आपको करनी हो, हमेशा नई तार करनी चाहिए, कोशिश करनी चाहिए कि आप हाइड्रोफिलिक कोटेड वायर को जेल करो। और इस तरह के केस के अंदर जिसमें जगह थी, विद माई लेवल ऑफ कॉन्फिडेंस आई कुड हैव जस्ट डिप्लॉयड ए स्टैंड इनटू द आरवी ब्रांच विदाउट जेलिंग दिस, और लो प्रेशर पे रख के मैं तो दोबारा वायर कर ही लेता हूँ। मेरे रखने का तो मुझे कोई खास फायदा हुआ ही नहीं। मतलब नेक्स्ट टाइम में अगर मुझे केस करना पड़े तो मेरा एक ही स्टेप होगा कि वायर को जेल करने की जरूरत नहीं, यहाँ पर मैं बड़े आराम से इसके अंदर तार डाल लूंगा लो प्रेशर पे लगा के। आई थिंक रेस्ट ऑफ द थिंग्स यू कैन डिस्कस अमंग योरसेल्फ। थैंक यू वेरी मच।
But I use plastic coated wire, that is whisper wire for entrapment. I never use coil wire. You will have no
अरे
problem.
लास्ट स्लाइड तो दिखा दो यार एक बार, क्या थी, बंद कर दी तुमने? नहीं वो और नहीं है, इसी का एक फाइनल है। मैंने इसमें बनाया था कि will you ever like to intentionally break intracoronary gears? Answer is sometimes you may have to. This is a classical case. चलो जी।
So let's stop with this most recent nightmare which I faced 5 days back. Patient was discharged 2 days back, day before yesterday. So we got a patient, 71 years old, hypertensive female, and STEMI, recent LV dysfunction was there. She was having moderate MR. LV ejection fraction was 35%. Patient was having recurrent chest pain on and off on a daily basis. She was planned for PTCA. This was the angiogram. There was a critical calcified lesion, circumflex OM branch. It was a big vessel. LED was non-critical. RCA was 100% occluded. Looks like a CTO. So the plan was that we will open the RCA first because it was more critical and it was looking like a subtotal occlusion. So we proceeded with a filter XT. It was quite easy. With the help of microcatheter, we easily crossed and then we did angioplasty. We simply did a drug-coated angioplasty, DCB angioplasty to this RCA. There was a small micro perf in a small PLV branch, which we waited on the table. No pericardial effusion was there. No hemodynamic issue was there. So this was all done. Now then we started PTC of circumflex. We use a 6 French EBU, radial access was there. We ballooned it with a 2.25 mm balloon at high pressure. The lesion didn't yield it well. So now our plan was to use a cutting balloon. Cutting balloon, it was not able to cross that lesion. We used a Aperta 2.513. Now we used a guide extension catheter. We crossed the Aperta balloon, and this was the thing. We inflated to check the position because we first crossed the balloon and then I quickly pulled out the guide extension because guide extension was hanging till the lesion, and asked my assistant to inflate. Just I pull out the guide extension, I will check the shoot, and this was the thing. The air, with a quick pulling of the guide extension, the air got trapped and the flow of LED and circumflex was occluded immediately. But this flow which we are seeing, it was after 1 minute of CPR, because once I saw the air, the whole process of air embolism management started. I started giving intracoronary saline, intracoronary adrenaline, high flow oxygen was started. CPR was started because all of a sudden patient had hypertension and bradycardia on the table. Our cardiac anesthesia team was so well supportive in that case. And we managed with intracoronary adrenaline, intracoronary saline and high flow oxygen. In between, what I did when this procedure was...
You see, your LAD gone 0. Circumflex also gone 0. So air gone into both the arteries.
Yes.
Okay. And patient arrested.
Yes.
Immediately you cross with the PTCA wire to the LAD, go with the thrombosuction catheter and suck the air. And similarly, all the already circumflex is wired. Already go with the thrombosuction with on this.
Actually, sir, the time which is required for all these things, that might not be well sufficient. So what I did it much more quickly before that getting it wire, because it was a 6 French, the aortic route was not that much compatible to go through the radial and do everything, because we were facing difficulty in crossing the cutting balloon.
Will go anywhere, I don't think.
And second, during CPR, that loop, it went into the aortic route. So the whole process of adrenaline, saline and high flow oxygen, it was done, pressure started recovering, and in between we took a femoral access, 7 French EBU. The whole process of CPR continued, and when I hooked through the femoral access, I got this flow. The flow was achieved, because I was sure, because the pressure started recovering. So I was sure that my intracoronary adrenaline, saline and high flow oxygen, it has done the job. After that, we proceeded. We had already prepared with a cutting balloon. I placed a stent or siro in that circumflex to OM. We inflated that. Proximal lesion was looking bad as compared to previous one. Now, the problem was not only there. Can I play get the second video played? So we stented that there was a good flow from circumflex to that OM branch, but the flow of OM, it got compromised. The OM lesion, it was critically diseased. We quickly wired that OM. It was difficult to pass on a balloon, so we used a 2N balloon and we opened the strut. Again, we prepared the proximal lesion, because we were knowing that proximal, it was not as that much critical lesion, but that calcification, it was troubling us. So that strut was opened and a passage was created. Then I planned to do a kissing balloon inflation after opening the struts at that OM ostia, but 2 balloons I was unable to cross through that proximal segment, even with a 7 French guide. So what I did, I gradually opened the strut with a 2, then 2.25, then a 2.5 at high pressure. Then I did a side pot on that previously stented segment, because I was unable to do a kissing balloon in that. After side pot, proximal stent was placed. 7 French guide we are having, sir. With femoral, I took a 7 French up front. Then I placed a second stent proximal, and this was the final result which I achieved. The flow was good all over. So basically, the take-home message is air embolism is not a very much strange thing if you are doing a lot of procedures, but we have to be proactive. In this case, our anesthesia team and cardiac cath lab support team, it was also proactive. I just knew that this is there, we have to. So all of them started their work immediately. Identification was delay was not at all. So that's why we got the patient recovered and revived within 2 minutes, 2 to 3 minutes.
Can I? You are working with 2 people, you and your assistant?
I was the only operator over there. My nursing staff was there.
So nursing staff was injecting, or you were injecting?
Nursing staff was injecting.
Okay, this is the problem. You see, you train them that you suck the contrast and inject only. Don't suck First time you suck, when you connected everything, you suck. Otherwise, don't suck through the, because once tree open and you suck, seems not knowing suck, and air comes out into your tubing, and then once you test, it goes to the, that is the region. So train them to take the contrast, inject only, assistant, if you are assistant. If you are yourself, then you know what you are doing. Always bleed before injecting. That's the another thing.
So what I learned from this case, using a guide extension with a 6 French, and if we quickly pull out the guide extension, that air sucking system is there.
देखो ये तुमने जो लिखा है ना, ये टेक होम है ही नहीं है बिल्कुल भी, ये टेक होम नहीं है। टेक होम तो एयर एम्बुलिज्म का एक ही टेक होम है, उसको बचाना कैसे है, ये कोई टेक होम नहीं है अकॉर्डिंग टू मी। तो बच गया तुम्हारा मरीज, बच गया, तुम लकी हो, नहीं बचता तो नहीं जाता तुम्हारे को। टेक होम इज नॉट दिस, टेक होम इज व्हाई डज द एयर गो इन। एयर तब जाती है जबकि कंपार्टमेंट छोटा हो और तुम्हारा जब गियर्स अंदर बाहर हो रहे हैं, दे वर्क लाइक ए पिस्टन। एक 10 cc की सिरिंज है, उसका अपना एक पिस्टन है, उसको जब सिरिंज का पिस्टन को खींचोगे तो वो अंदर कुछ भी होगा, पानी में पानी खींचेगा, हवा में हवा खींचेगा, पुश करोगे तो वो उसको जो भी चीज़ उस अंदर पड़ी है उसको बाहर फेंकेगा। एक 10 cc की सिरिंज में तुम इंसुलिन सिरिंज का पिस्टन लेके करते रहो जो मर्जी, कुछ नहीं होगा कभी कुछ। सो व्हेनेवर यू हैव ए गाइडिंग कैथेटर एंड इफ द गाइडिंग कैथेटर इज स्मॉल, जैसे कि 5 फ्रेंच है, 5 फ्रेंच गाइडिंग कैथेटर को विड्रॉ करने का सबसे बड़ा एक रीज़न यही था कि 5 फ्रेंच गाइडिंग कैथेटर के अंदर कोई भी चीज़ पिस्टन की तरह चलती थी, तो बहुत ज़्यादा एयर सक किया करता था। इफ़ इट इज़ ए 6 फ्रेंच, इन दी 6 फ्रेंच अगर तुम गाइड एक्सटेंशन लेके जा रहे हो, वो पिस्टन की तरह काम करेगा। खासकर अगर उस गाइड एक्सटेंशन के साथ तुमने कोई चीज़ डाल दी तो पूरा पिस्टन बन जाता है वो। दैट्स ए टाइम व्हेन यू कैन सक इन एयर। उसको बचाने का रवि एक ही तरीका है, बड़ा सिंपल तरीका है। तुम बताओ, तुम्हारे साथ काम किए हो, क्या तरीका है? साइड से नहीं, कुछ नहीं, साइड से एक फ्लश जो आपको आता है ना, उसको प्रेशराइज कर दो आप। जो आपको जहाँ से भी आप फ्लश लेते हो ना, उसके ऊपर आप एक प्रेशर बॉटल, प्रेशर वो लगा दो आप, जो तुम्हारा जो तुम्हारी प्रेशर बैग होता है वो लगा दो उसके ऊपर। जो तुमने प्रेशराइज बैग से तुमने फ्लश दिया ना, नाउ दिस फ्लश इज कमिंग टू योर टू वे बर्स्ट चैम्बर। एयर कहाँ से जाती है? टू वे के बेल से जाती है ना, और साइड पोर्ट से अगर उसमें अच्छी तरह से आपका फ्लश का प्रेशर आ रहा है, घुस ही नहीं सकती, सिर्फ फ्लश बाहर आएगा। यही इसका टेक होम सिर्फ यही है, ये टेक होम नहीं है। और वो 100% ऑक्सीजन का क्या रोल है? यू सेड यू गेव इनफ ऑफ ऑक्सीजन, उसका क्या रोल है
सर?
तो किताब तो लोग ऐसी पढ़ पढ़ के इधर से टीप के आगे डाल देते हैं, क्या रोल है? यू गिव 100% ऑक्सीजन, फिर क्या होगा? 100% ऑक्सीजन तुम्हारे लंग्स में गई, फिर क्या होगा? हाउ कैन इट टेक द एयर विच इज नाइट्रोजन विच इज ट्रैप्ड इन योर कॉर्नरी आर्टरीज? कर ही नहीं सकती। इट्स ए यूजलेस थिंग, एब्सोल्युटली यूजलेस थिंग। If you have to see, I was in TCT के अंदर वहाँ वर्ल्ड के बड़े दिग्गज थे, वहाँ इसी की बात चल रही थी। I blasted them off everybody. When I asked them, किसी बार कोई जवाब नहीं था। सेकंड चीज़ जो लिखी जाती है, हाइपरबैरिक ऑक्सीजन। अबे हाइपरबैरिक ऑक्सीजन क्या होती है, कब दी जाती है? These two things which are written for air embolism, they are written particularly in context of Caisson's disease. Caisson disease के अंदर आपकी नाइट्रोजन इज इन होल ऑफ द बॉडी। वो आर्टरी में भी है, वेन में भी है। जब वो वेन के अंदर लंग्स के अंदर आती है, वेन्स के थ्रू छोटे छोटे बबल्स, तब आप 100% ऑक्सीजन दे देते हो, तो वहाँ वो नाइट्रोजन बाहर निकलेगी क्योंकि आपने वहाँ पर हाइपरबैरिक काम कर दिया। बट नहीं लेकिन आपकी जाएगी कैसे? कुछ नहीं। हाँ, तो सी फॉर प्रैक्टिकल पर्पसेस हाइपरबैरिक, उसके लिए चैम्बर लानी पड़ती है। नॉर्मल तेल लाओगे फिर राधा नाचेगी, तो होता ही नहीं है बिल्कुल भी। वो हाइपरबैरिक ऑक्सीजन इज आउट, 100% ऑक्सीजन इज ऑल्सो आउट। व्हाट डॉक्टर आरडी सेड इज एब्सोल्युटली करेक्ट। जब कभी तुम्हें ये हो रहा हो, तुम बोल रहे हो कि मेरे पास सामान नहीं था, कुछ तो कर रहे हो यार तुम। थ्रोम्बोसक्शन कैथेटर को ले जाने में इतना टाइम नहीं लगता कभी भी। थ्रोम्बोसक्शन कैथेटर अगर नहीं आपके पास, नहीं ले जाना चाहते हो, टेक ए माइक्रो कैथेटर। कोई भी माइक्रो कैथेटर को ले जाके, जैसे तुम्हारा था साथ में, तुम्हारा बड़ा माइक्रो कैथेटर, इसमें तुम्हें निकालना एलईडी में से है, और तुम्हारा माइक्रो कैथेटर एलईडी में वॉक कर जाएगा। और माइक्रो कैथेटर में जब तुम खींचते हो ब्लड खींचना थोड़ा मुश्किल होता है. When they are doing CTOs before injection, every time they suck and show that you are free in the lumen. Sometimes you connect to the mind manometer and see that micro catheter showing you pressure waveforms. अगर वो नहीं हो रहा कभी पुश नहीं करो, कभी नहीं करो. तो लेकिन इनकी सबकी विस्कोसिटी बड़ी है, एयर की विस्कोसिटी तो कुछ भी नहीं है. So if you slip in a micro catheter into the LED, it will suck blood from the suck air from the main stem LED. It will go as deep. In fact, अगर तुम्हारे पास दिस थ्रोम्बोसक्शन कैथेटर नहीं है तो कई बार थ्रोम्बोसक्शन कैथेटर सिर्फ प्रॉक्सिमली एस्पिरेट कर पाता है, डिस्टली एस्पिरेट नहीं कर पाता. Whereas a micro catheter can walk very deep and can aspirate bubbles from distal coronary tree and even side branches. So I think suction of whatever you have injected should be top priority. Second is somebody should keep having the circulation on, that is by massage. Third is you should give epinephrine so that those areas जिनको थोड़ी फ्लो मिला हुआ है वो हाइपर एक्टिव करें कुछ टाइम के लिए. अगर ये सारी कहानी चलती है तो 3-4 मिनट में आपकी स्टोरी डिसॉल्व हो जाती है.
थ्रोम्बस्टर विद स्टिलेट.
थ्रोम्बस्टर स्टिलेट से लेके जाओ डीप. डीप लेके स्टिलेट निकालो उसके बाद सक करो.
स्लिटेड
दैट इज व्हाट इट इज.
स्लिट वो हो स्टिलेट वही वाला थ्रोम्बस्टर यूज करना चाहिए.
अगर थ्रोम्बस्टर ले जाने में दिक्कत है तो माइक्रो कैथेटर कैन आल्सो वर्क बिकॉज़ एयर को माइक्रो कैथेटर से निकालना इतना मुश्किल नहीं है.
Actually, sir, our next plan was like that. If we were unable to succeed after,
but your story ended in 3 minutes.
We did it within 3 minutes. Thank you, everyone. So tomorrow morning we will start at sharp 9. We will start with intervention cardiology quiz followed by STEMI and cardiogenic shock session. Thank you everyone. Have a good sleep, and tomorrow morning we are having breakfast in the Darbar Hall starting at 8. Those who are staying here, they can have their breakfast in the restaurant itself.